Good morning, everyone. Good morning. I just wanted to note a little change in the schedule. At 9:30, we're not going to have a presentation so that everyone can go to the keynote speaker. So everything will be pushed down a bit. The keynote speaker will be in ballroom 1 and 2, and that will be Dr. Oz. So just wanted to start the day like that. So welcome, everyone. It is a privilege to welcome you to the third annual Excellence in CABG program, Advanced Strategies for RNs, NPs, PAs, and Leaders. This year's program places a special emphasis on coronary artery bypass grafting, not just as a surgery, but as a world-class comprehensive program. It highlights the essential contributions of nurses, nurse practitioners, physician assistants, intensivists, anesthesias, and leaders whose expertise drives excellence. As we come together, we recognize that CABG continues to evolve in a remarkable pace. Patient outcomes depend not only on the innovation in the operating room, but also on the skill, vigilance, leadership, and compassion of the teams who support patients before and after surgery. The cardiac surgery nurses, nurse practitioners, physician assistants, and nurse leaders form the backbone of this continuum. You are the constant presence at the bedside, the champions of quality, workflow efficiencies, the educators for families and patients, and the link between disciplines that make world-class cardiac care possible. This program reflects a shared commitment to collaborate across professions and across borders, to challenge old boundaries, not to shape the future of coronary surgery together. Over the next few hours, we will exchange new research, explore best practice, and learn from leaders whose work is transforming outcomes. Thank you for bringing your expertise, your passion, and your leadership to this year's program. I hope that you find it learning, inspiring, and you can bring things back to your practice. So we're going to begin with our first presentation, which will be patient experience of recovering from cardiac surgery in the acute care setting, a qualitative study from Dr. Keiko Iwama, and Nikki Lee. Thank you, guys.
Thank you for the introduction, Dr. Freeman. Good morning, everybody. My name is Keiko Iwama. I am a staff nurse working at the cardiac surgery ICU at Mount Sinai Morningside Hospital. And this is Nikki Lee. She is our co-investigator, also my colleague. She is a staff nurse working at cardiac surgery ICU at Mount Sinai Morningside Hospital. And in this session, I will present patients' experience of recovering from cardiac surgery in the acute care setting. This is a qualitative study. And this study was inspired by the nurses at my unit. The nurses are trying to create a better patient education. We realized that not many patients know the process of their recovering, such as after surgery, they are sitting in a chair, walking on the hallway, do the incentive spirometers, or pain management. So in order to create better patient-centered education, we needed to include patients' perspectives and experiences. So therefore, we conducted this project. We have non-conflict of interest to declare of this study. Background out of this studies, cardiac open heart surgery is a major surgical procedure which involves general anesthesias, mechanical intubation, cardiopulmonary bypass, and physical trauma. This process affects patients' recovery and may lead to serious post-operative complications involving various systems such as neurological, cardiovascular, respiratory, GI, renal, that may impact long-term survival. Also, psychological effect of recovery, including delirium, depression, anxiety, may impact prolonged hospitalizations. immediate post-operative patient physical and psychological experience in the ICUs are well studied. Little is known about patients' experiences involving the entire recovery process. It's not well studied. The aim of this study is to explore experiences and perspectives of patients recovering from cardiac open heart surgery in the acute care setting. We utilize a qualitative descriptive approach. We also utilize purposeful sampling to recruit patients who are recovering from cardiac open heart surgery, such as CABG, valve surgery, at a cardiac step-down unit within a 500-bed tertiary care hospital in New York City. Semi-structured interviews are conducted from October 2025 to November 2025, and it continues until data saturation was achieved, which means that no new information is forthcoming. Interviews are audio taped and transcribed. Researchers, myself, and my co-investigator, Nikki Lee, coded transcript independently and identified themes and some themes. The research proposal was reviewed and approved by the IRB of Mount Sinai Health System. The study purpose, procedure, risk and benefit, and rights and responsibility as a participants and voluntary participation are explained to the patient. Consent was obtained prior to each interview. Philosophical underpinning. We utilize nursing middle range theory of unpleasant symptoms as a framework. So patients' unpleasant symptoms, for example, pain, anxieties, these are affected by physiologic, psychologic, and situational factors. And also that's impact distress, duration, and intensity and quality of symptoms. Eventually, these affect patients' performance, including functional status, cognitive functioning, physical performance. Therefore, we utilize these frameworks to organize our research. 12 patients are interviewed, 2 female patients and 10 male patients. Age are anywhere from 50 to 83 years old. Types of surgery are mainly CABG and valve surgery. The time of interviews are anywhere from post-operative 2 to up to 13 days. So we had actually quite bit a variety of the patients' perspectives in terms of recovery. Findings. 12 post-operative patients participated in this study. 6 major themes emerged from patients' narratives, starting with anxiety of the unknown, physical discomfort, building up trusting relationships, another chance to live, push myself to recovery. Finally, discharge plan is a part of recovery. I will go over each theme. Theme number 1, anxiety of the unknown. Due to lack of information and uncertainty of the conditions leads to patients' anxiety. So this patient never had a surgery before. So this patient said, I worry because I'm not a whole person anymore. I feel something being taken away from me. I've never stayed overnight in the hospital before. So it's even at 76, it's scary. Another patient describes while he was waiting for surgery, he was very anxious. My biggest fear was something would happen that I couldn't get it over with. Another patient said, I'm telling you, I thought I was gonna be bedridden for 2 weeks. Also, another patient said, not knowing things, it makes you a little bit anxious, and not everybody, it's not explaining. So therefore, patient feels anxious from unknown. Theme number 2, physical discomfort. Patients experience a variety of physical discomfort: pain, nausea and vomiting, endotracheal tubes, thirst, dry mouth, fluid restriction, lack of appetite, congestion and cough, constipation, and frequent bowel movements after we are giving a multiple stool softeners, edema, physical limitation, medical tape around the skin, and sleepless. So one of the patients described his pain. They are like a truck hitting one. They are like a truck hitting one. So it just hurts. When you are in pain, you are not in a good mood. Another patient describes their nausea and vomiting. I couldn't hold any fluids, and whenever they gave me Jello or lemon ice, I couldn't hold anything down. Another patient described about his sleep. Sleep was a big thing. It was so much interference. Almost just as soon as got to sleep, awake for the pills, for medicine. Sometimes these are too much crossover activities. So patients experience physical discomfort. Theme number 3, building up trusting relationships. The patient seeks attention from caregivers. Presence of caregivers build up relationships and promotes their comfort level. So this patient actually did very well after post-operative day 1. So he was downgraded to step-down units. However, his condition got worse and he needed to go back to ICU. So this patient described this. I knew I was going back to good people. So I wasn't worried about the part of it at all. I just figured they are going to go up and correct what they are going to do. And I already deal with a lot of people up there, which is ICU. So I knew I was in good hand. Another patient said, I remember seeing my doctor, my surgeon, and he was leaving. He shook my hand, he was leaving, and he turned around. He said, I got you. Don't worry. You are going to be okay. Okay? And that made me feel great, made me feel real good. On the other hand, if patients are not getting attention or not receiving care that they want, patients feel very anxious and feel isolated. So this patient described this. I need a care. I need a staff. If you cannot help me when I need something, why do I need a fancy TV? Why do I need a fancy room for? I don't need that. That's gonna require your presence. So patient seeks attention from caregivers. Theme number 4, another chance to live. Patients develop a positive outlook for their future, gaining health and quality of life while having a desire to maintain their health after surgery. So this patient described, I retired. I worked 35 years, never got sick in my life. As soon as I retired, I started getting sick. That's okay, because I got a second chance at life. God gave me a second chance, and I'm gonna do everything that I have to do to live longer. Another patient described that he gained back his quality of life. He said, I'm always concerned about the quality of life. I have 10 grandchildren, 4 of my children. Well, I didn't expect to be so good after surgery. Another patient said, taking better care of yourself, simple things like brushing your teeth, and even going to the bathroom, it's amazing that we take things like for granted. So patients feel another chance to live. They have a positive outlook. Theme number 5, push myself to recovery. Although patients have physical discomfort, they try their best to push themselves to recovery. A lot of patients mention about activities, walking around, physical therapy sessions. So this patient says, it hurts. It's a lot of challenges, but I'm trying my best. Like I said, I walked, I do the therapy, I walked a lot today. I gave myself credit because I walked all the way from this exit. Another patient said, I walked around, I felt a bit of pain, first steps, taking it. But I know that it's part of this process to get better, to recuperate. So I know that you have to have some pain to go through with that. So it's understandable. Also, another patient said, being that is difficult. You get beyond it. It's a physical. You got to do it. You got to put the work in. So now, our part as a caregiver, we have to help this patient's process. The last themes, discharge plan is a part of recovery. Physical limitation during the recovery phase increases patients' anxiety regarding their life after discharge home. On the other hand, if patient has a good support system, family, friends in their community, it's lessen their anxiety. So this patient worried about everything. So this patient said, that's my great fear, that everything is not accessible once you are home, and how am I going to wash my hair? And how am I gonna do this and that? Another patient's worried about his home situation. He said, the elevator breaks down maybe twice a month, and I have to walk 8 floors. I can't walk. It's bad enough for me walking down the stairs. Imagine me going up the stairs. I can't do it. It's too much. On the other hand, this patient has a lot of support, so she didn't worry about. So this patient said, I got 100 people. I don't have to worry about it. I got my friends. I live in my building. I got my daughter. I got a son. I got my nephews that love me to death. So therefore, discharge plan is very important. Discussion and implication. Provision of comprehensive preoperative and ongoing education and frequent communication are needed to promote patient understanding of care and treatment plan. Healthcare worker presence and caring behavior promotes a trusting relationship while promoting patient satisfaction. Interdisciplinary team needed to be a strength to support patients' recovery. Discharge plan and education should start at the preoperative phase and continue throughout patient's hospitalization. Further research will be needed to develop a better understanding of best practice to support patients recovering from cardiac open heart surgery. Limitation. The findings are limited by the setting of the single hospital, and these results may not be generalized. Most patients in these studies are English-speaking patients. Therefore, it may not reflect the perspectives of non-English-speaking patients. So I tried to interview one patient who didn't speak English at all. So I utilized interpreter service. However, when I use the interpreter, it's changed the context of the patient, so it's lose the essence. It was quite challenging, so this is the limitation. additional research is needed for patients' experiences at another hospital. Conclusion. The patients who undergo cardiac open heart surgery face a variety of difficulty due to physical discomfort and uncertainty. Frequent communication and healthcare workers' presence create a caring environment where patient feels secure. Interdisciplinary team approach is necessary to support patients' recovery phase. Finally, patient education should start at the preoperative phase and continue throughout their hospital stay. Lastly, I would like to thank Dr. Gale for being a faculty mentor, Dr. Murphy for supporting the IRB submission. For West staff nurse members, all nurses, NPs, PAs, and nursing assistants for supporting this interview process. Lastly, nursing leadership at Mount Sinai Morningside for supporting this project. These are references, and thank you. I don't know if we have a question, maybe 2 minutes. No questions? If you have any questions, please just come to the podium. Okay. All right.
Wait, she has a question. Come. Okay.
Yes.
As you know. So I have a question. So as you continue further study, do you plan to implement a different method of pre-op teaching for these patients in order to help alleviate their concerns?
Yes, we are going to do continuous another version of the studies and get a little bit more patient specific to the educations. Because we realize that patients' pre-op education is a little bit lacking, so we need to have more comprehensive. So this way, patient will know what to expect, and also that's increase patients' compliance.
Thank you. Thank you. Next, we're going to be hearing from Ami Shah, Pharm D. She'll be talking about pharmacotherapy considerations in ECMO patients. All right. Your thing is right, and then yeah. Perfect. Thank you.
Good morning, everyone. This is going to be a little bit of an interactive session, so just to get a gauge of who's in the room today, how many nurses do we have in the room? Amazing. And how many allied health or providers? Amazing. Perfect. So my name is Ami. Thank you, Shauna, for the introduction. Currently, I'm the Medical Director for Education for Cardiology and Pulmonology at VMedi. And today I'm going to be talking to you about ECMO and specifically the principles of pharmacotherapy management in ECMO. I have no relevant disclosures. The objectives of today, really, I want you to walk away understanding why certain drugs are different in ECMO versus in a regular ICU patient. So we're going to be going through the PK/PD alterations specifically in ECMO, and then we'll be going through a few different variations. We'll go through sedation, antimicrobials, and anticoagulation as well. So the first half of this, I'm going to be talking a little bit at you, but I promise it's going to come together. And again, I see a few people that I'm going to call out, so pay attention. We're going to be going through the PK determinants during ECMO. There's 3 major components. The first that I want to highlight is the ECMO factors themselves. So there's a circuit sequestration, specifically with the tubing. And then this is summarizing quite a bit, but also the priming volume. There's quite a bit of volume, as you know, that goes into these patients, which alters how these drugs behave. The second is disease factors. So we have increased VD, which is the volume of distribution. So with all of, specifically just critically ill patients, with the capillary leaks, the hemodilution, you're getting increased volume in these patients. And then you also have organ dysfunction. So as we all know, we often see specifically renal dysfunction and sometimes hepatic dysfunction as well, and so that affects how our drugs are metabolized. And then lastly, so we have ECMO, we have critical care, and then in addition to that, we also have each drug behaves a little bit differently. And so there's the drug factors. So we have the main things that affect how a drug behaves is the protein binding and then how lipophilic it is. We determine lipophilicity by log P, but essentially that means how quickly that drug distributes to the fat tissue versus if it stays in the plasma volume. So as we kind of already alluded to, there's critical illness and then there's the ECMO circuit. Sometimes they play together and have the same effect, and sometimes they don't. So I'll go through the left first. So this is critical illness first. I mentioned that you have an increased volume of distribution, which essentially means it just increases how much space your drug can go into in your body, whether it's in the fat space or whether it's in the water space or the plasma space. Mainly it's through the capillary leaks, but also because of how much fluid we give these patients. There's also altered protein binding and then end organ dysfunction, as we talked about. And then on the right-hand side, we have the ECMO circuit. So the ECMO circuit, in the VD issue, it creates the same increased volume of distribution. So you have hemodilution because of the priming volume. But on the opposite side, sometimes you get augmented clearance. So instead of the end organ dysfunction that does not process drugs as quickly, with ECMO, sometimes we see augmented clearance because you're now starting to distribute drug more quickly. You also see drug sequestration, which is essentially the drug starts sticking to all components of the circuit, whether it's the PVC tubing or the oxygenator or other parts of the circuit. So what does that mean, kind of in the middle? It essentially means that there's PK variability. It's not that they always play together. Sometimes they have opposite effects as well. When I'm talking about opposite effects, I'm not going to go through everything on this slide, but this gives you a little bit more insight as to which ones are the same effect versus which ones are different. So on the left side, you'll see there's several things that lead to lowered plasma concentration, but there's also a few that lead to increased plasma concentration. And just to orient you to what you're looking at, on the top, it's critical illness, and on the bottom, it's ECMO. And like I said, sometimes they play together, have the same effect, sometimes they have the opposite effect. So in essence, where does that leave us? If they have sometimes the same effect and sometimes the opposite effect, how do we know which drugs to increase the drug volume for and which ones to decrease? Before we get into the details of drugs specifically, I want to just orient you to when we talk about PK, what we're looking at. So I mentioned volume of distribution. This is one of the most basic analogies we can use to kind of understand how drugs behave. And I'll start first with what volume of distribution means and what I mean when I say that. So this bathtub, it essentially represents VD. It represents how big your bathtub, in essence, can get. That's the space your drug can go. Not every drug goes to the same space. It can either go to your plasma space or, like I said, it could go into the fat tissue. The second analogy is the drain. So the drain kind of represents our organs and how quickly these drugs are getting out of our system. The third is what we call drug sequestration. So these little ducts here are meant to represent proteins, and sometimes these drugs bind to the proteins, making them less available for the body to use. The more ducts you have or more proteins you have, the more drug gets absorbed, meaning you'll need more drug to get the effect you want. Those are kind of, in essence, in any patient, whether they're critically ill or not critically ill. These are the basics of how drugs work for our body. But when you throw in ECMO into this circuit, essentially ECMO, the analogy here is if you turn on the faucet, that's what ECMO feels like. So you're increasing your volume of distribution significantly. So the amount of drug you'll need to actually get the effect you want is sometimes very different than any other critically ill patient. However, at the same time, it also increases the number of ducts. And so that means you have more circuits, you have more things that it can stick to. And that means sometimes you'll also need more drug for that purpose. The biggest difference before we go into the details of what drug falls where is if it's hydrophilic, which means that it affects the plasma volume more, that essentially means you'll need more of a loading dose to get to where you want. You don't need more drug every single day for every single dose. You'll just need more upfront so that your bathtub can get full and full quicker. And then once that bathtub is full, you don't have to continue increasing the dose. You just give more of a loading dose and then continue your normal doses. In comparison to that, if a drug sticks or has more protein binding, what that means is that you'll need to give more drug every single time. It's not just a loading dose that matters. You need to give more drug. If it's a Q8 drug or a Q12 drug, you'll need to give a higher dose every time because you can expect that sequestration from the protein binding is going to happen continuously. So I mentioned a little bit about how drug properties influence behavior. We mentioned lipophilicity, and I mentioned if it's in the water or the plasma versus in the fat tissue. I also mentioned protein binding, and the one thing I didn't really touch on yet is molecular size and ionization. We're going to go into each one a little bit more deeply, but we'll start with lipophilicity. So if a drug is lipophilic, like I said, it's assessed by what we call log P. So that means it has a high log P. These drugs will also have a high VD, which is volume of distribution. What that means for you is that essentially you should remember that it's fat-loving and it sticks to the circuit. I gave some examples here, and the reason I give these examples is because they're drugs that we use every day. What's the impact of that? So if a drug is lipophilic, essentially that means, as I mentioned, it's going to stick to your circuit, it's going to be very attracted to the PVC tubing and the oxygenator, and that means you're going to have lower plasma concentrations, meaning you'll need higher doses. We mentioned this one already too, but if it's hydrophilic, meaning it stays in the plasma and in the water, and the two examples I've listed here are beta-lactams and vancomycin, that means you won't have a lot of sticking to proteins, but you will have from the hemodilution just a bigger bathtub, that analogy that we talked about. What does that mean? Early on, you're going to need higher doses. You are going to need a loading dose. You should not skip a loading dose on these patients. And we'll talk about specific examples as we go along of what drugs specifically and what that means for the dosing. And then lastly, if you have high protein binding, the biggest example is ceftriaxone, which we use for a lot of our patients. If that specific drug has almost like 95% protein binding, and like I said, we'll talk about drug specifics in a moment, but specifically ceftriaxone, it will always bind to your ECMO circuit. And so if you're giving something like ceftriaxone, you can expect that you're not going to get the same result that you would if the patient's not on ECMO. So what's the key takeaway here? Knowledge generally of where a drug falls. Is it hydrophilic? Is it lipophilic? How much protein binding does it have? If you know those characteristics of a drug, it can help you anticipate the extent and the relevance that it'll have for your patient. Obviously, every patient is different. Their organ function is a little bit different. How quickly the ECMO circuit's running is different. If you have to decannulate and restart the circuit, that will also change some of their effects. So patient-specific factors will play into this, but if you know how a drug behaves, it can help you predict what's going to happen next. So I know I talked a lot about the relative of these drugs, but I'm going to stop here and ask the audience. By a show of hands, what sedative do you use most commonly for ECMO patients? I'll start with fentanyl. How often do you guys see fentanyl for your ECMO patients? What about propofol? I see some for propofol. What about Versed, midazolam? I mean, you're using some sedation, so there has to be some answer. What about Precedex? How often do you use Precedex? Ketamine? Okay. All right, so I see Dan in my line of sight, so Dan, I'm going to pick on you. What sedative, if you're starting an ECMO patient, what would you typically use? Propofol. And what rate would you start propofol at? 10 and titrate up. Let's say this patient was already intubated before ECMO on fentanyl and prop. Let's say they're on prop at 40. What would you do differently once you start the ECMO circuit? Would you just kind of titrate those drugs? There's no wrong answer.
Yeah, I would essentially titrate it so that.
Okay. Perfect. Okay. So there is a little bit of a wrong answer, but we'll get into it in a second. But there's no wrong answer for any patient. You start essentially, and then you titrate accordingly. But some of these principles can actually guide what we're referencing. So I'm not going to go through everything on this chart, but I want to orient you to what you're looking at because I want you to actually walk away knowing at least some of the basics of what we're referring to. So on the left, we have the drug. In the middle, we have protein binding. And then on the right, we have log P, which I told you is how we measure lipophilicity. If you remember, the higher the protein binding, the higher the log P, the higher the doses you'll need. If you notice, the two drugs that we just mentioned, propofol and fentanyl, are at the top of that list. So you can expect that if you're, and in terms of not having a wrong answer, you're not wrong. You can always titrate these drugs. The problem is that you're going to be using much more drug than you previously were, and it'll take quite some time to get there. And so today we're going to talk a little bit about like what are our alternatives? What would you use instead? This is a very busy chart. I'm not going to go through all the details with you, but I want to have this for your reference. If you're ever looking back, and I think the slide set will be made available to you too, but at least then you'll know what drug behaves however it does. So just to orient you to what you're looking at, we have drugs on the left, standard dosing in ICU patients right next to it, the impact of ECMO following it, and then in the colored column you'll have what do we do with this information, what do I increase the dose, do I keep the dose the same, where do we go from here? So I won't read all of it to you, but I'll give you some of the highlights. So fentanyl, as we mentioned, fentanyl doesn't really have a cap high dose. So technically you can titrate and you can go as high as you need, but you should know that when you decannulate your ECMO circuit, you're gonna have rapidly different sedation needs. The impact of ECMO specifically is that it's variable dependent on the oxygenator, which does not help. Higher doses could be needed for analgesia, specifically in the first 24 hours, which is why in the first 24 hours you could be increasing your doses very rapidly. And so the dosing recommendation in the colored column is that for fentanyl specifically, you might need to increase your rates of infusion, and you're going to have to titrate to clinical effect. However, as I mentioned, that might take you quite some time to get the patient where you need them to be. The two examples I left here below are ones that are very different than fentanyl and propofol and some of the other ones we mentioned. Hydromorphone, we usually don't use a dilaudid drip in the ICU, but in this situation, it has no active metabolites. It's hydrophilic, meaning it's not going to be so affected by all the plasma volume that you're giving these patients, and it doesn't bind to your circuit as much as something like fentanyl does. And so hydromorphone or a dilaudid drip is one of the few that has standard dosing recommendations from our sedative columns. Morphine is a tricky one. We usually don't use morphine at all. I'd probably prefer something like dilaudid over morphine. But the concentrations remain kind of standard. So if you're using a morphine drip, the concentrations stay the same. What's interesting is that this is one of the few drugs where the clearance of morphine decreases. So you should use less drug because this patient will be more affected by morphine, if anything. Unfortunately, morphine also has an active metabolite, which doesn't help the situation, so it's more likely to also cause hypotension. So usually we avoid this for our patients, and dilaudid is preferred. But if you are using it, you should definitely know decrease the dose because it's going to have toxic effects if you don't. Also, in this call-out box, I mentioned caution in hemodynamically unstable patients, which is pretty much all of our ECMO patients, and then it's not preferred specifically for the accumulation in renal dysfunction. Again, not going to read all this to you, but highlights. Propofol, you will need higher doses. It's highly lipophilic. This is one of the few prime examples that will bind to your circuit. Significant sequestration within the ECMO circuit. In addition to needing higher doses, the thing, unlike fentanyl, if you increase the dose, you could just kind of keep going up. The only thing you'll have to worry about is withdrawal afterwards. Propofol is a little bit different. If you keep increasing the dose and have a high dose infusion for longer than 24 hours or even longer than 72 hours, you're gonna have to start worrying about the lipids and you're gonna have to worry about PRIS. And then I have some recommendations that if you do have a high dose up here, how often to check the triglycerides and what to do with the CK and that sort, just for your reference. Precedex, as we mentioned, we don't use frequently in a lot of our ECMO patients, but if you do use it, it is also going to be something that sequesters to the circuit. Precedex is different than propofol in that the losses happen earlier in the circuit. So if you're using Precedex, increase your doses, but you'll probably need it up front and then you could back off. Ketamine is like a little bit of a secret agent. I somehow love this drug, but it works very well for these patients. We don't use it frequently, but you can. The doses are highly variable, but 50 to 100 is your sweet spot. I have the dosing references here for you as well. It could cause hypertension and tachyarrhythmia, so caution specifically in our cardiac patients, but it does have low protein binding. So what that means is that it's recommended as part of the multimodal therapy, so once we start getting to the point of very high doses of fentanyl, propofol, we can start thinking about alternative agents and adjuncts like ketamine. The last two for sedatives before I take a quick pause. Ativan is the other one. The biggest issue with Ativan, it doesn't sequester to the circuit, but if you're using an Ativan drip, we don't use it often, but one of the biggest issues is the propylene glycol diluent, so toxicity is something you should monitor for. And then one that's also another kind of secret agent that I love for ECMO patients is Versed. So Versed, unlike fentanyl and propofol, it does get sequestered to the circuit, and so you will need significantly higher doses than in a typical ICU patient, but it's definitely, as part of the whole multimodal effect, very effective. So I'll pause here. I know every institution, sometimes they have a protocol, sometimes they don't. This is going to be really small for you to read, but I wanted you to have it for your reference so that if you're ever looking back on these slides and you're trying to figure out what do I do with the sedation in my ECMO patient, that you have something like a stepwise approach to follow. So I'll walk you through it. Don't expect you to be able to read the small print, but I'll tell you the highlights. The first highlight is identify your sedation goal. VA ECMO versus VV ECMO, very different sedation goals. Obviously, how acute the patient is determines how much sedation they need, whether it's deeper sedation or not. But knowing what your RAS goal is going to be is probably the first step in this process. The second step is analgesia. Before you go to sedation, think about your analgesics. We talked about fentanyl, but the first line, I would really recommend Dilaudid before fentanyl. Second line is fentanyl, so you can, like I said, just use fentanyl, but then increase your doses. Ketamine could be added to reduce opioid effects, especially if you're going to start being concerned about withdrawal, if patients are expected to be on something like fentanyl for a long time. And then you have some of your enteral agents, which I feel like a lot of people often forget, but you could use Dilaudid if you have enteral access. You could also use gabapentin. Specifically, that helps with our cardiac patients. Step 3, once you're done with your analgesia, now you start thinking about sedation. So our sedation preferences, we have propofol and Precedex. For most of our patients that need deep sedation, propofol is really the next step. If you need light sedation and you're on VV ECMO and you're just kind of preparing the patient for transplant, or they're not going to stay on ECMO for a long time, then something like Precedex is appropriate. You could use like IV pushes or intermittent doses of benzodiazepines, so Ativan. And then if you still need additional help beyond that, that's when you could start something like an Ativan drip or probably more often a Versed drip. You could also, as I mentioned, ketamine could be added. Once you start getting those really high doses, really start thinking about ketamine. It could really help kind of lower those opioid effects and get the patient under better control. Step 4, once you've done, we talked about analgesia first, then sedation. Now you're going to start thinking about delirium. So for delirium, we have a few options. Precedex is probably one of the best, so that kind of serves dual purpose if your patient's delirious. But you also have Seroquel and Haldol. Do note, though, that Seroquel and Haldol studied in ECMO patients, it's not as well studied. And so sometimes the doses that you use for a typical ICU patient, specifically for Seroquel, will be different in an ECMO patient, typically higher. And then step 5, just reassess your analgesic goals. And step 6, if you're still not getting anywhere at this point, you've done something like your Dilaudid or your fentanyl, you've added sedation with propofol, you've added either Versed or Ativan pushes. Now you should start consider paralysis. If your patient's still hypoxic and not getting any additional analgesic sedation, you should start thinking about paralysis and go into a deeper sedation phase. So we talked a little bit about fentanyl and Dilaudid, and I know we typically don't use Dilaudid, but I think if you walk away with anything, I want you to know, 1, you should think about if the drug is hydrophilic, lipophilic, what the drug behaves like. And as we talked about, fentanyl we use very often in addition to propofol, but these drugs, if you use them in an ECMO patient, you will need much, much higher doses. So start thinking about something like a Dilaudid drip. If you're thinking about how to convert something like fentanyl to a Dilaudid drip, I left this table here as a reference. I do want to note it's not an exact science. These are estimates of where these drugs fall. There is also what we call cross-tolerance reduction, so you should always be reducing the dose. If they're going from fentanyl to Dilaudid, it's not a 1-to-1. You should reduce it a little bit more and then titrate. Some patients are also very variable to how they react to these drugs, so what you would expect for the conversion to be may not be the same. And then the reduction, as I mentioned, should be like 25 to 50%. So if you're using a table like this and you're trying to convert, just do it a little cautiously, maybe reduce by 25% and then titrate up. So just to close out sedation and analgesia, this is a summary. I won't read all of it to you, but these are the major points. Number 1, initiate the drugs at cannulation. Early requirements, we talked about the VD, we talked about the bathtub getting bigger with all these priming volumes that we're giving them. You will need higher doses up front, specifically if you're using something like fentanyl and propofol that have that sequestration bind to the circuit. So initiate it. If they're not already on sedatives, start it when the ECMO circuit is cannulated, and then be ready to kind of monitor and increase those doses. Establish targets early on and reassess neurologic function, which we do often. Titrate these infusions as hemodynamics stabilize. The dose requirements often decrease once ECMO is stable. And so you should start these up front, but be very ready to start decreasing these doses when your patient is stable. Anticipate substantial dose reductions at decannulation. So once a patient is decannulized, you will need drastically different doses. I would not keep them at the same doses that they were on at the ECMO circuit. Monitor closely for delirium and withdrawal. And then lastly, if you walk away with anything from this, incorporate multimodal analgesia. One drug does not fix it the way that we typically use for our critically ill patients. So if you're only using fentanyl, only using propofol, start thinking about your other drugs like we mentioned, the dilaudid drip and ketamine. Okay, so we're going to switch over from sedations and analgesics to now antimicrobials, which is another hot topic for our ECMO patients. ECMO, because of the cannulation, is at increased risk for nosocomial infections. The rates go up to like 65%. There's not enough, before I go into further details, there's not enough data to support treating these patients prophylactically, but there is a lack of dosing protocols even if they have an infection. You are going to see pharmacokinetic variables, not only with your sedatives, but also with your antimicrobials, which is what we're going to go through next. And the first thing I'll start with, we talked about hydrophilic and lipophilic. That same concept applies to antibiotics. Again, very busy chart here, mainly for your reference. I won't read all of them to you, but this is a separation. On your left, you have hydrophilic antimicrobials. Again, that means they stay more in the plasma space versus lipophilic. Just as a reminder, in ECMO, you will have increased volume. So the hydrophilic antimicrobials, what that means, your bathtub is bigger. What do you do for the dose if your bathtub is bigger? Give more, but give it only up front. You'll need a loading dose, and then once the bathtub is kind of full, you can back off. So loading dose is important for hydrophilic antimicrobials. Lipophilic, what lipophilic means, it's being bound to all we call them the ducts in the bathtub, right? So what that means in terms of dosing, you won't really need a loading dose, but you will need higher dosing continuously. The two examples I'll provide to give you the difference here is hydrophilic is more like your beta-lactams that we use very often, and then lipophilic, there's a few examples here, but we'll go through each one. Flagyl is probably one of the biggest that stick out, and fluoroquinolones, but we'll go through each one specifically. Now, this concept of hydrophilic, lipophilic, we talked about that with sedatives and analgesics, but antimicrobials have one more step. The other step they have is that they have what we call pharmacodynamic variables. Unlike things like sedatives, or you could just titrate to the RAS, you can't really titrate antimicrobials to an effect. And so this added pharmacodynamic variable adds quite a lot of complication to antimicrobials. This chart is one that you'll see often, and I'll spend a little bit more time here because it is important that we understand what this means. So the graph in the gray, it represents what your concentration of the drug is over time. And so obviously when you first give a drug, you expect the concentration to rise and then you expect it to drop. What's an example of a drug that you see often that has a very high loading dose and then backs off? Give me anyone you could think of. Vancomycin, my favorite. So we'll talk about vancomycin more specifically, but that's a great example. There are some drugs where there's different parameters that matter differently. For example, on this graph, there's certain drugs where it's called concentration dependent, that how high it goes is what's more important than how long it like plateaus out for. The one example I could think of is in the OR, we give something like gentamicin, we give one dose. Why is that? Because we only care for how high it's going, and as long as it's reaching what we call that Cmax or that peak that you see there, that's all we want. We don't need to give it repeatedly. It's okay if their renal function's not great. We just want that peak, and then it'll taper off eventually. Other drugs, like vancomycin, is the AUC over MIC, which is that second circle you see here. That one it matters how high it goes, but then it also matters how deeply it goes down, like how much area is under that curve is what AUC stands for. So not only for vancomycin and fluoroquinolones do we care for how high it goes, but you want that dosing to be continuous so that enough stays in the system. And then there's others that are time dependent, so that last one. And so what that means is that dotted line that you're seeing, that's the MIC. MIC stands for minimum inhibitory concentration. So that's the rate at which it needs to be higher than that for killing of the bacteria to be effective. And so for these drugs, specifically beta-lactams, we don't care how high it goes. I just want it to be right above that dotted line for as long as possible. The best example I could give you is something like any penicillin that we give over 4 hours. The reason we give it over 4 hours is because it needs to be above this line continuously. If I give it for 2 hours and then I drop off, it'll be above the line for 2 hours and then it'll drop below, which is why that MIC for those drugs is a little bit different. I'll pause there to see if there's any questions. Okay, great. So just to summarize, there's hydrophilic, lipophilic, we talked about all of that, but in addition for antimicrobials, we have which drugs do I care to get that high peak for, like aminoglycosides, Which drugs do I care just to be above the dotted line, meaning give it for longer, which is something like penicillins, and then drugs that fall in the middle, which is something like vancomycin, where I kind of want both. I want the loading dose, but then I also want it to be given continuously over time. So these are kind of theoretical concepts. How do we apply them to the drugs that we actually use for ECMO? A lot of information. I'm not going to go through all of them with you, but I want to give you the highlights of what you can expect, and then you can always reference these charts when you're giving these drugs for your ECMO patients. To orient you to what you're looking at, same concept as what we talked about before. On the left, we have the drugs. Protein binding is next. The impact of ECMO follows it, and then what you do with that information is kind of in the colored column. So we'll start with ampicillin. Ampicillin has, in addition to being that beta-lactam that you'll need to give continuously, it has large sequestration. It also is impacted by that volume. And so if you're giving something like ampicillin, the recommendation is try to give something else. It's not the best agent to use for ECMO patients. ANSEF, which we use very frequently, I want you to walk away remembering that the protein binding is high. It's almost 85% or at least 80%. What that means is that as we give all this volume, the dosing for ANSEF will be higher. So may require higher doses for cefazolin, specifically if you're not using it for prophylaxis and you're trying to treat an infection. Ceftriaxone is the other example I mentioned. This one has up to 95% protein binding. What that means is that if you're using something like ceftriaxone, use the higher end of your dosing. And cefepime is different than the other two. Only 20% protein binding, minimal loss. It does have increased clearance, so you could use a standard dose of 2 grams Q8 or Q12, but an extended infusion, again, this is a beta-lactam, so being right above that dotted line may help for some of these patients. We don't typically do extended infusion for cefepime, but for our ECMO patients specifically, if they have, let's say, a Pseudomonas infection that they're just not getting better, you really should start talking to your pharmacist or your ID team to maybe consider a prolonged infusion for something like cefepime. Meropenem, again, won't go through all the specifics, but the few things I would highlight here, standard dosing, you might need a little bit higher dosing for these patients, specifically if they have a high MIC, which means they have resistant organisms, and meropenem is also a beta-lactam, so extended infusions are preferred. Zosyn or Piptazo, standard dosing. We do have something that we don't use often called TDM, and that's therapeutic dose monitoring. I'm sure you're familiar with vanco levels, but you can technically get those types of levels for almost all of our drugs. We don't do it frequently because you don't technically need to. Vancomycin is one that you probably should, just to make sure you're on the right spectrum. But for something like Piptazo, when you're using it in ECMO, therapeutic dose monitoring is recommended. So again, start talking to your ID team, start talking to your clinical pharmacist, and consider some of these levels. I left the ranges here for you, but a goal of 64 if you're getting these levels is recommended for some of your dosing here. Vancomycin, standard dosing recommendation. TDM, again, use your levels and adjust accordingly. We don't do vancomycin continuous infusions often, but in very rare situations it may be needed. Again, you'd have to talk to your ID team if this is something you'd want to consider. And then gentamicin is one of the few that we said, I care more about the peak. I care how high it's going. I don't care what happens after. And so standard dosing, use your peak levels and then use your trough levels to determine what you want to do with your dose. These drugs we don't use very often, so I won't go through these, but it is here for your reference. And then there's a whole table of additional drugs on the publications listed here as well. So use these tables for your reference. Come back to them if you do have an ECMO patient and they're not really adjusting to what you expect them to do. Okay, so we're going to shift gears now. We talked about sedatives, analgesics. We talked about antimicrobials. We're going to shift now into coagulopathy. I know the text here is small, but the one thing I want you to walk away with is knowing that there's two major things that cause coagulopathy in ECMO patients. This triangle is what we call a Virchow's triad, and essentially ECMO patients affect all three parts of the Virchow's triad. We have endothelial surface, which means that it's just extra surface and the lack of endothelium that causes coagulation for these patients. We also have hypercoagulability, so you have free hemoglobin from hemolysis, you have circulating microparticles. There's a lot of reasons why these patients can have coagulopathy. And then lastly, abnormal blood flow. As it's going through the pump, it just increases your risk of clotting. Secondly, you also have patient variables. Again, won't go through all the details, but really it's important for you to know these patients have a lot of reason for clots to happen. And so it's important that we're giving them anticoagulation, but then it's also equally important to understand how do these anticoagulants behave in ECMO. Just because we use heparin often doesn't mean we can expect the same titrations in an ECMO patient versus a regular ICU patient. So again, we'll go through all of these, and I'll spend a little bit more time because we really only have 3 anticoagulants that we could use, or 4 technically, but 3 that I've highlighted here. and it's important to know how they differentiate. So heparin is our drug of choice. The advantages are that it has a rapid onset. You could reverse it if you need to with protamine, and it's easy to monitor. We'll talk about monitoring in a moment, but heparin is kind of our first line. It is important to know that even though we kind of titrate it based on PTT levels, it's really non-linear. So sometimes the effect that you're looking for is not as linear as we'd hope for it to be. It is also dependent on antithrombin or AT activity, which we'll talk about in a moment, and then HIT is always a concern. Typical dosing I left here for you, and the monitoring specifically for ECMO patients I've also left here. So your ACT goal, 180 to 220, PTT 60 to 90, which is pretty standard, and then a 10A level, which is pretty important. We'll talk about that in a moment, and those ranges are listed here for you. Now, the two other things I want to highlight, I won't go through the rest of this chart, but I want you to know that the two alternatives that we use are gatroban and Bival. Peggy, I'll pick at you because you're sitting right in front of me as well. When would you use Bival over argatroban for any ICU patient? Okay, and then if you have HIT, would you ever use Bival, or is argatroban kind of your standard? Okay, perfect. That's actually typically what I see for a lot of practitioners. The one thing I want you to walk away, if you remember anything about anticoagulants here, one, I mentioned heparin ECMO patients standard. If you're concerned about HIT, obviously you have other alternatives. Argatroban and Bival are your alternatives, but I want you to remember kind of what's bolded on the bottom. Argatroban is cleared hepatically. So if you have someone with liver failure and you're worried about why their PTTs are not coming to where you want them to be, don't use argatroban. For other patients, it should be totally fine, but if you have hepatic dysfunction, argatroban is not your friend. And then bivalirudin is exactly the opposite, which kind of helps us in a scenario. So if you have renal function, don't use Bival. And if you have hepatic dysfunction, don't use argatroban. The other things are kind of here for your reference. I've left the doses here. You kind of titrate them to what your standards and what your ranges should be. But the column that is probably pretty important is that monitoring column. So look at them. They're pretty standard for what our typical ranges are, but those are the ranges we're looking for our ECMO patients. So while we're talking about monitoring, I mentioned ACT, PTT, and 10A levels. When do you use which one? And specifically in ECMO, why does it matter? We'll talk about ACT first. I'm sure as you all are familiar, it's rapid, it's point of care, it happens quickly. But at the same time, it could be prolonged for a lot of reasons. And the reasons kind of are in that column, on the first column in the second tab, I'll point to it here. Thrombocytopenia, platelet dysfunction, hemodilution. Why is that important? All of our ECMO patients have hemodilution, so using an ACT is not going to be as reliable for these patients. PTT is kind of the standard. It depends on your lab, but typically 30 minutes. But anti-10A is really what I want to touch on here because it's not something we use often, but it's something that could be very useful for our patients. Usually it's a send-out test, so it does take a little bit longer. But what's important is that it's a direct assessment specifically for heparin of how these drugs behave. 10A does not work for something like Bival and argatroban, but if you're using heparin at 10A level, if you're not getting the results you want to with the PTT, a 10A level is very helpful. And their typical goal is listed here, 0.3 to 0.7. Now this next slide is very busy. Don't read it. What I want you to focus on is this top column here. All of these from left to right are different guidelines. The reason I left this here for you is because often we have guidelines giving us different recommendations of where we should target. So what I have here is all the relevant guidelines that impact our ECMO patients and then all of what they recommend. I would highlight that this is one of the rare situations where all the guidelines actually agree. They actually say if you're looking for ACT, around 180 to 220. If you're looking for PTT, some of them are variable. Some of them say 50 to 70, some of them say 60 to 80, but really it depends on your institution. But know that generally there's an agreement of somewhere between 50 to 90 is their sweet spot. Anti-10A is the other one. We mentioned 0.3 to 0.7. Anti-10A is recommended by all of these guidelines. If you're not getting the level of anticoagulation you need in an ECMO patient, really consider an anti-10A label. Again, only helpful for heparin, but not others. There's also other, just for reference, other types of tests that you could do, specifically TEG and others, but they're not consistently recommended. So the top three that I mentioned are really our workhorses. So key takeaways, this is my final slide, so I'll pause here and take some time here. One, know that ECMO alters how drugs behave. It's important to recognize what a drug could do, whether it's hydrophilic, lipophilic, how it behaves in terms specifically when we talked about antimicrobials. Do I need a higher dose in general? Do I need a higher dose over time? Is the load more important or is the overall higher dose more important? Having some of this knowledge of how drugs behave is going to help you estimate what the clinical outcome will be. We mentioned lipophilic, and I mentioned that if it's a lipophilic means it's bound to proteins. If it's bound to proteins, what does that mean for your drugs? You want a higher dose, but you want a higher dose every time you give it. If a drug is hydrophilic, that means your tub is bigger. What do you want in that scenario? You want a higher dose, but you want a loading dose. Get the drug and get that bathtub filled in fast, and then once it's there, you can back off. Antimicrobials are a little bit different than something like sedatives. We talked about sedatives. You just kind of use one, titrate, and eventually you'll get where you want to go. Just make sure you're titrating appropriately. But antimicrobials don't work that way. So make sure you're taking account both the hydrophilic, lipophilic, but then also the doses that we talked about. And then most importantly that we didn't touch on, but I want you to remember as well, the drug exposure changes over the course of ECMO. Just because it's working now does not mean it'll work later. What that means for you in practice, if you're starting and cannulating a patient, you will probably need higher doses up front. Be ready to back off once that stabilizes. If your patient is getting recannulated, your dosing is going to change. Probably look more frequently and assess more frequently than you typically would if they're stable on ECMO. And then if they're being decannulated completely, know that you're going to have to down titrate much quicker than you typically would do for any other ICU patient. I will now take any questions. Okay, thank you guys.
So I just wanted to note a schedule change. We will be ending at 9:30, so everyone has an opportunity to listen to the keynote speaker, and then we will be back here after break at 10:30. But we have one more presentation until we do that, and that's going to be Dr. Aparna Chopra, and she's going to be discussing management of coagulopathy in post-bypass surgical patients.
Thank you. Thank you so much, Shauna. All right. Does anyone know how to launch the slideshow? Sorry, I should probably know this.
It's okay.
It's supposed to be presenter view.
There you go. Perfect.
Thank you. Good morning, everyone. It's so great to be here. My name is Aparna Chopra. I'm an intensivist, and I work primarily in a cardiothoracic ICU. And today I'm going to be talking to you a little bit about the management of coagulopathy in post-cardiac bypass surgery patients. So in making this presentation, as you can imagine, it's a very, very broad topic. And this is meant to be a brief overview of the risk factors, the diagnostic testing, and management options for coagulopathy in cardiac surgical patients. I certainly learned a lot while making this presentation, and I hope that you learn a little something too. All right, so let's begin. I have no disclosures. So understanding the complex mechanisms and management of coagulopathy is essential for cardiac surgeons, anesthesiologists, perfusionists, and all of us as ICU providers. Cardiopulmonary bypass-associated coagulopathy is usually multifactorial, and refractory blood loss can contribute to hemodynamic instability and end organ damage. Approximately 10% of patients undergoing cardiac surgery can experience serious bleeding, and about 20 to 40% of cardiac surgery patients may require blood product transfusions. So what are some of the mechanisms of coagulopathy? These include hemodilution, surgical bleeding, contact activation of the intrinsic system, tissue factor activation of the extrinsic system, residual heparinization from systemic anticoagulation, and the upregulation of inflammatory cytokines like interleukin 8, 10, and TNF-alpha that in turn cause the systemic inflammatory response. So what are some of the risk factors for postoperative bleeding? Number one is increased patient age. a cardiopulmonary bypass time greater than 150 minutes, a non-elective surgery. So a lot of our patient population are already on some sort of antiplatelet or anticoagulant. And when they present for urgent or emergent surgery, we have not had a chance to optimize them yet. And we can run into issues with coagulopathy post-op. Also, reoperation. So patients who have already been operated upon in the past, they can have a lot of tissue adhesions, and our surgeons work very deftly through this. However, we can have a lot of bleeding in these cases. Preoperative liver or renal failure, of course, can have a major impact on coagulopathy. And the preoperative use of antiplatelet agents. So what is the rate of reoperation in these cases? Approximately 5% of cardiac surgery patients will require reoperation for bleeding. About 5 to 7% of patients lose more than 2 liters of blood within 24 hours of surgery. The associated end organ damage is significant, and there's multiple blood product transfusions that can lead to TRALI, as well as hemodynamic instability that can lead to AKI and ATN. This, as you can imagine, leads to prolonged ICU stay and hospital stay, as well as decreased survival rates. There's a number of hemostatic derangements that occur in cardiopulmonary bypass. These include a decrease in fibrinogen concentration, decreased platelet count and function, a decrease in coagulation factor activity, an increase in clotting time, a decrease in clot strength, an increase in fibrinolysis. So the mechanisms of coagulopathy are as follows. There is platelet dysfunction, hypofibrinogenemia, and impaired thrombin generation, as well as hyperfibrinolysis. So as a background, in order to understand what are some of the tools in our arsenal to combat coagulopathy, it is important to know the coagulation cascade. We all remember this diagram. There were a lot of arrows, and there's a lot of Roman numerals, and it does look scary, but it is important to know this. So there's actually a very simplified version of this, but as an overview, there is an intrinsic pathway, which is through contact activation and endothelial damage. There is an extrinsic pathway, which is tissue factor release in trauma and inflammation. And then there is a common pathway. So I found this simplified slide by Rhesus Medicine. I encourage you to check it out. This looks far better. But in the intrinsic pathway, you have factor 12 that activates factor 11, which then activates factor 9, and factor 9 in combination with factor 8 then activates factor 10. Now, on the extrinsic pathway side, you have release of tissue factor, aka factor 3, which then acts along with factor 7 to also activate factor 10. This is where we come to our common pathway. So factor 10, along with factor 5, in the presence of the very important cofactor ionized calcium, then activates prothrombin to thrombin, and this thrombin then activates fibrinogen to fibrin, and this is very important for stable clot formation. This will become very important later on. So when it comes to management, there are some key elements. Number one is anticipation of bleeding. Then there's preoperative medication management, point-of-care viscoelastic and platelet function testing, and avoiding the delayed recognition of surgical bleeding. So when it comes to preoperative considerations, I came across this review article by Bartoshko et al., highly recommend. And here they talk a little bit about DOACs and the recommended preoperative discontinuation duration. So as you can see, dabigatran or Pradaxa should be held at least 2 to 4 days before planned cardiac surgery. When it comes to Xarelto, Eliquis, or Savesa, at least 2 days or at least 2 doses should be held, longer if the patients have renal failure. These are the ACC and AHA guidelines for patients who are on antiplatelet agents. So patients who have non-ST elevation ACS, who are referred for elective cardiac or elective CABG, in these patients, there is a class 1 level B recommendation to hold Plavix and Brilinta for at least 5 days prior to surgery. Prasugrel should be held 7 days prior to surgery. And in case of urgent CABG, Plavix and Brilinta should be discontinued at least 24 hours after cardiac surgery. Before cardiac surgery. So the STS guidelines, on the other hand, so in order to reduce bleeding in patients requiring elective cardiac surgery, Brilinta should be held for a minimum of 3 days, Plavix for about 5 days, and Prasugrel for 7 days. Of course, we can use lab and point-of-care testing. We've heard of the P2Y12 platelet function assay. And this is in patients who have recently been on DAPT prior to surgery. So we look at the number 200. If your P2Y12 assay is greater than 200, you're usually good to go. If it's under 200, you still have some platelet inhibition in play. And again, this is very operator dependent, but that's usually how we proceed. What are some intraoperative considerations? So now when our anesthesiologists bring the patients to the unit, we hear things like we gave ANH, we gave cell saver. So what does that actually mean? So ANH is acute normovolemic hemodilution or whole blood sequestration. So this is the collection of the patient's whole blood prior to surgery. This is replaced by colloid or crystalloid, and that whole blood is later reinfused back into the patient. Now, the point of this is to minimize the need for transfusion. However, as you can imagine, not everybody is going to tolerate this. If patients are already anemic to begin with, or if they're hemodynamically unstable, this doesn't work so well. Then coming to cell saver. So this is red cell salvage. All of the blood that is lost during surgery is collected and it is processed, recovering only the RBCs while washing away all the other components. And these RBCs are then returned to the patient. But since we're only returning the RBCs and no other clotting factors, this can cause dilution coagulopathy as well as fibrinogen depletion. So when patients arrive to the ICU, we can order a few studies. These are the COAG studies that we routinely look at. This is platelet count, PTINR, PTT, and fibrinogen levels. But there are some other point-of-care tests that we can look at. So in the operating room, they use the ACT, the activated clotting time. Why don't we normally use this in the ICU? When we're anticoagulating patients, for example, who've had DVT-PE or have ACS, we don't normally use ACT. So ACT measures the level of heparinization during surgery, and it has higher sensitivity at higher doses of heparin. So in cardiopulmonary bypass, we're using doses of heparin that are 300 to 400 international units per kilo. A PTT would not be useful in this case. So the goal ACT in surgery is 420 to 480 seconds. Again, this is a little bit different in every institution. The activated partial thromboplastin time, or the APTT, sorry, this is frozen. Okay, so this tests the functional nature of intrinsic coagulation pathway, and it detects heparin activity at lower doses. We also have anti-10A levels. This measures the functional anticoagulation effect of heparin. So a therapeutic heparin level, it refers to an anti-10A level between 0.3 and 0.7 units per ml. After reversal of heparin, you really shouldn't have any anti-10A activity detectable. But in terms of heparin rebound, the anti-10A level becomes very important because it will be elevated. Then coming to viscoelastic testing. So this measures the physical properties of clot formation by converting torsional forces into an electrical signal that is then mapped out. So there's a couple of tests that we look at here. One is TEG, or thromboelastography, and ROTEM, which is rotational thromboelastometry. So ROTEM looks at three different things, which is the extem, the extrinsic pathway, the intem, which is the intrinsic pathway, and fibtem, which refers to the fibrinogen. So how does this work? So For the point of this presentation, I'll be focusing more on TEG, but they both kind of work in similar ways. You take a sample of whole blood and you put it in a cup. Then you heat this up to 37 degrees. Then you have the machine that actually runs the test with a protruding pin that is then put inside this blood sample. The pin movement is proportional to clot strength. So in ROTEM, the pin that is inserted inside the sample, the pin is what's moving, it's oscillating. In TEG, the pin remains stationary and the cup is oscillating. So the forming clot is then going to start moving the pin. So as the clot grows, the pin will move more, and as the clot breaks down, the pin will move less. And this leads to a tracing with numeric results that we then interpret. Again, this looks much scarier than it actually is. So in the same review article, they did a really neat thing where they mapped out the TEG and ROTEM side by side. So you can sort of see what the parameters are. They're not exactly equivalent, but it kind of gives you a better idea of what we're looking at. So this is actually a graph of the amplitude as a function of time on the x-axis. So the R time that you see is actually the reaction time. This is the time to initiation of the first measurable clot. It is dependent on clotting factors and residual anticoagulant activity. The counterpart in ROTEM is the clotting time. Now the K time is actually the kinetic time. So this is the time from the first clot initiation to an amplitude of 20 millimeters. And this is dependent upon the fibrinogen levels. The counterpart in ROTEM is the clot formation time. Now the alpha angle is the same in both, and this is the slope or the rate of clot formation, and it is dependent upon the fibrin buildup and cross-linking. The MA is the maximum amplitude and the strength of clot formation. This is dependent on platelets. And in ROTEM, this is maximum clot firmness. The LY30 and LY60 is the percentage of clot breakdown or lysis after 30 minutes and 60 minutes of achieving maximum amplitude. And in ROTEM, this is the lysis index at 30 and 60 minutes. So I put together this table that really breaks it down and makes it easier to understand. So this is in 3 phases. There's a clot initiation, clot strength, and clot stability. So the R time, or the initial fibrin formation, if this is increased, we should be giving clotting factors. Where do we get clotting factors? In FFP. And if there is residual heparin activity, then we give heparin reversal. In terms of the clot strength, we have the K, or kinetic time. And if this is elevated, we would give cryoprecipitate because it contains fibrinogen. Again, if the alpha angle is increased, that means you're in a hypercoagulable state. But if it is decreased, again, we would give cryoprecipitate. If the maximum amplitude is decreased, we would give platelets plus or minus DDAVP. And of course, if there's increased lysis with an increased LY30 or LY60, then we would give an antifibrinolytic agent like TXA or Amicar. So we can actually interpret some of these different tracings. So the normal TEG is what's seen above. The second one down is when you have an increased R or K time. So in this case, we have a factor deficiency, so we would give FFP. In the third diagram, we have a decreased maximum amplitude. It looks very skinny. So in this case, we would give platelets or DDAVP. In the fourth tracing, we start off with a normal R time and a K time. However, we reach maximum amplitude and then it quickly starts decreasing, and your lysis time is increased gradually. So this is when there is fibrinolysis taking place, and we would give TXA or Amicar. Outside the realm of cardiac surgery, if we see this tracing, we might think this patient got TPA, but obviously in cardiac surgery, we would not go there. In a hypercoagulable state, we would see a very thick tracing because our maximum amplitude, our alpha angle, everything is increased, and you don't see much of the fibrinolysis. So this is a very hypercoagulable state. And the last one is the most ominous, I would think. It is a teardrop shape where you start off with a hypercoagulable state, so your R and K times are small. Your maximum amplitude increases initially because you're hypercoagulable, but it rapidly starts decreasing, or the lysis time starts increasing because you're now in a state of fibrinolysis in consumptive coagulopathy, or DIC. So now that we understand this, let's talk about treatment options. We all know that we can give blood products. So this includes PRBCs, platelets, FFP. And FFP contains not only clotting factors, but it also contains plasma proteins like albumin and antithrombin. And then there's cryoprecipitate, which contains fibrinogen, factor 8, 13, and von Willebrand's factor. Now, in cases of undifferentiated hemorrhage, if you have to give a large amount of allogeneic blood products, they should be administered as a 1-to-1-to-1 red cell to plasma to platelets for a balanced resuscitation. Coming to heparin reversal. So heparin binds and activates antithrombin 3, which is a natural anticoagulant. And this binds to factor 2A and 10A and inhibits them. So protamine is used as a reversal agent in a dose of 0.5 milligrams per 100 units of heparin. And typically we give about 25 to 50 milligram dosing, which results in heparin neutralization over a span of about 5 minutes. However, we should remember that excess protamine can actually cause fibrinolysis, so we cannot give excess protamine either. There is a phenomenon called heparin rebound. We just touched on this a little while ago. There is reappearance of anticoagulant activity after heparin has been adequately reversed with protamine after cardiopulmonary bypass. So the heparin is still bound to plasma proteins, and that is leaked back into circulation. This manifests as postoperative bleeding. So in this case, we would look at the anti-10A levels. If you've reversed the patient with protamine, really your anti-10A levels should not be elevated. And if they are, we know that there is some residual heparinization. There is also heparin resistance. You'll hear in the operating room, we kept giving heparin, we were not achieving the right ACT, then we gave antithrombin concentrate. So due to low antithrombin 3 levels, we need higher than expected doses of unfractionated heparin to achieve the therapeutic anticoagulation. And this could be upwards of 600 international units per kilogram. There's 3 different types. There's type 1, which is decreased synthesis of AT3 in the liver. There's decreased activity, or type 2, of antithrombin 3 with normal protein levels. And of course, acquired. If you have liver failure, you're not generating enough. If you have nephrotic syndrome or protein-losing enteropathies, you're losing all that protein. And then, of course, there's DIC, where you have consumption. So the treatment is to supplement AT3 concentrate. FFP also contains antithrombin and additional heparin. So DDAVP. DDAVP increases the plasma levels of factor 8 and von Willebrand factor, and thereby helps in platelet aggregation. There's a class 2B level B indication for the use of DDAVP to attenuate excessive bleeding and transfusion in patients with demonstrable and specific platelet dysfunction as of the SDS guidelines. This is in patients with uremia or cardiopulmonary bypass-induced platelet dysfunction or type 1 von Willebrand's disease. The dose is typically 0.3 mics per kg with a max single dose of 20 micrograms. Next, we'll come to the lysine analogs. So this is TXA and Amicar. So this inhibits plasminogen conversion to plasmin, which then breaks down clots. So per the SCS guidelines, the use of Amicar and TXA reduces blood loss and blood transfusion during cardiac procedures, and it is indicated for blood conservation. This is the class 1A recommendation. TXA also reduces bleeding and total transfusion in off-pump CABG surgery. Coming to PCC. Now, PCC stands for prothrombin complex concentrates. This was originally developed for the reversal of coagulopathy due to deficiency of vitamin K-dependent clotting factors, and they restore thrombin generation. There's 2 different types. There's 3-factor PCC, which is factors 2, 9, and 10, and 4-factor PCC with the additional factor 7. This also can contain protein C, S, and antithrombin. So when we compare FFP to PCC, we know that PCC has more effective restoration of thrombin generation with less volume and less alloantigen exposure. The dose is typically 10 to 15 international units per kilogram. There was a meta-analysis conducted by Roman et al. In 2019, which compared 423 patients who received 4-factor PCC versus 438 patients who received FFP. What they found was that patients in the PCC arm had less risks of receiving PRBC transfusions. There was no difference in chest tube output, reoperation for bleeding, stroke, or AKI. But interestingly, there was a trend in the PCC group toward requiring renal replacement therapy. According to the SDS guidelines, in patients who need emergent cardiac surgery who have recently taken a DOAC, you should administer the specific antidote. If that is not available, then PCC can be used as a Class 2 indication, recognizing that the effective response may be variable, and PCC is reasonable to consider over FFP as a first-line therapy for refractory coagulopathy in cardiac surgery in select situations. Next, we have fibrinogen concentrate. This can be used to treat acquired hypofibrinogenemia in cardiac bypass surgery patients. Cryoprecipitate, on the other hand, is a non-purified product, and it contains variable doses of fibrinogen, anywhere between 3 to 30 grams per liter per unit. Now, fibrinogen concentrate is a lyophilized powder. It is pathogen reduced. It is purified, and it has a defined concentration of fibrinogen, and that is 20 grams per liter. So this was published in JAMA. This is a randomized controlled trial published by Callum et al. In 2019 across 11 hospitals in Canada. It enrolled 827 patients with clinically significant bleeding and hypofibrinogenemia after cardiac surgery. They were randomized to receive either 4 grams of fibrinogen concentrate or 10 units of cryoprecipitate. The primary outcome was blood products transfused after 24 hours of cardiac surgery. So in the findings were that in the fibrinogen concentrate arm, the mean number of blood components transfused was 16.3 versus 17 in the cryoprecipitate arm. So really the ratio was 0.96, and this just meant that the fibrinogen concentrate was non-inferior to cryoprecipitate. Let's talk about recombinant activated factor 7A. So this is effective in intractable bleeding despite having corrected metabolic and hemostatic derangements. This is a Class 2B, Level B indication for use in cases of intractable surgical bleeding post-cardiopulmonary bypass that is unresponsive to routine hemostatic therapy. So there was this phase 2 placebo-controlled trial in cardiac surgical patients conducted by Gill et al. Back in 2009. And what they found was that the rate of reoperation for bleeding was 25% in the placebo group versus 14% in the 40 mics per kg recombinant factor 7A group, and about 12% in the 80 mics per kg recombinant factor 7A group. But there was an increased risk of critical events, including strokes, in the patients who received recombinant factor 7A. This was the study. There were about 172 patients who were randomized. And as you can see, the percentage of patients requiring reoperation in the A graph, you see that in the placebo group, there was about 25% versus the 14% in the 40 mic per kg group and about 12% in the 80 mics per kg group. But the percentage patients avoiding transfusions was lower in the placebo group as compared to the patients who received recombinant factor 7A. Lastly, we'll talk about factor VIII inhibitor bypass activity. This is FIBA. This is used in cases of intractable bleeding and, again, cardiac surgical patients. It contains prothrombin, factor 7, 9, 10, 7A, 10A, thrombin, and protein C. So just a few things. There are no large prospective randomized control trials that actually compare the use of FIBA versus recombinant factor 7A in refractory bleeding in this patient population, but there was a retrospective study in 2014 by Rao et al. That evaluated 168 patients who underwent cardiac surgery who received either FIBA or recombinant factor 7A. When they measured 30-day mortality, they found that there was no significant differences in the number of thromboembolic events, 30-day mortality, or rates of revision surgery. However, the recombinant factor VIIa cohort somehow received more platelets than other blood products than those who received FIBA. So we know we have all of these tools in our arsenal, but what are some things we can do in the ICU before we consider using any of these things? So number one, we correct coagulopathy. We keep the patient sedated and intubated. There is no need to wake them up and try to extubate them when they're already bleeding. So we have to stabilize them before we do that. You can always increase the PEEP to 8 or 10 as long as the blood pressure tolerates. The positive intrathoracic pressure will also help to curb some of the bleeding. Please ensure that the chest tubes are patent. Make sure that they're stripped, they're not clotted, otherwise we'll run into problems with tamponade. Always avoid hypothermia. A cold patient is a coagulopathic patient. As we remember, factor 4 is very important, which is ionized calcium. It is part of the clotting cascade. If patient is hypocalcemic, please replete the calcium and avoid hypertension at all costs. You must correct acid-base disturbances. Acidosis potentiates coagulopathy, so we must correct the acid-base disturbance. And of course, we should transfuse PRBCs and blood components as we see fit based on our viscoelastic testing and coagulation studies. So the take-home points in this case, hemostatic derangements in cardiac surgery patients are multifactorial. Point-of-care testing has revolutionized the diagnosis and management of coagulopathy. Surgical bleeding must be recognized early. We should be in direct contact with our surgical colleagues, make sure that they're aware, and if the patient needs to be taken back to the operating room to correct a surgical bleed, then that should be done very early. Management of coagulopathy is extremely nuanced, and it is institution-specific, and that prevents us from really having a standardized algorithm for managing coagulopathy in all patients. Thank you very much for your kind attention. It's my privilege to be here today. These are some of the references I used. I highly recommend this, the first article there. It's a review article on coagulopathy, and it was very helpful to me. Thank you very much.
Hi, good morning, everyone. Welcome back. We have our next presenter, and that's going to be Dr. Leila Hussainian, and she's going to talk about failure to rescue in cardiac surgery. So please welcome Dr. Hussainian for her presentation. Where am I?
Thank you for the introduction. Just to give you guys a little bit background about myself, I am an anesthesiologist and an intensivist who's been working over 15 years. I've worked in a variety of hospitals, large academic centers, mid-sized academic centers, and now a large community hospital in the suburbs of Philadelphia. And what I'm going to speak to you about today is something I believe is critical in improving outcomes in inpatient medicine, regardless of what type of hospital environment you're working in. I have no conflicts of interest. So why do some hospitals have higher mortality rates compared to others? Is it because of the number of complications or this topic of failure to rescue? So this is a wonderful paper that was published in the New England Journal in 2009 by Gaffari, a general surgeon. He looked at the data from the American College of Surgeons National Surgical Quality Improvement Program from 2005 to 2007. There's 186 hospitals that participated in this, and they looked at 130 patient variables, including 30-day patient morbidity and mortality numbers. He analyzed data from over 84,000 patients who underwent high-risk surgeries, either general or vascular surgery, high risk meaning greater than 1% mortality rate. And what he found was that although the rate of complications here is similar, the rate and the rate of major complications, which I've included over here, is similar. The rate of death after major complication varied significantly at a rate of 3.5 to 6.9 versus 6.9% in high death hospitals. So there was no difference in high or low mortality hospitals with complications that I've listed in red. Only unplanned intubation had a statistically significant increase in high mortality hospitals. So that's a pretty significant difference when you're looking at the complications being relatively equal among hospitals. So what he said were patients who were treated at very high mortality hospitals had nearly 2 times the likelihood of dying after development of major complications, as did their counterparts in very low mortality hospitals, 21 versus 12.5%. And when you look at certain complications, you see the difference is quite significant. With strokes in a high versus low mortality risk hospital, 46 versus 22, deep wound infections, and septic shock. So failure to rescue was popularized because it's defined as death after a complication and is a measure of hospital quality. So failure to rescue implicitly accounts for the fact that post-operative complications will occur no matter how hard we try, and if the care even has been fully appropriate. Although complications are primarily associated with patient characteristic, by comparison, failure to rescue is associated with the setting and context which care is delivered, i.e. hospital characteristics. And failure to rescue is based on the premise that prompt recognition and treatment of complications can profoundly impact a patient's eventual outcome. And this represents a clear focus for quality improvement, because we know these complications are going to happen, but how can we be one of those low mortality hospitals? So we have to look at different factors that affect failure to rescue. We have to look at patient factors, institutional factors, and system factors. Patient-specific factors include the presence of frailty and comorbidities. These are things that we can't, even after adjustment for age and comorbidities, frailty actually remains an independent risk factor for failure to rescue. Then we have to look at macro system characteristics. We look at the number of hospital ICU beds. We look at surgical volume. So using 2005 to 2007 Medicare data, there's this paper by Gaffari actually identified patients undergoing 3 high-risk cancer operations: gastrectomy, pancreatectomy, and esophagectomy. They ranked the centers into 5 groups based on volume of the cases that were done. With all the 3 operations combined, failure to rescue had a much stronger relationship to hospital volume than post-operative complications, as you can see by this slide. The primary argument in favor of high-volume centers is that they potentially have more standardized treatment pathways for perioperative care, helping them to have low failure to rescue rates. We can also see this among cardiac surgical cases. So a total of over 43,000 patients were included across 17 centers in Virginia undergoing index cases, AVRs, CABGs, mitral valve repairs and replacement. Of these, 5,315, which is 12%, developed failure to rescue complication. So for the STS, a failure to rescue complication is prolonged ventilation, which is greater than 24 hours, post-op renal failure requiring dialysis, reoperation, and stroke. So of those patients that developed a failure to rescue complication, 735 of them, which is 13.8%, experienced actual failure to rescue. So observed to expected failure to rescue was significantly associated with the case volume. Increasing case volume was independently associated with decreasing failure to rescue. So the conclusion to this, increasing center case volume is significantly associated with improved failure to rescue rates, which brings to question whether we should allow all hospitals, whether big or small, to do all types of cases. Should we consolidate surgeries, high-risk surgeries, into a big, high-volume centers, as they do in some countries? and ask patients to travel to those centers. So closing down some of the maybe cardiac hospitals that do very few cases and sending them to the main hospital. This is a question which this data kind of brings to light. There's also macro system characteristics that affect failure to rescue. The institutional staffing of physicians and experienced nurses, along with support staff, plays a crucial role in the patient rescue plan. The absolute physician-to-patient and nurse-to-patient ratios and the expertise level of the staff highly contribute to the reduction of failure to rescue rates. There's mounting evidence demonstrating a negative correlation between nurse and patient risk ratios and failure to rescue rates. In other words, as the nurse-to-patient ratio increases, the failure to rescue rate lowers. In institutions with low physician or nurse-to-patient ratios, the staff has the duty of caring for more patients, thus reducing their time dedicated to each patient, making them unable to detect patient deterioration early and unable to escalate their level of care. In addition, these ratios provide a high burden, and that contributes to job dissatisfaction among staff, along with exhaustion and high turnover. In addition, they showed that nighttime nighttime coverage of physicians also reduced failure to rescue. So there was retrospective observational study that was published in the Annals of Surgery in 2019. They looked at the Michigan Quality Surgical Collaboration, which is a prospectively collected data, and they looked at this database. They identified 44,000 patients undergoing major general or vascular surgery from 2008 to 2012. Their main outcome measures were looking at mortality, complication, and failure to rescue rates. Low failure to rescue hospitals tended to have closed intensive care units, high proportion of board-certified intensivists when compared to high failure to rescue hospitals. They also had more hospitalists, they had residents, and they had more overnight coverage, as well as a rapid response team. So now let's switch gears and look at the systemic approach to patient rescue. General surgery literature has promoted the concept of a circuit with two limbs. First, we have to recognize that there's a complication, which is the afferent limb, and then there has to be a clinical response. Complications can be variable, and there's different series of complications that we look at for general surgical cases versus cardiac surgical cases. So between complication recognition and complication treatment, there exists a complex process of escalation of care. And it's important not to forget that that puts those two pieces together. So there's a four-step approach to rescue. First, you have to recognize, you have to escalate care, you have to effectively manage the patient, and you have to mitigate additional complications, because as the number of complications increase, your ability actually for failure of rescue goes down, and your morbidity and mortality goes up. So for complication rescue, we need to identify clinical deterioration. We need to make sure physicians and nurses are doing their physical exam, appropriately monitoring vital signs, and following lab values in a timely fashion. So that's how sometimes ratios can come into play. You need to be able to anticipate your complications. And often we can do that with good sign-outs. We can anticipate whether a patient is at high risk for delirium, might jump out of bed and fall. If a patient had complex multi-valve surgery, has a high risk for heart block, you make sure your pacing wires are working and are there for backup. You may have patients may be at high risk because they're going to have to get systemically anticoagulated because they have a mechanical valve. We can predict a lot of the complications that patients have, and it's important that we anticipate those and we make sure the whole team is ready to take care of it. Next, we go into escalation of care. We have to develop a shared understanding when the patient's deteriorating, increase our monitoring, and begin our diagnostic workup. So either we have to bring the patient back from step down into the ICU, we have to now start with invasive monitoring, get more access, or consult specialists. Now, the reason escalation of care is so important is that the incidence of delayed escalation can be quite significant, 20 to 47% are some estimates. And delayed escalation of care is associated with higher mortality. So if you find out there's a problem, but you don't actually get to that next step, you didn't really do any benefit for the patient. So causes of delayed escalation, recognition escalation are either clinical inexperience, either people are overwhelming workload, fear of hierarchy and intimidation and criticism, I think that's a big one, and poor communication. I think we've all seen this. A patient comes out of the OR is bleeding. You see 15 minutes, half an hour, 1 hour, you start transfusing, you call the surgeon. I think your patient has a surgical bleed. No, if you give more products, it's gonna stop. So delaying that, I've seen surgeons give 10, 12 units before they actually agree to take a patient back to the OR. So I would call that as a delayed escalation of care, and that can lead to failure of rescue. We see this with a patient who comes out of the OR and maybe is extubated and isn't moving one side so well, and you say, oh, it's a little bit of anesthesia, residual anesthesia, just let it wear off. I'm sure they didn't have a stroke. You tell the surgeon, I really think we have to send the patient for a CAT scan of the head. No, just let them wake up longer. So this delayed escalation of care is a very dangerous thing, and unfortunately is controlled by multiple different people. We have taken some of that away. We do have nurse-directed stroke codes, for example, which is kind of eliminated that delayed escalation. The nurse at the bedside can make that call for the neurologist, the head CT to happen without waiting for someone to agree with them. And that's helped to decrease this delayed escalation escalation. But keep in mind, if you do delay this, you will affect your ability to, you may end up in a situation where you're in a failure to rescue situation. So effective management, once you've escalated your care, now you have to effectively manage the patient. Acute stabilization is often led by anesthesiologists and intensivists. You have to get your consultants in place, and you have to move forward quickly and efficiently with your treatment. As I said before, you have to mitigate. Once you have a complication, you have to mitigate additional complications, because as your number of complications increases, your mortality increases, and your ability to overcome that failure to rescue, it goes down. So once a patient has had a complication, make sure we focus on preventing the additional ones, remove lines, wean them back from the ventilator, mobilize them, try to get them back to that next stage as fast as possible. And when we talk about mitigation of additional complications, this is a nice figure. It was taken from a retrospective study with over 266 patients who underwent high-risk general vascular and thoracic surgeries. You can see that the mortality increases as the number of complications increases across all hospital groups, and 2/3 of the mortalities occurred in patients with greater than one complication. So there's everyone has a role when it comes to patient rescue. Junior physicians and nurses, they need to be monitoring vigilantly. They need to be able to speak up and feel free to speak up and advocate for their patient. They need to have smooth and efficient communication. And senior physicians, they should anticipate the problems. They should tell their teams what they expect this patient is at risk for. They need to listen and take seriously the concerns of the nurses and trainees, and they need to teach so they can, and they have to incorporate teaching with their trainees and nurses. So when we look at ways of improving rescue, we can look at the airline industry. Nearing the end of the 1990s, Korean Air had more plane crashes than any other airline in the world. According to Malcolm Gladwell, best-selling author of The Outliers and The Tipping Point, communication and culture are the most important elements used to predict safety in aviation. You can't hear the...
And that the most important aspect in the safety of a plane
Hold on,
is not the plane.
let's go back. How do we go back? Let's do this.
So, what is
What?
one thing people need to know about how cultural differences cause planes to crash? People need to understand that the most important aspect in the safety of a plane is
It's not
the
loud
plane
enough.
itself. It's not the hardware. It's the pilots. And in particular, it's
It's
how the
Max.
pilots communicate. And if they can communicate openly
Yeah,
and honestly,
but you can't hear it. This is,
clearly,
oh, is it
they
loud?
can minimize their chances of crashing. And their ability to communicate in that way is a function of their culture.
So
And cultures
basically,
where
I don't think it's very loud.
subordinate is
So
difficult
basically
to
what
speak
Gladwell
to,
links, here, I'll just
uh,
kind of tell you what happens. So Gladwell links the poor safety record of Korean Air in the 80s and 90s with pilot behavior that was dominated by cultural hierarchical structure. So specifically one of high power distance as well as cockpit miscommunication. So the junior pilots were too scared to talk to the senior pilots when there was something wrong and tell them. And that miscommunication is what led to the high level of crashes. So Korean Air actually restructured their training, and they included cultural reorientation inside the cockpit to encourage the crew to speak up about perceived dangers and voice concerns in plain language, and they were able to significantly improve their safety record. So I've broken down strategies to improve rescue into 4 categories. So one is culture and communication, education, technology, and system teams. These are all 4 important pieces regardless of the size or structure of your hospital. Number 1 is improving communication. So this is a freebie. It doesn't cost you any money to learn how to communicate effectively. You don't have to hire new nurses. You don't have to hire more doctors. It's a microsystem factor that's been argued to actually have the greatest impact in terms of failure to rescue. The first requirement to improve culture and communications is to create a culture of psychological safety. So psychological safety is the ability to show or employ oneself without fear or negative consequences of self-image, status, or career. This is core into creating a successful team functioning as it improves learning and the likelihood that team members will suggest new ideas because you've destigmatized questioning. Psychological safety creates the environment to support escalation of care. As we talked about, that little escalation of care piece is critical to avoiding failure to rescue. It's important that anybody who is involved willingly brings up the concern about a patient forward without worrying that it'll make them look bad. We can understand we have to understand that there's no perfect time to escalate. Again, as I talked to you before, after how many cc's of blood, after how many liters of blood do you have to call the surgeon? Within what period of time should you call the surgeon when you're going up on pressors and inotropes? Within what period of time should you call the stroke code? These are very, very difficult things that the person at the bedside often is scared to kind of make that call, and they're worried that they may be overcalling someone, and when they overcall, they're going to be humiliated in front and saying that you have terrible clinical acuity, I can't believe you expected that this patient really had a stroke, now you're trying to make me look bad by making me take the patient back to the OR. But the reality is that we need to encourage this communication and understand that when someone is bringing this up, it's not to make the physician look bad, but it's to say, hey, I'm trying to protect the patient. I want to make sure that maybe this is a good time to escalate care. You can make the final call, but you don't need to be humiliated because you're bringing it up to them. So let's look at quality of communication, because the reality is we need to be communicating on the same waveform. The S-bar is a tool that used to improve physician-nurse communication as well as handoffs in medicine. It was originally developed and used during submarine handoffs by the US Navy. It provides structured format for presenting medical information in a logical and succinct sequence, but there's no consistent data to support the use in terms of failure to rescue. So the S-bar, although it's important and it's helpful for organizing thoughts, the only way to really take this to the next step is for all of us to be speaking the same language. And to do that, we need to do things together, meaning rounds need to be interdisciplinary, sign-outs need to be interdisciplinary, M&Ms need to be interdisciplinary. And that allows us to all be speaking the same language. It needs to be that all people need to be contributing. It shouldn't be passive. So at rounds, nurses also should be participating, not just passive at rounds. And part of all of the different elements. And when you do that, everyone starts to just naturally speak the same language and have a better understanding of how to kind of communicate. And with every surgeon or every doctor that you speak to or every nurse you speak to, eventually you learn that there's different ways that you have to communicate with each person to kind of get the message across. And you learn that with more and more communication. The next thing we're going to look at is technology. Over the last 15 years, I've witnessed myself how technology has impacted the day-to-day care of patients. When I started, we used paper charts, and now we have Epic. I can find any piece of data from the last 15 years in a patient's chart. And technology, in the end, has helped to improve our daily routine, and I do think it has helped us to take better care of patients. A technological tool that is increasing in popularity to improve early detection of patients in need of rescue is Epic's Deterioration Index. This DI index is a proprietary machine learning model that has been in use since 2017. It's a predictive algorithm using 17 parameters to calculate a patient's risk of deterioration during a hospital stay. It's calculated every 15 minutes. There's a score from 0 to 100. The higher the number, the higher the risk of deterioration. And the optimal DI score, though, with which to trigger a clinical intervention, though, is still unclear. So this score can help physicians prioritize which patients they see first on rounds. At our hospital, this score is required documentation for nurses. But if that number gets high enough, greater than 40, or if there's a sudden change of delta 14, there is an ICU nurse off-site that will actually call the bedside nurse to talk to that bedside nurse about this patient to understand whether this patient needs an escalation of care. So it's when you use technology, but you have people behind the technology, you have that conversation, that's where you can see the benefit to this, because using this DI number in of itself hasn't necessarily been shown to to improve failure to rescue. But in some hospitals, this DI index has been shown to decrease mortality up to 22%. But again, I think people need to be involved, and there needs to be communication about this number to actually make it effective. Now let's look at patient monitoring systems. How many people, like the pulse ox for anesthesia has never actually been proved to improve outcomes. It's never been proven. So do I expect that we're going to be able to prove continuous monitoring is going to improve rescue? No, but deep down I can tell you that it will help us recognize patients in need of rescue faster. When we talk about technology, we have to think, are these screens and monitors, however, distracting us from taking care of patients? Does technology increase the barrier to direct patient care, hurting our ability to rescue? Or does technology decrease the barrier to patient care by allowing doctors and nurses to spend more time with patients rather than manual charting? As you can see here, this picture, the only person who actually is watching the event rather than watching their phone is this nice little old lady at the bottom. So we have to just make sure we don't lose sight of the fact that we actually need to be going into patients' room, touching patients, talking to patients, and we can't just be looking at monitors. There's an interesting observational trial that demonstrated the importance of bedside surveillance in preventing failure to rescue. Patients that were seen by their nurse more than 12 times a day had significant decreased odds in experiencing failure to rescue. And I think that's pretty meaningful, because I can tell you that over 15 years, the amount of time that I see, I can tell you for doctors, especially doctors in training, the number of times they actually go into a room when a nurse tells them, hey, this vital has changed or this has changed, has gone down significantly. Instead, the first thing that they're going to do is just look in Epic instead of actually going to the patient's bedside. The next strategy to improve failure to rescue is education. It's not a hard sell to tell you that education is critical to the improvement of failure to rescue. Number one, we can look at simulation. It helps to expose trainees to infrequent complication. It's been used for years in anesthesia, but taking the next step to create interdisciplinary sessions to build that culture of safety and improve communication is vital. Next, let's look at our M&Ms. Traditional M&Ms, they focused on discussing individual errors in decision-making and usually included only members of that specific specialty, versus rescue M&Ms, which are devoted to critically evaluating failure to rescue by focusing on key issues that hinder timely treatment of complications, and all of the stakeholders are invited to participate. Finally, just as the process of obtaining advanced degrees helps to improve failure to rescue. The more nurses that you have with BSNs, the improvement of failure to rescue. The final strategy to improve failure to rescue is use of system teams. System teams quickly convene multiple specialists and disciplines to rapidly evaluate patients at risk, formulate a plan, and mobilize the resources to provide the highest level of care quickly and efficiently. We see this with rapid response teams, stroke code teams, shock teams, PERT teams. You get everyone together quickly so you're not delaying that care. The Agency for Healthcare Research and Quality reviewed the literature examining the use of rapid response teams on failure to rescue, and they didn't find consistent data to show there was a decrease in hospital mortality. There was moderate evidence to show that there was a decrease in non-ICU cardiac arrest rates. But once again, I have a strong suspicion that, as we discussed with technology, there's an element of culture and communication that can affect the success of these groups, which is exemplified by their statement, recognition of the benefits of RRT implementation often take a long time. So once that group becomes ingrained in the culture, we get used to communicating with them, we get used to understanding what they're gonna do and how they're gonna help us, and we know how that's when we start to see the benefit of this group. So just to review, there's 4 basic elements to improve failure of rescue: the culture and communication, education, system teams, and technology, and they all need to be taken together into actually improving failure to rescue. And in the end, the improvement of failure to rescue is what decreases morbidity and mortality in patients. And it's a way of taking a step back from just pointing the finger at the surgeon with the complications that a surgeon deals with, and instead looking at our role in how we can take a complication, which oftentimes you're gonna get complications. The best surgeon is gonna get complications. But now, as intensivists, as nurses, as all of the other people who take care of those patients for the next 3 to 7 to 14 days that the patient is in the hospital, we play a role in improving the morbidity and mortality of that patient by making sure that this patient isn't a failure to rescue, and rescuing them quickly and efficiently so they can go home and we don't have another mortality. I'm just going to leave you with this quote: rescuing a surgical patient is an intricate, experiential, and very human process that hinges on continuous interpersonal interactions. And I can tell you, whatever people want to dismiss, the interpersonal interactions is critical to a highly functioning department, a highly functioning unit. And places that may not have the same volume, but if you have very strong interpersonal interactions, you have a strong team, you can do a lot with that, and you can really help patients just with good communication and with vigilance. Thank you.
Thank you. Our next speaker is going to be Fred Dunal, Jordan Townsley, Mallory. Oh yeah, no, what's your last name? Mallory Perrin, and they're going to go over nursing interventions for mechanical circulatory support for CABG patients.
I got to get to mine. I can't. Mine didn't get pulled.
I'm here.
That's not mine.
Yep.
No, yep, that one. Thank you. Thank you, Shauna. Okay, good. My name is Fred. I work at Morningside at Mount Sinai, Mount Sinai at Morningside. I've been in nursing critical care for over 35 years. I've worked with these devices quite a bit. Me and Mallory will be discussing today circulatory support devices, mainly intra-aortic balloon pumps and impellers. First, I'll talk to you about skills and theories, and then some of the nursing roles in taking care of a patient on an intra-aortic balloon pump. So first, there's two reasons why we would place an intra-aortic balloon pump. One is for coronary perfusion. The other is for cardiogenic shock. And we may think that there are other reasons to put these balloon pumps in, but it all comes back to increasing coronary perfusion and decreasing afterload to help with patients in cardiogenic shock. Now, we have to understand kind of like the physiology of what's going on in the heart and how it does perfuse itself, or how it perfuses the coronaries. The coronaries are perfused during diastole. So during systole, blood is ejected out into the aorta. During diastole, the aortic valve closes and the heart is now relaxed, so the coronaries open, allowing the diastolic pressure to push blood into the coronaries. Now, if you have coronaries that are stenosed or occluded, sometimes that pressure during diastole is not enough to get blood flow to the coronaries, hence you'll have chest pain, ischemia. So how can we increase diastolic pressure to force more blood into the coronaries? We can use an intra-aortic balloon pump. It's basically a balloon in the descending aorta that will inflate during diastole, forcing more blood into the coronaries. That's how it takes care of coronary perfusion. Then, remember now we have a balloon that's inflated in the descending aorta. The heart fills with blood. A split second before it goes to contract, the balloon will rapidly deflate, almost causing a vacuum inside of the aorta, assisting the blood out of the heart, decreasing systemic vascular resistance, basically decreasing the workload of the left ventricle. So that's what it does. The elements of the balloon pump itself. Well, first we have to get the balloon pump in. It goes in through an 8 French introducer. Then we have the balloon. It comes in different sizes. There's 3 sizes. Most places will use 2 sizes. Depending on the brand, it can be either a 50 or 60. Other brands are either 40 or 50. But it goes by height. It doesn't go by weight at all. It just goes specifically by height. Usually patients 5'4" or under will get a specific size. Anybody over 5'4" will get the larger size. We also have a helium tank in the console. And why do we use helium rather than air? It's basically 2 reasons. Because helium is much less dense, has a lower molecular weight than air, hence it can much more quickly go in and out of the balloon. Plus, if the balloon ever ruptured, it would be better to have excess helium in the aorta rather than excess air. And then we have the console itself. The 2 companies that make the consoles are both Marquette and Arrow. Basically, they serve the same function, regardless of which brand you have. Then we're talking about the size of the balloon, which I already explained to you. It goes by height, not by weight, but placement of the balloon itself. The balloon has to be far enough in to function, but not too far in where it's going to obstruct your left subclavian artery. And if it goes even further, it will obstruct even more arteries. So it's very important that we check pulses in the left arm, brachial pulses, hourly to make sure that the balloon did not migrate in too far. If the balloon is down too far, it can obstruct the renal arteries. Hence, it's very important that we monitor urine output. If we even suspect that the balloon got pulled, we should get an X-ray. On that X-ray, you will see, can you guys see my pointer up there? Yes. You will see we have a radio-opaque marker on the balloon pump itself. You can't really see the balloon itself. Sometimes you can. It might be a little darker area if you happen to get the X-ray when the balloon is inflated. But usually we'll just look at the tip of the balloon. Couple of ways to determine if it's in the right place. It should be level with about the second or third intercostal space on the X-ray, but remember that only works if your X-ray is taken perfectly straight on. If your X-ray is taken at an angle up or an angle down, you can see if this is the catheter and I angle it, it's not at the second or third intercostal space anymore. So you have to make sure that the X-ray is taken appropriately. Another way is to actually look and find the arch of the aorta, and we can see that arch right here, and we can see that the balloon is right before it, okay? If the balloon is in too far, you will get an excellent waveform on your balloon. It will not dampen that waveform, it'll actually make it better, but you may lose an extremity. So we don't want that. So you can't go like my waveform is great, I don't need to check the placement of the balloon. Contraindications to the intra-aortic balloon pump would be cerebral peripheral vascular disease, aortic valvular insufficiency, and that really makes sense, right? If I have a valve that doesn't close properly, I don't want to inflate a balloon and increase diastolic pressure against a valve that's not closing properly already. Severe coagulopathies, aortic aneurysm, or aortic dissection. Oh, I thought that slide wasn't there. We'll skip that slide. Basically, it just talks about the balloon assists when you have narrowing of the coronaries to help perfuse better. Now, why not use inotropes? Well, in certain situations when we use an intra-aortic balloon pump, we can use inotropes. But we wouldn't use inotropes in a patient who is ischemic. So if we're talking about a patient pre-operatively or pre-procedure that's going for either stents or a CABG surgery, we can't use inotropes in those patients because it's increasing oxygen demand. Post-operatively, once we've become revascularized, there is sometimes when we can use inotropes, and now we're really only using the balloon for the afterload reduction to rest the heart while the heart recovers, or to offload the heart. But usually, on an intra-aortic balloon pump, you would not normally use inotropic agents. This slide here just talks about basically what I just said before, and I'm going to repeat it again because it's important. The heart perfuses itself during diastole, meaning it perfuses the coronaries during diastole. So it does it somewhat passively, but under the pressure of diastole, which is not a very high pressure. So during diastole, the balloon will be triggered. The main trigger on the balloon pump is usually the EKG tracing, the QRS. If the heart rate's very rapid or irregular, it may just use the R wave alone. If you can't get a good tracing, it can trigger off of pressure. But most it'll trigger off of EKG. But that trigger will trigger the balloon to inflate. That balloon will now remain inflated until a split second before systole, where the balloon will rapidly deflate, decreasing the afterload that the heart has to pump against. Hemodynamic changes that you can expect if you're doing hemodynamic measurements. You'll notice a decrease in your systemic vascular resistance. You will notice an increase in your MAP, but the increase in the MAP is coming from the augmentation, so it's not raising your systolic pressure, it's just raising your diastolic pressure. In reality, it should be decreasing your systolic pressure because of the decrease in afterload, and when we look at the waveforms later, you'll understand that. And with the decrease in perfusion and the, did I say decrease? With the increase in perfusion and the decrease in afterload, you should have an increase in cardiac output. So this is a waveform. It's not a real waveform, obviously, but it's just a drawing that depicts what's actually going on with the balloon pump. We see here, this is the dicrotic notch. This is where the aortic valve closes. Here we have end diastolic pressure with no assistance from the balloon. Here we have our unassisted systolic pressure, no assistance from the balloon. Here, right at the dicrotic notch, the start of diastole, the balloon will rapidly inflate, increasing or augmenting the diastolic pressure to help push more blood into the coronaries. The balloon will remain inflated this whole time. Right about here, right before the next systolic beat, the balloon will rapidly deflate, driving down peak end diastolic pressure. Hence, the next beat will not have as much resistance to pump against, and you will have an assisted systolic beat that is lower than your unassisted systolic beat. Now, these are the things that is very important for the nurses to recognize and report to the provider. This is early inflation, meaning this is not my dicrotic notch. You see my dicrotic notch is all the way down here. This balloon, this heart was still contracting. At the end of systole, the balloon inflated, impinging on the end of systole. So we actually increased afterload in this situation. This is detrimental to the patient because we have the balloon pump in to help the patient. This is actually hindering the patient. Okay? We're still augmenting, we're still getting more perfusion, but we actually increased the afterload on this patient. This here is also something that would need to get reported to the provider. This is not as dangerous. We can see the balloon inflated late. It should have inflated just slightly before or right at this dicrotic notch. It waited a little while, so we got this little W wave. Now, it didn't harm the patient, but we could have gotten more augmentation if we inflated it just slightly earlier. So although this is not dangerous, we could have optimized it a little bit better. Now we'll talk about the deflation of the balloon. Early deflation. This one also is not dangerous, but it needs to get reported and fixed. This balloon pump deflated a little bit earlier. So what happened is the balloon was inflated, and we reached the end. Before we reached the end of diastole, the balloon deflated, decreased the pressure inside of the aorta, and then the heart contracted. So we lost a lot of that afterload reduction, we wasted it. So although it didn't harm the patient, and we did still have some afterload reduction, we could have done a better job. Here, this one is one that needs to be reported immediately. This is detrimental to the patient. The balloon remained inflated too long. So the heart, we had the balloon inflated, and the heart tried to contract, but the balloon was still inflated, blocking the outflow tract of the left ventricle. So this is actually detrimental. I actually severely increased afterload on this patient, increased oxygen demand. Okay? Didn't do anything. I'm still augmenting well. And this is why we need to look at the balloon every single shift, whether it's the provider that does that or us, on 1 to 2. It doesn't matter if we don't think the patient's stable enough to go to 1 to 2, momentarily, even if it's for 5 or 10 seconds, to make sure that this isn't happening. Okay? Because this does happen more frequently than what you would think. Okay? Even on auto. Okay, now this is, well, they were supposed to give me the ability to run these. All right, but this is a normal waveform, and it looks good. We have good augmentation. It looks like I'm augmenting at the right time. And it looks like I have some afterload reduction. I have nice V waves, but I can't really tell because I have nothing to compare it to. So that's why I need to go, oh, here it is. But this is what the waveform would look like. This is what we see on an everyday basis when we take care of an intra-aortic balloon pump. But it's very important that we look at it on 1 to 2, because now we can see that this is where my normal dicrotic notch is, and I'm inflating it right at the right time. I have a nice V wave here. And I also have some afterload reduction. The afterload reduction is the difference between here and here. And I can see it in the numbers. You see that my augmented pressure, which we're hoping would to be about 10 to 15 points higher than my systolic pressure, and it is. This is my augmented pressure, this is my systolic. I'm also hoping that my assisted diastolic pressure is lower than my unassisted. This is where I decrease the afterload. So in this situation, I have, I don't know how much, 16 or 17, or 50, at least 15 points of augmentation. And I have about 7 points of afterload reduction. It's okay. It's good. Here, we can see, you guys can tell what's going on here, right? I have early inflation. This is dangerous. It looks like if I was to just look at this on one-to-one, I may not be able to tell. It might look fine. But since I have something to compare it to here, I can tell that I'm inflating very early, which is detrimental to the patient, needs to be reported to the provider right away. Here, I have late inflation. Let me see, I don't want to skip to the next slide. Okay, good. Here, I have late inflation. This is not harming the patient, but we could be doing a better job in getting more augmentation here. This here, we kept the balloon inflated a little bit too long. This is not really harming the patient, but it's not helping them at all. We actually added a little bit of afterload to this patient. Unassisted was 51, assisted was 53. So this balloon was inflated a little bit too long. Here, we can see that the balloon was inflated a little bit too early. It's not harming the patient, and we do have some afterload reduction, but it's not optimal for this patient at all. It's not going to the next slide. Is there a reason? And I don't know why it expanded, it got bigger. It made a hand there, I don't know why. Okay, oh, perfect. Now it should work. Oh, no, it's a hand again. Oh, no, there we go. I probably clicked on that, right? Oh, made the hand again. Oh, shit. Okay, we're good. Thank you. And then we come back to a waveform that looks perfect. We have good augmentation, we have good afterload reduction on 1 to 2. Once I get this, we will switch it back to 1 to 1. And when you switch it back to 1 to 1, that's what it will look like. This is just one of the consoles, not really that important to look at. Now we're coming to the nurse's responsibilities. The nurse's responsibilities are to monitor the patient's hemodynamics very closely. We need an arterial line. We can't only have the balloon pump line. We need an arterial line to monitor this patient closely. But I do want you to recognize that we should be titrating drips to mean arterial pressure, not systolic pressure, because the systolic pressure that we see on the monitor is actually our augmented pressure. The top number is your augmented, not your systolic. The monitor just recognizes the highest and the lowest number. Okay, so we should be, you can titrate, there can be an order that says titrate to augmented pressure, that would be fine, but it really should be titrate to mean pressure. We need to monitor our heart rate, our rhythm, our cardiac output. Watch for improvements and deterioration once the balloon pump goes in, and evaluate augmentation pressure on the arterial waveform. Okay, ensure that the balloon is inflating properly during diastole and deflating properly during systole. Because we have a catheter in the groin, we have to look for limb ischemia. So should be checking for color, temperature, capillary refill, sensation, movement, and distal pulses. As far as the mobility of the leg should be kept immobile. We can use what are those braces we use? The knee braces that we put on the leg. The head should definitely be less than a 30-degree incline. We can raise the head of the bed to 30-degree incline, but it should be mostly achieved by reverse Trendelenburg. I would feel comfortable going to about 10 or 15 degrees in bend, but really no further than that. Remember, it's not a huge catheter, but it's an 8 French. Complications that can occur, the vascular ones were limb ischemia, hematoma at the site, and bleeding. Remember, a lot of these patients will be on anticoagulation for the balloon pump itself. It's not an immediate need, but if they're going to have it in for any length of time, you should be on heparin. Balloon rupture. If the balloon ruptures, you will see blood in the helium tubing. At that point in time, the balloon should be shut off immediately and removed. Aortic dissection, although that's very rare, we should look for the signs and symptoms of that. Systemic complications could be infection, certainly thrombocytopenia, because we have a balloon inflating, deflating, could be crushing some of the platelets, and embolization. The things that we should chart, besides the trigger, would be the timing of the balloon. Is it 1 to 1, 1 to 2, 1 to 3? Neurovascular checks, alarms and interventions that we've used on that patient. Remember, besides the strip that we print out for an EKG, every hospital, no matter where you work at, you should also be charting a strip from the balloon pump itself, and whether the patient is tolerating it. Caring for a patient with an aortic balloon pump requires close monitoring, strong assessment skills, and an understanding of hemodynamics and mechanical circulatory support. Thanks very much. I'm not going to take up any more time. If we have questions, we can wait till the end. I'd like Mallory to start with the presentation.
Thank you so much. Hello, my name is Mallory Ann, and I am a CCU nurse and a nurse like most people in this room right now. I spent about 8 years between the cath lab and cardiac ICU at Brigham and Women's Hospital before I came over here to J&J MedTech to work with the Impella device. So we have 3 Impella devices as our platform. We have the Impella CP with Smart Assist, which is FDA approved for up to 4 days in cardiogenic shock or up to 6 hours in high-risk PCI. Your RP Flex, which is FDA approved for up to 14 days in cardiogenic shock for RV failure. And then the Impella 5.5, which is FDA approved for up to 14 days in cardiogenic shock. Today we're going to be chatting about the Impella CP as well as the Impella 5.5. So recently, earlier this year, the ACC/AHA have updated their guidelines to talk about what we should be doing for patients who are coming in with an AMI cardiogenic shock followed by a STEMI. So there are 3 classes. You have class 1, which is we absolutely should be doing this. Class 2, which has 2 subcategories, class 2A and 2B, which 2A means there's a randomized controlled trial that says that there is most likely a benefit for utilizing a product or a device, and then class 2B, where there could be benefit, there could be risk, there's just not enough data out there to give us what we need. And then class C, which is we don't recommend using that, there is no benefit. So before these recent guideline changes, the Impella CP and the balloon pump are both sitting at a 2B. So with a new study that came out last year called the Danger Shock Study, there have been some changes to our guidelines. So the Impella is now a class 2A, which means that there's a randomized trial that shows that there could be benefit for utilizing this device with our patients. And then balloon pump is brought down to a class 3, showing that there is no benefit for that. And I'll show you in a couple slides exactly what I mean by that. So how does the Impella work? So the Impella is a device that directly unloads left ventricle. And so by unloading left ventricle, we're going to be reducing our LV-EDP and our LV-EDV. And that's going to help us give forward flow, so we're not backing up, causing pulmonary congestion. And it's going to be increasing the O2 supply while decreasing the demand of the ventricle, because we are kind of taking over part of that workload of the ventricle. And then we know that our MAP follows our forward flow. If we have a sick heart that can't contract and push the blood out, our MAP is going to be low, thus our forward flow is going to be low. So we'll also see our MAP increase by increasing our forward flow, and that's going to help with our end organ perfusion. So I have a little bit here just to kind of show you how the device actually works, and it kind of gives you that image of seeing the blood being pulled directly from the ventricle into the aorta. So you'll see it right there, the blood's leaving the ventricle into the aorta. And the device on the screen right now is going to be the Impella CP with Smart Assist. And I kind of want to briefly show you guys this really wonderful slide. You might see it listed in your charting, or heard people talk about our SCAI shock stages. So this is a really important topic that we as nurses have the ability to kind of help utilize to advocate for our patients if we think maybe they need more support or we need to intervene sooner. These right here are your SCAI shocking stages. You'd be surprised that a class D is going to be somebody with a lactate between 5 and 10, being on one pressor, and or one device. And that is kind of detrimental because we have so many of our patients that we see like this, and if we can intervene by putting some type of temporary MCS in earlier, maybe we can prevent them from spiraling downwards and having a detrimental shock and refractory shock. So I had mentioned briefly this thing called danger shock. So in 2024, the New England Journal of Medicine had put out an article entitled Danger Shock, and it is the first positive shock study since Shock 99 came out, which taught us that by intervening early, we can save more patients' lives. And we're like, yeah, of course we know that, but we didn't know that for sure until that study came out. So this study looked at patients who had AMI, cardiogenic shock, following an MI. They had a lactate greater than 2.5 or a mixed venous of less than 55. Their EF was 45%, and they were in cardiogenic shock due to their STEMI. Patients who had any type of papillary muscle rupture, free wall rupture, they were comatose in the field, or severe RV failure were automatically removed from that trial. And in Europe, their standard of care arm is actually just medical therapy. They've had a balloon pump as a class 3 for quite a bit of time before the US has. So they did medical therapy versus Impella. And in the Impella leg, we can see that there was a 12.7 mortality reduction, which is significant. It's huge, especially with these patients who are in that shocky state. And why is that important? So there have been other studies out there that have looked at different temporary MCS devices and if they have a mortality reduction for our patients. So you'll see we have the balloon pump shock 2 study that did not show any change in mortality. You'll see both the black line is going to be the control and then the red line will be the balloon pump. There was no change in mortality. Same thing with our ECLS or our ECMO shock study. There was no correlation or change really in our mortality rate. But the danger study, you'll see that as the line moves closer to the left side, we're seeing that less patients in that Impella arm were having a mortality event. And if we broke that down even more, we found that patients who were under the age of 77 had an absolute mortality reduction of 20%, which is significant. And then I do recognize that as we have a larger bore access, there are more challenges that can arise. But despite the challenge that can happen with having a larger bore access, more patients still survived. And then with that, the Impella arms were able to clear lactate quicker as well as have a reduced number of vasopressors required to help support the patient. And then just to kind of go over some management for our patients. So when the patients come to the ICU, what are we doing? There is a 1-800 number on the top of that screen right there. It's listed on every single consult. There is somebody who can answer any questions day or night. Typically, you will have a local representative from your J&J MedTech team that will also be at the bedside to help support you. And some things we want to make sure we do. We want to make sure that there is an angle match. So wherever the interventionalist, when the Impella CP had went in to stick their initial stick into the artery, is where the Impella is going to try to sit. So we don't want to make sure it's not too flat or too elevated because that can tent the vessel and cause some oozing and bleeding. Just like our ETTs, we want to make sure we're looking at our centimeter markings every shift and documenting that. There's a 2E Boris valve on there, which is right above the that blue portion, that butterfly there. We want to make sure that's finger tight, and that's going to make sure the Impella can't move in or out. Making sure we have adequate volume status. We recommend a CVP of about 10 or so if we're having suction events, and to make sure we're looking at our urinary output, the color, and the amount that we have for those patients. Other things we want to make sure we're doing or considering is going to be a baseline echo. We want to make sure the Impella is going to be sitting in the middle of the ventricular space. If it's the Impella 5.5, it's going to be about 5 centimeters from your aortic annulus, and the Impella CP will be about 3.5s from our aortic annulus. Along with that, Your patients will have their Impella consult with a bag of our purge solution. The purge solution is going to have either D5W with 25 MEQs of bicarb per liter or 25 units of heparin per cc. And the reason why that is your bicarb has a pH of about 4.5. When we add the heparin, it brings the pH up to about 6.5, and then with the bicarb, it brings the pH up to about 8.5. And that'll just preserve the motor housing for longer, making it be less acidic. So those are all some things that we're doing, as well as checking any alarms. And what's nice about the Impella console is whatever is alarming, it tells you what it's alarming, how to fix it. And that's really nice. It's a very user-friendly face front. Other things to look at too is we talk about an ACT of 160 to 180. I know in the units we're looking more at a PTT or a 10A, and that'll be per your hospital guidelines. When it comes to the neomobilizer here, I think it's a great tool to have as our patients might be ventilated, they might be moving, or when we're turning, we have the ability to maybe reposition accidentally and make it malplaced. And making sure you have a nice dressing on it as well too, so that we are mitigating any risk for infections. So if we're seeing any groin bleeding, or if we are not having distal pulses, or we're finding that one leg is cooler than the other, we do want to make sure we notify our attendings right away, and so that we can kind of work out the kinks and decide if this is a way that we can mitigate any challenges that we spoke about earlier in the previous slides. So what is PAP? So this is a method that we can utilize to help mitigate any type of challenges that we can see in patients leading to adverse events. We as people are preload dependent. Your devices are also preload dependent. They're afterload sensitive, so if we have a really elevated MAP, we're going to see that there's resistance against the Impella device, making it harder for the Impella to give the flows it's meant to give you. And then positioning. Positioning is a critical thing for us because if it's malpositioned, that's when we can see a lot more hiccups happening. So we can have positioning problems and preload problems over by the pigtail over there, and that's going to be inside the ventricle. So we can have positioning and preload problems within the ventricle, and then over on the other side is going to be what's happening in the aorta. We are afterload sensitive, and positioning problems can also be challenging here. And what I mean by that is if you have your Impella malplaced, it can be up against a structure at the left ventricle, and we can have a partially included inlet. And when that happens, it can reduce our flows, and it can cause a lot of shearing for this of the red blood cells. If the Impella is in a ventricle that's really underfilled, whether it's RV failure and we're not able to get the blood from the right side over to the left side, or their volume down, whether it's CVVH, their volume status in general, we're having an underfilled left ventricle. So every time we're contracting, the ventricle is closing on the inlet cage, and that can reduce our flows as well too. And then when it comes to the outflow area, if your Impella is malplaced, say it's at the level of the aortic valve, for example, it will cause a lot more shearing of those red blood cells, and that can cause hemolysis. So if we are able to capture these things quickly and intervene on them quickly, we can mitigate our risk for having any adverse events. So you'll see here we have everyone's dreaded thing to look at, which is going to be that hemolysis looking urine right there. And so if we can make sure our CVP is appropriate, we can make sure positioning is great by echo, we can mitigate a lot of these things that are happening. And like I said, the Impella is great because it does tell you what's going on and how to fix it. And when it comes to these suction events, the first thing we're going to do is reduce our P level, or our, this is basically a set number of RPMs that gives the Impella a range of flows. So we can try to break our suction that way by seeing if that will get it off the side of the wall, or maybe pull a little bit less. The other things that we can do is grab an echo. Make sure that looks good. Look at your CVP. Is our CVP really low or really elevated, showing volume downs or being an RV failure? And then just making sure that we are telling our staff quickly what's going on and try to troubleshoot it on the earlier side. So, spoke about preload dependent. We do worry about the red blood cells shearing. That's going to be a major concern. Look at your wedge if you guys track wedge pressures in your units, or also look at your CVP. And if you're running the Impella with ECMO, the Impella is the inferior device. It's meant to support by unloading left ventricle, not to compete with the ECMO circuit itself. So it's there just to unload the left ventricle. So we want to make sure we're having appropriate P levels to mitigate any suction events and just kind of pull off what the ventricle is going to need. Afterload, if we have a high MAP, maybe we can consider either downgrading the Impella or reducing our pressors if they're on a lot of pressors. They might even need vasodilators to help support the patient during this time. But the higher our MAPs are, the lower flows we'll get. For example, a patient who is on P9 should be about 3.7 liters of cardiac support from the Impella device. Yesterday, I was at a hospital around midnight last night, actually, and their MAP was 107. So a little bit on the higher side, and my Impella flows on that P9 were about 3.2. So they were able to reduce our pressure requirement, get the MAP in a more normalized position, and the Impella flows came right back up to 3.7. So positioning we spoke about before too, it's great just to have the echo at the bedside when the patient's going to come up, just so they can throw the probe on and just take a peek and see, are we in a good position? Do we need to make any changes while interventional is here or while the Impella rep is also available? And then we spoke about this before too, about the echo itself and what's good. So your Impella CP should be about 3.5 centimeters from your aortic valve, and then your Impella 5.5 also should be about 5 centimeters from there. And then I briefly want to show you guys this. I want to keep you guys on track for your timing. So we spoke about the suction events and what to do for here. Over here, we're going to see those P levels and how we can drop it. You're going to use your toggle, scroll down, click in, as long as it is per your hospital policy, or maybe you have to have an advanced provider there to help support you with that. Check volume status as well too, and also check hemolysis labs. These right here are our smart metrics. And so we have two different types of suction events that we can see here. And I like to show this slide just because it can kind of show you the difference between the two suction events. You can kind of almost troubleshoot what's going on where. The top one, the continuous suction event, you have the white waveform, which is going to be your LV signal, and that's a derived waveform from your motor current, and the red line, which is going to be your AO placement signal. And if we see that the AO placement signal and the LV signal have peaks that are no longer meeting, that can tell us that there's a continuous event happening in the ventricle, so the Impella could be partially up against the wall, leading to decreased flows. And then the one below that is going to be a little bit less concerning. So that is telling us that because we are seeing the peaks meet of both of those waveforms, and we are seeing the notch, which is kind of like checking ourselves and mitigating the suction event in that area, it's going to show that there's a diastolic issue. So my LV is really underfilled there. Again, you can see here a little bit what it does, and you can really see the decrease in our flows here. So for that continuous suction event, you're going to see the flows be incredibly low, about 2 liters on the bottom there. And then with that diastolic suction event, they're a little bit less. It's not as significant, but there's still reduced flows and still increasing our risk for hemolysis for these patients. So when it comes to managing our purge system, again, we spoke about the importance of using D5W. We should never be using any saline-based product on our Impella devices. It can corrode the motor housing. D5 only, and either that 25 MMQs of bicarb or 25 units per cc. Here we have our purge cassette. We changed that per hospital policy. Typically, I see a lot of hospitals do it within every 96 hours when they're changing their IV tubing as well. And with that, I want to show you a little bit of that purge animation and how it works. So the purge is basically acting like an umbrella, and as the blood is leaving the ventricle, hitting, going through the aorta out of the outlet cage, you're going to see this purge solution kind of meet up, and how viscous it is going to allow it to have the Impella and any other biological material from reflecting off and not entering the motor housing, so the pump can remain patent. You can see that here with this. And your purge pressure should be between 300 and 1100, with your flows being between 3 cc's and 30 cc's. This right here is your Impella itself, and when we have a high purge alarm, it can mean a couple different things. Typically, patients are on D5W. Sometimes it can be up to as high as D20. So we might want to consider dropping down to a less viscous form of dextrose, whether if they're not on the D5. And then we want to look for any kinks. Is someone stepping on the line somewhere? Is it kinked anywhere? Is our clear side arm bent a little bit? That can all cause those high pressures. And then if we have low pressures, we're going to see that my flows will be greater than 30. I think of it like having a leak somewhere along the line. So check your connections, make sure there is no leak anywhere at all. And I'll also say too, no alcohol-based products should be on the Impella device at all, none of our purple wipes, because that can actually corrode the clear sidearm. And the other thing too is sometimes when these patients are on support on a longer period of time, say they are on an Impella 5.5, for example, as a bridge to advanced therapies, whether it's a HeartMate 3 or it's going to be a transplant, you'll see that it can be really hard to unscrew the purge cassette from the Impella device. As an ICU nurse, your first thought's probably like, let's grab Kelly clamps and try to twist off that way, because that's what I would do with my central lines. We don't want to do that here because that can actually crack the clear sidearm itself. So remember, this is a sugar water substance. So take a 4x4 and then just run it under some hot water and put the hot water 4x4 around the perch clear sidearm, right where that yellow Lurlock is, and then you're going to twist off because it'll melt that sugar water. So what's one last thing just to end on? I want to just kind of go over the basics of how we manage these patients. I want to make sure you have time to ask questions, so I will let it be that.
Good afternoon, everyone. We're going to get started. Our next presenter is Dan Almodovar. He will be presenting Enhancing Patient Outcomes, the Intersection of AI and CABG Surgery.
Hey, good morning. Oh, sorry, afternoon, my time was moved. So we're going to start talking about AI, and that's not aortic insufficiency, in case you're asking. I was asked that, and people thought it was a strange topic. But yeah, we're going to talk about artificial intelligence and its uses in CABG. And the inspiration for this was essentially one of the intensivists that we work with, Dr. Sakuja, is kind of heading up the AI research at Mount Sinai. And after talking with him about AI, it was very disheartening eventually. Everything will be done by AI. Your job, doing lines, doing everything, we'll just put something here. And so I decided that I'd kind of dive into my own little research and look at it and see how we're applying it. And I saw it being applied in my institution. I don't know if anybody here, in terms of where you work, do you guys see it applied where you work? Just by show of hands. Anybody? All right. So I think the most important thing when you're talking about hospitals is to follow where the money goes. And in our institution and across Mount Sinai, they're heavily investing in AI. And so we're starting to see that. It kind of first showed up when we were looking at x-rays, right? There was a preliminary read by an AI program. And that kind of made sense to us because we know a lot of radiologists are sitting at home and making their money and reading x-rays, but why couldn't a program do that? And they actually applied it, and it was being used in the hospital. Recently, we started using a program called Dragon. Well, it's not brand new, but it's essentially an oral dictation tool for physicians to write notes, and that's being done mostly in the outpatient setting, but you can now see it getting incorporated into more and more practices. And recently, there's been some teaching in the hospital in terms of some of the nurses, which usually tells you it's going to be implemented hospital-wide, that are starting to get trained in AI programs, and that really tells me that it's going to be coming soon. When? I don't know. But when you're looking at investments, the hospital is doing it by tens of millions of dollars. So you can just get an idea where this will eventually be going. And hopefully what we'll do is kind of start laying a foundation in terms of your understanding of how AI kind of initially started, and we'll kind of bring it up to modern day. So let's start by some objectives here. So we're going to just go over a brief history of AI, and its progression over time. Along with that, some milestones in CABG and its progression using AI and data. Also, how we're using AI in terms of in the pre-op, intra-op, and the post-op setting. And then we'll start looking at the future and its use in CABG itself, but this kind of applies directly to pretty much all cardiac surgery. So first, believe it or not, the term was coined in the 1950s. So artificial intelligence, the idea was for it to mimic human reasoning. And they started very simply by getting the program to actually learn a game of checkers. Seems fairly simple, but the idea was that it would build upon itself. It would learn from its mistakes and then eventually be able to kind of beat its opponent. They eventually were able to succeed with that. But what made the improvement significant was that in 1958 they invented the microchip. And that was done here in the United States by Texas Instruments. And that, as you know right now, is probably the main reason we progressed with AI, is that companies like NVIDIA, which are some of the most profitable in the world, most of these chips are made in Taiwan, and I think you're kind of familiar with world conflicts in China, and it's wanting to take over Taiwan. There's a specific reason why there's a lot of tension between our countries, because it's needed for all these systems. And so that's why we're in negotiations and trying to prevent conflict, because whoever essentially owns this essentially can just keep the technology mostly to themselves and the advancements. And so it's become a big issue. But moving on, back in the 1960s, in the world of CABG, we had René Flavour at the Cleveland Clinic start using saphenous vein grafts in surgery. And he was a big mentor to many, taught many surgeons. And that, along with the following year, 1968, a gentleman by the name of George Green started using the leaded LAD graft. And he eventually became the director of St. Luke's Hospital, which is actually Mount Sinai Morningside, but that was the previous name. And he became very world famous in using that, and now it's essentially the gold standard in terms of bypass surgery. In the 1970s, we saw progression in technology. We started seeing basic computer models being used, some algorithms allowed us to better understand blood flow dynamics, graft placement, myocardial perfusion. Although these were kind of simple systems, they started building on itself to become what it was today. So in the 1980s and 90s, we had continued expanded research. We had the development of EPIC, which was big. Although it was initially started in 1979, its introduction was in the early 1980s in the outpatient setting. So nobody kind of knew the potential, but it was saw that there was a lot of potential in grabbing data and using it for future use. There were a couple other companies. Most of them were defense manufacturers, Lockheed Martin. All that technology usually moves to the defense sector first, and then we move it a lot of times into the private sector and public for use in terms of like making money, of course. The other major thing that happened was that in 1989, the STS database was started. And that was particularly interesting because it was started in response to the Healthcare Financing Administration, which is CMS. You guys heard Dr. Oz talking about it, right? Centers for Medicare and Medicaid Services. They had released morbidity and mortality data over the years and essentially released it to the public. That wasn't really being done before. And so when they saw this data, the surgeons were actually horrified because it wasn't risk adjusted. So they thought they'd come up with their own system. And that's when they developed that system in 1989. And over the years, we know through doing surgery, what do we use? The STS, right? The risk analysis. And that's how it came to be. And eventually it's something that's progressed over the years to what it is now. And that was essentially the impetus for starting that. And once we did that, we obviously were able to better predict risk predictions, and then we'll kind of move along now to the kind of early 2000s. That was basically improvements upon what was already there. We were better able to predict surgical outcomes, started to do interesting things like being able to predict who is better for on-pump versus off-pump surgery, and then we were better able to start managing patients in the perioperative setting to hopefully optimize our outcomes, which I think has progressed to this day pretty significantly. So it's considered a very safe surgery. If you look back 20, 30 years, a lot of people had a lot of negative connotations. I'm sure you've dealt with family members who are like, my grandfather had it in 1980 and he was almost dead. So now it's considered pretty routine. So now we start getting into, I think, where most people picture AI to be in the past 15, 20 years. And so we start hearing concepts of this deep learning, but the true advancements were when we developed this convolutional neural networks. And that eventually refined the imaging that we used to have these grainy images. And it was difficult to see anatomy. And with the way they started kind of using this layering technique, it allowed much better definition of anatomy. And we were able to see definitive features. And I think one of the key things that happened is we were lucky enough to take part in a trial called the Fast Track trial that Dr. Puskas was one of the lead investigators. And I think the fascinating thing was this trial essentially took the surgeon, blinded him to the coronary angiogram. And he had to base his bypass grafts based on a CTA with FFR using AI technology. So the cardiologist would look at the angiogram, say, okay, this is the other areas we're going to bypass. Now we're going to take, the surgeon will take a look. He will not only decide what to do, but then he's going to perform the surgery. And I thought that was a little nuts, but I was like, hey, let's do it. So 114 patients were entered into the trial across Europe and the United States. And then eventually, I believe it finished in around 2023, and it was shown to be essentially non-inferior to invasive coronary angiography. And I think that was a big milestone right there because it showed that here we have a less invasive procedure that I think most people, if we were going to ask for the two, would prefer to have a CTA. Now, I don't think it's considered the gold standard yet, but it shows you what's possible in terms of just imaging technology. Along with that, we have more AI being able to be used in terms of looking at graphs, looking at graph configurations, and that's essentially helping change the field in itself. If you move on a little further, what are we going to do with all this information that came up, right? How are we going to incorporate it? So in the preoperative settings, we'll start with risk stratification, morbidity, mortality. We want to reduce things like AFib, stroke, graft failure. We obviously want to reduce the risks of prolonged ICU stays, readmission rates, which are incredibly expensive to the hospital. We're going to keep on using imaging and surgical planning just to optimize the patients and their surgeries. And then we have things that are starting institutes like 3D reconstruction models and some simulations. And that's being done now and starting to be integrated into, that's more the surgeon's area, but I think it's fairly interesting. The intraoperative areas, we have things like the Da Vinci robot that's being used, and they have some tremor modifications. The other thing that they're doing is they're allowing the robots to start suggesting a different approach to a particular area in the surgical field. They're also omitting some of the things. If you guys have ever been in the operating room or scrubbed in, you'll notice it can be bloody. There's towels, there's instruments, there's things obstructing. The AI is essentially kind of removing layers to allow you to better see the surgical field so you don't get into an area where you might be able to injure whatever it is that you're working on. This doesn't apply, obviously, just to cardiac surgery, but to all surgery. And I think that's fascinating and pretty important. We'll see better intraoperative monitoring and things that we usually run into, especially postoperatively, things like ischemia, things like bleeding. There should be alerts, at least in the operating room, that these are risks that are possibilities and to hopefully help prevent them before sending this patient who's had a successful surgery to the ICU to where they're going to income all these complications. So I think that's got some promising applications. So post-operatively, and this is where I think some of us are seeing it already being applied. We obviously want to reduce the risk of wound infections, graft failure, AFib once again, which leads to prolonged hospital stays. We have remote telemonitoring, and that's something we're doing right now. And the Apple Watches and stuff where you can do EKGs and you can send them to your cardiologist. I think you're going to see that grow, and eventually you'll get O2 sets, vitals, all that stuff will be sent. And obviously all that is the idea of preventing any sort of complications from happening down the road, but mostly recognizing arrhythmias, possible ischemia, where you might have to go back to the hospital and just have an angiogram, hopefully catch something before something unfortunately drastic happens. The other thing, which I just passed over, was anticoagulation. One of the things they're looking at is optimizing anticoagulation that we put our patients on, most of the time post-op for AFib, sometimes it's tissue valves, reducing the risk of bleeding post-operatively. And that's a very big deal for most of us who've dealt with patients with INRs of 6 or more. So the idea of optimizing the choice of drug and also the dosage of drug. And that, I think, would be revolutionary. You just need the surgeons to listen. That would be the most difficult portion. Kind of moving on from there, we're going to start looking to the future. And right now, currently, we have some virtual reality, being able to kind of essentially look at the surgery you're looking to perform on a patient. That's actually was already being spoken about in the other room. And that was done not last year, but the year before. They had already spoken about that. But I think the real game changer here is this thing called digital twins. I don't know if anybody's ever heard of it before. But digital twins is essentially an exact replica of you in a digital format, anatomically, physiology, all the information that's collected on you, essentially over a lifetime, likely data that will be incorporated when you're using your Apple Watch or whatever. That way, we have almost an exact replica of you in a digital format, and the idea is that we can actually start applying medications to you, see how you would actually possibly react, possibly do a surgery, see how you possibly react before actually doing the surgery on the patient. Now, that requires a lot of data. That becomes there's a lot of ethical concerns regarding that, but I think that's pretty exciting. But I think that's down the road where you're going to see a lot of the technology go. We're continuing to try to better predict any outcomes post-operatively, but we're also going to try to incorporate, or they are trying to incorporate, the health records to get this data, and that once again becomes another concern. And so let's just move right to ethics. So in terms of the future of surgery, I think personalized surgery will be one of those things that is going to become very bespoke, right? We'll look at you, we'll tell you about your coronary anatomy, the things that we're looking to do, what conduits we're going to use. That, I think, is something that you'll wind up seeing in the future. The autonomous robots, were like some robots operating on you, that we start, there's a challenge to that. And that starts to pose a lot of ethical concerns. And that's where we start getting is, accountability, transparency, bias, your consent. And so all those things pose challenges to advancements and will likely need laws to be passed in the future to be able to regulate what can and can't be used. So, what about my job, right? I just told you that Dr. Sakuja is like, we're all done, forget it. They're good. And I don't believe that. In terms of patients who've been spoken to about AI, far majority, greater than 70%, say, hey, I don't want to be talking to a machine. This doesn't seem right to me. And so the optimal thing is using AI to at least help the provider, give them some treatment options that they can speak to the patient about. And that seems to be not so controversial. And so it's there to kind of help guide the care, but not totally take over the care. And that's where I think most people don't want that to happen. But I think more importantly is kind of seeing the bigger picture of what we actually do here in the room in terms of the treatment of patients. Yes, there's all these rules and guidelines that we follow, but we provide a lot of other things that you can't actually replicate in AI, at least yet. So simple things like caring for a patient, providing comfort for the patient, being empathetic, right? You can have to motivate a patient. You have to be able to speak to the family and really help understand what's going on with the patient. Right now, that's not something that AI takes care of. That's actually what you guys do. So will it be incorporated into what we do? I think absolutely 100%. The hospital obviously thinks so. But I think it's more important to say that you guys are absolutely 100% useful as long as we're still working with people. And the future is bright for us, I feel, compared to other fields. But understand that your ability to integrate technology into how you work is going to be important for your future, how would I say this, employment. That's how it'd go. Thank you so much for your time. I appreciate it. Please, if you have any questions. Thank you. Questions? Great. Thank you.
Thank you, Dan. Next up, we have Mallory Montalvo. Oh, no, wrong slide. And she will be presenting Building Excellence in Cardiac Care, a roadmap to becoming a comprehensive heart attack center.
Good afternoon. Our agenda for today is we will review what a CHAC center is and the requirements, information evaluated prior to certification, planning, QI, survey review process, and our SAFER metrics, which lists all of our citations. So what is CHAC certification? It's offered in collaboration with the American Heart Association. It essentially means that you provide care for patients with ACS, PCIs, cardiac surgery, cardiac resuscitation with hypothermia, cardiogenic shock, and we need to refer our patients to cardiac rehab. What are the program requirements? We need to provide 24 hours a day, 7 days a week on-site coverage for interventional cardiology, cardiology services, cardiac surgery, and emergency services. They no longer require to perform at least 400 PCIs per year or 36 primary PCIs. However, our program needs to align with our clinical practice guidelines. We need to implement multiple performance improvement activities related to ACS. We have to adhere to their standardized performance measures and participate in the American Heart Association Get With The Guidelines. This is the patient population that we have to treat: STEMIs, NSTEMIs, ACS of all kind, unstable angina, cardiogenic shock, cardiac arrest with ROS, temperature-targeted management, and cardiac rehab. In order to even apply for this, we first needed to look at our demographic information. We had to look at our clinical practice guidelines, our PI plan, make sure we're adhering to the standardized measure, and submit all of our data. After we applied, we made sure that we socialized our clinical practice guidelines and we had them posted with the main 10 take-home points. And during opening, on survey day, one of the first questions that the surveyors asked us was, how are you adhering to the new 2025 clinical practice guidelines? So we said we are prioritizing ticagrelor over Plavix. We're adding Zetia, and that Mount Sinai Morningside, we use close to 90, I want to say 5% radial access site for PCIs. The Joint Commission, they're here, or they were at Morningside. What they really focus on is performance improvement. The way they explain themselves is we're here to help you, but most importantly, the patients. So they were heavily focused on our PI improvement, which included our scope of PI activities. We had to explain the composition of our multidisciplinary team, which was from the emergency department to the inpatient units, social workers, everything. Our current year for our PI goals, what are we doing in 2025 to make sure we're providing the best care for our patients? What are the activities that we're doing to meet our current PI goals? And within cardiac surgery, how do our performance improvement plan coincide with what the overall organization is doing? So these were our mandatory standardized measures, and these were our non-standardized performance measures. So radial access usage, composite vascular complications, hematomas, length of stay, 30-day readmission, and SSI. So on every unit, we posted our scorecard, and our scorecard outlined the different measures: EKG within 10 minutes, primary PCI less than 90 minutes, EMS first medical contact to PCI less than or equal to 90 minutes, arrival at first facility to primary PCI, ACE or ARB for left ventricular systolic dysfunction, cardiac rehab, ACE and ARB for NSTEMIs, and dual antiplatelet therapy. Then we presented each month and where we achieved it. In red, we highlighted how we did not achieve it, and then we compared what we were achieving from 2023 to 2024. Most importantly were our STEMI algorithms that we had posted in the emergency department. We outlined each algorithm according to if a patient were to walk in, and because we are a receiving center, we had our referring hospital algorithm, which is Mount Sinai West, and it completely outlines what happened when a patient walks in with any type of chest pain. How did we plan for this? We created a timeline. We had been preparing for this since 2023. Finally, in 2024, we buckled down. Majority of our time was spent on our gap analysis. And what a gap analysis is it identifies and addresses gaps between current practices and the Joint Commission's certification standards. And essentially, this process helps organizations assess readiness, highlight areas needing improvement, and prioritize action to ensure compliance with certification requirements. So when we were doing the gap analysis, it was an interdisciplinary approach. We had nursing, we had physicians, we had social work, case management, and PT. So our performance improvement methodology, which the Joint Commission heavily focuses on, we use a Plan, Do, Study Act, which is a structured problem-solving and continuous improvement approach. We use A3s to show how to delineate our PI plan. One of our A3s was prolonged intubation, which we know can increase length of stay in the ICU, increase the risk of pneumonia, and increase the risk of pressure injuries. So when we began this A3, in 2021, our O to E ratio was 1.3. You want an O to E ratio less than 1. Part of this improvement plan was to use SBAR Epic handoff, protocol for standardization of bed utilization, documentation on ET removal, and utilize visual management to identify time of extubation by writing it on the door. And after we implemented all these different initiatives, our O to E went from 1.3 to 0.9, which is good because it's less than 1. Our next PI plan was utilization of the heart score. The heart score is to determine disposition. It's mainly utilized in the emergency department. However, it was not documented. So when a patient would come in with chest pain and a decision was made either to admit or discharge, there wasn't really any documentation as to why the physician was making that decision. Documenting the heart score will show this is why I made this decision. So as we know, chest pain is the most common symptom of CAD. It's also the second most frequent reason why patients present to the ED, and it was before significantly underutilized. However, after this initiation and with alignment with Agile MD, there is an algorithm for the heart score to be utilized. So finally, we had our survey review process. It was 2 surveyors for 2 days. They were all throughout the hospital. One was in the emergency department, the other one would be in the cath lab, then they would go to the inpatient units, then they would go back to the ED. So before they came, they did send us an agenda and it outlined their specific activities. This is a screenshot of it. So on survey day 1, which was our opening, we presented a PowerPoint and it showed our program leadership, the interdisciplinary team, our mission vision, what CPGs we are following, and our overall PI improvement plan. And then there was a question and answer, and then the 2 surveyors reviewed why they were there. They asked us, why did you guys invite us? Why are we here evaluating your hospital? So we had to give them goals and they gave us goals as well. So after the opening, then they did their tracer activity. The tracer activity is majority of their time here, and it was during survey day 1 and survey day 2, and this is when they went all throughout the hospital, interacting with the staff, interacting with the patients, and going through our charts. Then survey day 2, after they did their tracers, then they did a data tracer. This is where we really show our excellence at Mount Sinai Morningside, and we had to meet all these metrics, show the percentages of all of the standardized performance measures, non-standardized performance measures, our action plans. Patient experience was also really, really big, our strengths and weaknesses, and processes used to obtain our data. Survey day 2, after our data tracer, then we did competence assessment and credentialing process, and the purpose of this session was to discuss how the program meets the need for qualified and competent practitioners. The reviewer in the organization will discuss and review the processes for obtaining team members' credentials and information, orientation, competencies, in-services, and our education. Then we had our program exit conference. This is where the surveyors tell you either you're getting the certification or not, and your strengths and your weaknesses, and it's open for question and answers. So our survey dates were April 15th and April 16th. And afterwards, we receive our SAFER matrix. So the SAFER matrix is how they show essentially all of our citations. So if you look on the vertical axis, that's your likelihood to harm a patient, visitor, or staff. It goes low, moderate, high, and immediate jeopardy. And then the horizontal axis is how widespread it is. So is it limited, pattern, or widespread? So if we just focus on the high widespread, it says assessments and reassessments, and that was, which we knew was one of our weaknesses, that was our transradial band assessments and reassessments and our process for removing them. And so when the surveyors, multiple times, they asked us about TR bands. Finally, during one of our sessions, they sat down, they took out a piece of paper, and they wrote down, this is how it needs to be documented for the safety of the patient. The second was our leaders ensure privileges. This was a matter of semantics, I would say. And then as we move down, our other citations were documenting pain assessments, making sure that our discharge instructions align with our ABS, consents, and providing and documenting education to our patients. All right, finally, on June 27th of 2025, we received our Advanced Comprehensive Heart Attack Center certification, and we are so happy about it. Any questions?
I would just like to make a comment. The SAFER matrix is also what the Joint Commission uses for your triannual survey. So every 3 years when Joint Commission comes into your organization, they use that SAFER matrix to see if you have widespread problems, and the more you get in the red, the closer you get to, having a problem with that. So they use that methodology when they come in for your triannual and any type of certification. Up next, we have Christina Choi, who is a nurse practitioner, and she's going to be discussing sternal wound infection after CABG, prevention, early detection, management from a nurse practitioner's perspective.
Okay, good afternoon, everyone. The 5 objectives for today's presentation are, number 1, describing the risk factors and the clinical significance of sternal wound infections. Number 2, identifying strategies for preventing sternal wound infections during pre-op, intra-op, and post-op phases of care. Number 3, recognizing early signs and symptoms. Number 4, differentiating appropriate management approaches. And number 5, explaining the critical role the NPs play. So what is the significance of this? According to the Journal of Thoracic and Cardiovascular Surgery, the incidence of sternal wound infections has actually decreased to about 1 to 4%, but they continue to be associated with increased morbidity and mortality. Although the numbers 1 to 4% may not seem like a big percentage, it's crucial to note that the morbidity rate can be as high as 40% and short-term hospital mortality as high as 20% with deep sternal wound infections. This leads to increased length of stay, readmissions, reoperations, and ultimately increased cost. Not only does this impact all of us financially, but this also decreases the quality of life for our patients. Before we move on to our objectives, I want to go over the types of sternal wound infections. Broadly, it can be divided into 2 types according to the level and the depth of the infection. First, we have superficial sternal wound infection, which involves the skin, subcutaneous tissue, and deep fascia. Next is the deep sternal wound, which affects the muscle tissue, sternum, substernum, and the mediastinum. I also want to mention sternal wound dehiscence here, which is the actual mechanical failure and the separation of the bone. Although sternal dehiscence itself is not an infection, it can provide a route for the infection into the deep tissues, or it can be a manifestation of a deep sternal wound infection. Here we have some images. The first picture is what an average post-op incision should look like. Next, we have superficial sternal wound infection, and the last picture is a picture of a deep sternal wound infection. We have another picture. So how do we prevent this? First step is to identify those patients that are at high risk. And these are the patient-related risk factors. We have diabetes on the list. Poorly controlled diabetics are at high risk due to impaired blood flow, and wound healing and immune function. It's found that hemoglobin A1C above 9 is strongly linked to mediastinitis and mortality. We also have to be aware that non-diabetics with elevated blood sugars post-op are also at risk. Next, we have obesity. Patients with BMIs over 30 are at an increased risk due to reduced blood flow to the thoracic walls. And being in this chronic inflammatory state disrupts the normal wound healing process. Increased soft tissue creates more. Increased soft tissue creates more skin folds where the bacteria can colonize and be introduced to the wound. And increased tissue tension around the wound. Sorry, I can't get the mouse to the other section. It's not going to the other panel. Sorry. No, like to get here. I'm trying to get here. It's okay.
Just scroll down. Is that better for you?
Let's see. Okay, sorry about that. Technical difficulties. Okay, where were we? Increased soft tissue creates more skin folds where bacteria could colonize and be introduced to the wound. And increased tissue tension around the wound edges it creates more shear and traction forces on the sutures. Next, we have COPD. The main reason for increased risk in patients with COPD relates to impaired oxygenation. COPD patients are also at risk for prolonged mechanical ventilation, which can further impair the healing process, as well as the potential to introduce other pathogens. We have renal insufficiency next, which impairs immunity and affects the general state of immune dysfunction, which can increase the body's susceptibility to infections and other complications. Immunosuppression. Patients that are on steroids and or other immunotherapies are at risk due to weakened body's response to fight off pathogens. We have smoking next, which impairs blood flow, oxygen delivery, and immune function, which leads to poor healing. And lastly, age. Unfortunately, advanced age is associated with poor tissue regeneration and higher prevalence of other comorbidities. Next, we have procedure-related risk factors. The use of bilateral internal mammary arteries, it devascularizes the sternum and impairs the blood supply and healing potential. And just as a side note, I wanted to mention the two different techniques in harvesting the arteries, skeletonized and pedicled. Pedicle method is where the artery is harvested with all of its surrounding veins, tissues, and fascia. Skeletonized method is where the artery is dissected from all of its surrounding tissues, leaving only the arteries. This method decreases the risk for sternal wound infection, but poses a greater risk for graft occlusion. And ultimately, it's up to the surgeons. Prolonged bypass time combined with hypothermia impairs the blood supply to the sternum. And duration of the entire surgery is an independent risk factor for sternal wound infection. Longer procedure time increases the overall risk of contamination and tissue damage. And patients undergoing emergent surgeries are often in a more critical condition with comorbidities, which some of them which we mentioned in the previous slide, and may require longer bypass times, and will probably not likely have had time for a thorough pre-op preparation. Next, we spoke about prolonged ventilation in the previous slide. Inadequate skin preparation will increase the risk by failing to reduce the number of bacteria from the skin surface. Now, our role in the pre-op prevention. Once the patient is referred to us and is deemed a surgical candidate, it's important that we start optimizing the patient immediately in order to have a successful outcome. Our role in the pre-op prevention starts at initial encounter. I mostly see patients in the inpatient setting, but also see same-day patients post-cath that may require an office visit. Once I see the patient, I communicate with our outpatient office MPs on what their pre-op needs may be. Glucose control is important. I think we could all attest to this, but many of our patients are not compliant, not because they don't want to be, but many times because they lack the knowledge and deeper understanding of their disease process. It's easy to say, and I'm guilty of this too, that patients not compliant and things are not going to change no matter how many times we tell them. But I think as healthcare professionals, it's our duty to educate and to re-educate and to intervene. We sometimes bring our patients in 1 or 2 days prior to surgery if we know that they need closer monitoring and intervention, such as starting an insulin drip or getting endocrine consult to have them follow the patient throughout this stay and after. And this ties in with medication reconciliation. It is our role to review our patients' med list and verify what their current medications are. Many of our patients have just long lists of medications that may include medications that have been discontinued. One thing to mention here is the increased use of GLP-1 drugs, such as Ozempic, Mounjaro, and Wegovy. It's found that about 1 in 8 US adults are on these GLP drugs for either weight loss, diabetes, or heart problems. Typically, these should be stopped about 14 days prior to surgery, as they can cause delay in gastric emptying and pose an increased risk for aspiration during anesthesia. In our diabetic population, it's important to bridge this anti-diabetic therapy to avoid hyperglycemia pre-op. As far as skin prep goes, clipping hair is recommended versus shaving. Shaving can cause micronicks and cuts in the skin, which can increase the risk of bacteria entering and causing infection. CABG wipes are also recommended to reduce the number of bacteria in the skin, which in turn reduces the risk of infection. We have smoking cessation on the list. I think smoking cessation is important not only in the pre-op period, but just in general. I can't think of one positive thing to say about smoking. Next, I want to briefly go over what preventative measures can be taken during the intra-op process. While in our institution, MPs are not typically in the OR, we could influence adherence to evidence-based protocols such as correct timing of the antibiotics, skin prep, and sterile techniques through procedure and policy. Post-operatively, our responsibilities include maintaining tight glycemic control, support early extubation and pulmonary hygiene, and providing support for our bedside nurses, ensuring dressing integrity, proper wound care management, sternal precautions, and monitoring for early signs of infection. MPs, along with the primary nurses, are often the first to assess the wound. Patient education is crucial, and it should really start early on and not just at discharge. We provide our patients and families with clear instructions regarding incision care. We tell them to avoid creams, lotions, antibiotic ointments, powders, and I tell this to my patients, and deodorants. I still remember we had a patient many years ago that came back with wound dehiscence, and apparently she was putting on deodorant on the wound because it started to smell bad. I know sometimes like things that may seem like common sense to us may not be so common in many of our patient populations. Next, we have activity restrictions. We tell our patients to avoid lifting, pulling, pushing anything above 10 pounds, raising arms above the head or behind the body, and we collaborate with our PT, OT colleagues, and they're just so great at providing education and support. We also talk about showering precautions, which includes no bathing, swimming, sauna. And I know it's hard to imagine being on the beach right now, but I've had patients that got discharged and went straight to the beach and had, he was taking precautions and putting sunblock on the wound, but, you know, maybe 6 weeks to 3 months after surgery. And for women, we also have them wear sports bras at all times, especially those with larger breasts for support. I don't think I added this on this slide, but nutrition and hydration are also very important to support wound healing. Next, we educate on how to recognize concerning symptoms and when to notify the care team. Our patients are discharged with 3-4 different phone numbers with access to someone on the cardiac surgery team 24/7. I've had patients call me at 3 o'clock in the morning because they couldn't sleep. But if we could have the patients access to reach us at all times, and why is this important? And this leads to early detection. Early detection is one of the most important functions. Our average length of stay for post-CABG is about 4 to 5 days, and early onset infections can appear within the first week, but more commonly it's between 2 to 4 weeks after surgery, which means our patients are at home. This is why discharge instructions and education is extremely important. Local symptoms to watch out for include redness, warmth, drainage, whether it's clear or purulent, and separation at the incision site. Pain that seems to be worsening rather than improving is often an early clue. Systemically, fever, tachycardia, or elevated white count may be present, and catching these subtle changes early on prevents progression into the deep infection. So what assessment tools and diagnostic workup do we have available? We rely on consistent documentation and wound pictures to track changes over time. Point-of-care ultrasound can help in identifying fluid collection. Labs such as CBC, CRP, and set rate can support clinical decision-making and monitoring treatment responses. Wound cultures and blood cultures guide targeted antibiotic therapy, and CT imaging is usually required when deep sternal wound infection is suspected. This allows us to see fluid collections, sternal instability, and mediastinal involvement. And unfortunately, even with all these preventative measures, we are going to see patients with sternal wound infections. So how do we manage this? For superficial sternal wound infections, typical oral antibiotics may include first-generation cephalosporins, such as Keflex for MSSA coverage, and Doxy and Bactrim for MRSA coverage. Many of these patients can be treated as outpatient with close monitoring and follow-up visits. Local wound care and assessment will be important in monitoring for extension into the deeper tissues. Management for deep sternal wound infection will obviously be more extensive and more costly. This includes readmission, prolonged IV antibiotic therapy up to 6 weeks, wound vac placement to surgical and plastics intervention, including wound debridement, complex reconstruction requiring muscle flap and sternal stabilization. Next, this is a case study. This is a patient that came to us in his 50s with multiple comorbidities, including obesity. This patient came to us weighing over 300 pounds. Obviously had a very complicated post-op course, including prolonged mechanical ventilation, but eventually was discharged to subacute rehab. And this is the picture right before he left. And within 2 weeks of being discharged, he comes back to us with sternal wound dehiscence and deep tissue infection, which required multiple trips back to the OR for washout, debridement, of course, long-term antibiotics and wound vac and closure with muscle flap. I still have another patient. This image is from a patient with normal BMI with history of diabetes, A1C of above 11, and PAD. She underwent CABG ×3, uncomplicated post-op course, and was discharged on post-op day 5. And this is the picture of her wound before she was discharged. And exactly 14 days later, a patient comes back to us with this. This patient also required going back to the OR with washouts and debridement, ended up with a wound vac and long-term IV antibiotic therapy. And the last picture is 2.5 months after her initial surgery. As we could see from those two case studies, not only does this affect healthcare costs, but it greatly impacts the patient's quality of life. And the reason why we do the surgery is to enhance their quality of life. So what is our role in care coordination? We collaborate with our cardiothoracic surgeons, ID, wound care, PTOT, social worker, and case management colleagues. We ensure adherence to antibiotic plans. We manage our patients, our outpatient NPs, with tracking and monitoring. And we collaborate with social workers and case management to set up home health for home IV antibiotic therapies or wound vac and home care. With early detection, we could reduce the time to diagnose and decrease the progression of the wound, which results in shorter length of stay and reduced mortality and reduced 30-day readmissions. So the three key takeaways from this presentation are: the prevention starts pre-op and continues throughout discharge, and early detection is key, and prompt intervention prevents progression into the deep sternal wound infection. Thank you.
Thank you, Christine. Now we have Dr. Peggy Traynor O'Malley, who's going to talk about alternatives to pain management following cardiac surgery. Oh, what's happening here? There you go.
I just press.
Just you can click here.
Just click there. Okay. Good afternoon. I'm Peggy O'Malley. I'm one of the nurse practitioners on cardiac surgery at Mount Sinai Morningside. Today I'm going to talk about alternatives to pain management. Cardiac surgery is the treatment of choice for many patients with cardiovascular disease. Can this be made bigger? It's too, I can't read.
Oh, it's because I think the way your slides are. I think it's because you have your slides like this. Yeah,
It's too
yeah.
small.
Oh, yeah, this is the last resort of one of me like that.
Yeah, I was thinking that.
So that's
This is the
current
slide
and
up.
next. Current
Can you make
slide.
it? Okay.
And this is the next slide. This is the current slide. You want it bigger? And
little
you
bit.
also have it there.
Oh, okay.
Bigger.
Okay, thanks. Patient concerns following heart surgery are chances of successful surgery, the fear of death, the recovery process, sleep disturbances, discomfort, resumption of normal life, and pain. What is pain? Medically, pain is characterized as an unpleasant sensory and/or emotional experience associated with actual or potential tissue damage. Pain is a multifaceted and subjective experience. It is affected by biological, psychological, and social factors. Pain serves as an indicator that there is an underlying problem. Pain is often referred to as the fifth vital sign. The dimensions of pain that describe the multifaceted aspects of pain are physical, sensory, behavioral, sociocultural, affectual, and spiritual. The introduction of pain occurred in 1995, where Dr. James Campbell presented at the presidential addresses to the American Pain Society the idea of pain being evaluated as the fifth vital sign. The hope was to elevate pain as an essential information leading to proper evaluation and management of pain. The Veterans Association and JACO have adopted the need to address pain. Due to the influence of these two organizations, pain is now routinely addressed in clinics and hospitals across the country. Pain is now a quality measure. The fifth vital sign, pain, is not easily quantified, such as pulse, heart rate, blood pressure, and respiratory rate. Pain is very subjective. There is an emotional component to pain. There is suffering associated with pain and complicates the treatment and evaluation of pain. Uncontrolled postoperative pain leads to hypertension, tachycardia, increased myocardial oxygen demand, prevents functional recovery, many times can lead to chronic pain and disability, impaired ventilatory efforts leading to pneumonia, increases the risk of persistent post-op pain, poor healing, a decrease in the patient's functional quality of life, and many times the patient feels that this is an indication of low quality of care. Physical discomfort from cardiac surgery as a result of trauma and manipulation of the body during surgery, immobility for several days after surgery, physical manifestations of psychological stress. Pain following cardiac surgery is often more intense, many times undertreated, and the occurrence of chronic pain following cardiac surgery can vary from 21 to 55%. Poorly controlled pain leads to increased hospital stay, higher costs, and increased morbidity. Studies have shown a significant correlation between preoperative anxiety and postoperative pain. Psychologically, relaxation leads to a reduction of sympathetic response to pain. leading to a decrease in O2 consumption, BP, heart rate, and respiratory rate. Psychologically, relaxation is an internal component of relaxation that affects pain management by reducing cognitive awareness of pain. Treatment options have usually been benzos and opioids, but now we have complementary therapies. Complementary therapies are non-pharmacological, they're widely available, they're easy to use, cost-effective, with minimal side effects. Complementary therapies is a treatment method that emphasizes the importance of the practitioner-patient relationship, addresses a range of physical, emotional, psychological, social, spiritual, and environmental factors affecting the individual's health. Alternatives to pain management include listening to music, reflexology massage, respiratory relaxation, aromatherapy with the use of lavender, hand massage, acupressure, acupuncture, and massage therapy. Music therapy has been used since ancient times to influence human health. It has been used in hospital settings to reduce pain, stress, and anxiety. It improves quality of life and has been seen to reduce cortisol levels. Music therapy has been shown statistically significant beneficial effects on patients' anxiety, pain, neurohormonal stress response, with the less use of intraoperative sedation and postoperative opioid consumption. There has also been a positive effect in the ICU. Music therapy, again, cost-effective, safe, and can be an independent nursing function and can be easily integrated into routine patient care. Healing through music therapy reduces stress, increases mood, promotes relaxation, and awakens memories. The genres are classical, which is soothing melodies and predictable rhythms that can promote relaxation, ambient that are ethereal and calming sounds that can create a sense of peace. Natural sounds such as birds, water, and wind can evoke feelings of tranquility. Massage therapy addresses both the physical and psychological symptoms of reducing muscular tension, reducing anxiety and pain, leading to increased sense of well-being. One study provided localized treatment to the top of the neck and shoulders, leading to relaxation. One theory why this technique is effective can be explained by Bielowski and colleagues, who suggested that the mechanical force from massage initiates a cascade of neurophysiologic responses from both the peripheral and central nervous system. Massage therapy has been shown to improve quality of life, increase emotional well-being and satisfaction, reduces muscle tension, decreased systolic and diastolic blood pressure, decreased muscle tension, decreased pain, and psychological stress. Massage therapy, again, safe, non-invasive, and has been investigated on numerous populations. It involves an assortment of techniques involving manual manipulation of the soft tissue of the body via pressure and movement. The location of the massage has included shoulders, back, neck, scalp, hands, feet, and legs. The area of massage was chosen by the patient, was the area usually of most discomfort. The massage was the Swedish massage involving the Swedish technique that involves moderate pressure and gliding and kneading movements. Reflexology involves stimulating specific points on the feet. Reflexology, along with massage, has been found to reduce pain. It can release endorphins, providing comfort and relaxation. Reflexology foot massage is useful in chest tube removal. Prior to this massage beginning, the patient was instructed to take slow, deep breaths for 5 minutes. Using the left foot, center 1/3 of the sole on the anterior side with a knuckle under the second toe and the thumb begins the massage. This was started moments before the chest tube was removed. The massage was done in a circular motion and was deep. The massage continued for an additional 10 minutes. Relaxation techniques is another complementary therapy. It involves deep breathing, muscle relaxation, guided imagery, and mindfulness. Guided imagery for anxiety and pain management, you need to find a quiet, comfortable place where that you can relax. You close your eyes and take deep, calming breaths to center yourself. You visualize a peaceful scene, for example, a beach, a forest, and you engage all your senses. Focus on the details of the imagery, including the sights, the sounds, and smells. Allow yourself to feel the emotions associated with this peaceful place. This does require practice to enhance its effectiveness. As complementary therapies become more popular, healthcare providers are becoming more open to their use. Knowledge, skills, and attitude of healthcare team members in the area of pain relief are the factors that will influence pain management methods. The nurse plays a significant role in pain management. Why? They spend more time with the patients than any of the other healthcare professionals. Nurses assess the patient's pain, they implement the appropriate interventions, and they evaluate the effectiveness of the intervention. The nurses and CTs in relation to pain management, it's crucial to assess the nurse's knowledge of the CTs, their attitudes towards the complementary therapies, and their practice. In conclusion, pain and anxiety go hand in hand following heart surgery. Patients' perception of how healthcare providers address their pain impacts their overall recovery, impacts sleep, pain, increased heart rates, appetite, feelings of exhaustion, and other negative effects. Further research is needed on how to address the subjective fifth vital sign. Positive steps have been made using non-pharmacological means to address anxiety and pain. The next slide is a relaxation technique that I've developed with the help of the speech pathologist at Morningside. She has a very pleasant voice, and it's guided imagery, it's music therapy, and mindfulness training. I encourage you to try and do it as she speaks.
The reason we are teaching you this technique is to help you cope with the stress of the surgery and during the recovery process. This technique will focus on slowly tensing and then relaxing each muscle group. You will tense your muscles for about 5 seconds and then relax for approximately 30 seconds and repeat. Close your eyes. Take a deep cleansing breath. Tense your toes. Tense your lower legs. Relax. Balance your thighs. Relax.
It goes on like this. It lasts 8 minutes. It is on the intranet. I encourage the nurses to use it, but sadly, when they put it on the intranet, it's not like a 2-button thing, so it takes a long time, it takes a little bit to find it, but if they did turn it on more, they'd get to it a lot quicker. But that's in how using music and guided imagery, and the idea is to put yourself in that situation, and hopefully it would be a calming sensation. And these are a few references. Any questions?
Okay, now we have Anthony Duncan, who will be speaking about when the bypass patient bounces back, preventing readmissions after CABG in the ED.
Hi, good afternoon, everyone. My name is Anthony Duncan, Director of Nursing for Emergency Services at Mount Sinai Morningside. Today we'll focus on how the emergency department can actively prevent hospital readmission for patients who've recently undergone coronary artery bypass grafting, or CABG. We see these patients often with chest pain, shortness of breath, wound concerns, or vague not feeling well. Every one of those encounters is a chance either to prevent a readmission or to make sure a necessary one is safe and efficient. I'll be walking you through some common reasons for bounce backs, red flags, ED-specific interventions that support safe transition back to home and reduce avoidable admissions. By the end of this session, you should be able to describe why recent CABG patients come back to us, recognize which ones are at higher risk for readmission, and understand ED-based strategies that can either safely return them home or facilitate an appropriate admission. We'll also talk about the importance of good communication with cardiothoracic surgery and cardiology, and how we can use metrics to track our success. So CABG patients are high risk by definition. Most have long-standing coronary disease and often heart failure, diabetes, or kidney disease. They leave the hospital on multiple new medications and lifestyle instructions. It's not surprising that for the first few weeks, they're fragile. So when they appear in the ED, there's a brief window to catch complications early, optimize therapy, and reinforce education, all of which can reduce readmissions. So this slide summarizes the most common drivers in ED visits and readmission. Cardiovascular issues are obvious, so they'll come with chest pain, they'll have a history of heart failure and arrhythmias, but don't forget pulmonary complications and wound issues, especially sternal or leg harvest sites. Also, not every bounce back has a hard medical issue. Sometimes they have poorly controlled pain, confusion about medications and anxiety, and normal post-op sensations are frequent. Those softer issues are sometimes easier for us to fix and can prevent unnecessary admissions. So let's move over to triage. So when we're triaging and evaluating these patients, certain features should immediately raise our antenna for readmission risk. So time from surgery is huge. So someone that is 5 to 10 days out is in a much higher risk than someone who's 60 days out, and that's simply because it's a fresh post-op. Comorbidities like heart failure and CKD also drives readmission, so chronic kidney disease. Don't underestimate social factors. If a patient lacks reliable support at home, can't get to the follow-up, or has difficulty understanding their regimen, even mild clinical issues may warrant admission or intensive discharge planning. So the ED sits at the intersection of inpatient and outpatient worlds. After CABG, once the patient goes home, the ER often becomes the first stop if something feels wrong for that patient. In the moment, we can identify serious complications, but we can also manage small issues before they become big ones. Our decisions around evaluation, treatment, and disposition often direct impact on readmission rates, and more importantly, patient outcomes. So triage is the first opportunity to prevent delays and missed complications. Recent CABG should be a high-risk flag in the system. So essentially, once a patient gets discharged from the inpatient side, you'll put the flag in. When they come to the emergency department, we'll see the flag when the patient registers in the ED that they recently had CABG. And that will help us to expedite the patient through. We should prioritize quick EKGs, monitoring, and early labs, especially in patients with chest pain or dyspnea. Standardization is also very important because it gets us to go through with the protocols, which we do so by order sets, and these reduces variability and ensures critical tests are not forgotten on a busy shift. So one of the most powerful tools we can use is a standardized ED pathway for recent CABG patients. When cardiothoracic surgeries and cardiology and ED leadership collaborate on an order set, we create clear expectations for evaluation and disposition. This reduces both under and over treatment. For example, having set criteria for observation versus full admission for atrial fibrillation with RVR or mild volume overload can prevent both unsafe discharging and unnecessary inpatient days. Heart failure is a major driver for readmission after CABG. So in the ED, we can carefully assess volume status, use bedside ultrasound when available, and start appropriate diuretics early. But equally, what's important is making sure the patient leaves with a clear medication plan and close follow-up. Whenever possible, link them to a heart failure clinic or cardiology appointment, and this needs to be done in the next few days, and spell out exactly when they need to seek help if symptoms reoccur. Medication confusion is also common after CABG. Patients may have pre-existing pills mixed with new ones. They might be overlapping their prescription from a different provider or incomplete understanding of what each drug is for. A careful medication reconciliation can uncover issues that would otherwise drive complications and readmissions. For example, a patient who stopped their beta blocker or they're now doubling up on their diuretics, which can cause depletion of your potassium because it's non-sparing. So whenever possible, partner with pharmacy to help clarify and then give patients a clear, updated medication list at discharge. My colleague before spoke about surgical site infections. Surgical site infections are another significant cause of readmission, and they may be very subtle. So you have to inspect every incision, including the leg harvest site. They also harvest from the lima, but don't assume it was done already. Myocellulitis may be safely managed as an outpatient with antibiotics and close follow-up, of course. But deeper infection or systemic signs should trigger admission and surgical consultation. Before discharge, make sure the patient knows exactly how to care for the wound and what changes should prompt them to call and return. Of course, we're not doing this alone. The best way to prevent readmissions is to function as part of a coordinated team. Rapid access to cardiothoracic surgeons or cardiologists helps us make nuanced decisions. For example, is this a minor effusion and is it safe, where they could follow up outpatient as opposed to an admission, or do we actually need to readmit for drainage? Clear documentation of that shared plan builds trust with the patient and with inpatient teams who can see the chart later. Every ED discharge is also an educational encounter. Even if the visit is brief, we can reinforce what normal looks like and what recovery will feel like versus warning signs. Use simple language, avoid jargon, and ask the patient to repeat back the plan of care. And it needs to be in their own words, obviously. Include caregivers whenever possible. They're often the ones who will notice the early warning signs early at home. Strong education is one of the most Strong education is one of the most evidence-supported ways to reduce readmissions across conditions, and CABG is no different. I just want to say that we won't eliminate readmissions altogether. Some are absolutely appropriate. The key is being intentional in our disposition decisions. Higher risk or unstable patients clearly need admission. Others may benefit from an observation stay to fine-tune medications and watch symptoms. For those discharged, ensure the safety net is strong. So you're going to have written instructions, clear follow-up, and accessible contact information for questions. To know if we're making a difference, we need data. So tracking readmission rates for recent CABG patients, plus the reasons they came back and how they were managing the ED, helps us identify patterns. Regular multidisciplinary review with ED, cardiology, and CT surgery allows us to adjust pathways and educational tools so that we're continuously improving our approach. Here are some practical steps that we can implement at the ED level. A triage flag for recent cardiac surgery. Ensure the team is aware of their higher risk. Dedicated order sets make evaluations more consistent. A simple discharge checklist can catch gaps before the patient leaves. And for higher risk individuals, early involvement of case management and pharmacy is invaluable. To summarize, CABG patients are vulnerable in the first weeks after discharge. They come back to us with predictable set of problems. So there'll be heart failure, arrhythmias, infection, and medication issues. By standardizing our approach, communicating with our inpatient partners, and investing a few extra minutes in education and discharge planning, we can meaningfully reduce avoidable hospital readmissions while still catching the serious complications that require inpatient care. Now it's time for a case example. So I hope you were listening. We have a 68-year-old male that came in, CABG ×3. This was done 10 days ago. He presents with shortness of breath. He has about 5 pounds of weight gain with mild lower extremity edema. Vital signs are stable. Chest X-ray shows mild pulmonary congestion. BEP is elevated. I'll assign a number, 145. Troponin is negative. What ED interventions can reduce his chance of readmission in the next 30 days? I heard medication. I heard diuretics. Awesome. So you definitely want that loop diuretic. Mostly resort to Lasix. Some providers might start off at 40, see how the patient does, and then they might double up to another 40 to settle out at 80, right? What else? Awesome. So, yep. And I think for this particular patient, I wouldn't necessarily move to admit them right away. So I might think about observation status. This patient might be worked up in the ER under observation for about 12 to 20 hours. They might even go to the first or second midnight. All depends on how well they do. So you want to make sure that they have that diuretic in them. You want to make sure that they're doing either ultrasounds, chest x-ray, labs for sure, to continuously monitor, see how well they're doing, and then a rigorous discharge plan where they're connected to, like my colleague said, someone called her at 3 o'clock in the morning with questions. You want to make sure that they have someone that they can speak to with any questions that they may have. All right. Thank you very much.
Next, we have Dr. Michaelia Yemen, who's going to talk about common postoperative complications, part 1.
Hi, everyone. First of all, I was told I have to finish by 3:35, so I may talk super fast. But I'm going to take you back to basics. I'm going to talk about basically clinical problems that we see in the postoperative period. I picked these 4 topics because how many of you are inpatient and how many are outpatient in this room, or a combination of both? And how many of you are in the ICU and the floors? So these 4 topics are the most common complications we encounter in every spectrum of our patient care services. And the reason I picked these 4 is there's preventable things that we can implement on both levels, whether it's outpatient, inpatient, and we can improve our patients' quality of life, but also the way we deliver our care and our surgical outcomes. So hopefully you'll take something from them. And the first, I won't review this for time purposes, but you'll see some of the indications and recommendations, guidelines throughout the talk. First topic and the first section is really going to focus on arrhythmias, which are the most common complications we face. Ventricular arrhythmias are not as common, fortunately, but they're the ones that we fear the most. So starting off with postoperative AFib, as most of you know, it's likely the most common rhythm complication we deal with in our post-cardiac surgery patients. Surprisingly, the way we manage post-op AFib, depending on where you are, it's quite variable. But this is the one area where we have a lot of data available. This chart here shows you the available publications, specifically focusing on postoperative AFib since the 1960s to 2021. There's abundance of data looking at not only diagnosis, but management, prevention strategies, as well as certain surgical and medical measures that we can take. Unfortunately, despite the data we have available, if you go to different centers, postoperative AFib is one of those conditions that's managed quite variably between centers. These are the available guidelines we have throughout the world telling us how we should be managing our patients in the immediate post-op state. And this, I apologize, I have a cough. For coughing a lot today. But this is a recent publication from the UK surveying 31 of their 35 cardiac surgery programs, and they asked the centers, what is your process in managing postoperative AFib? And the UK is much smaller than the US and other countries, so you would think the answer should be uniform. But the questions asked in the survey were very basic. Like, what is your, how do you define AFib? What guideline do you use? Do you have a risk stratification strategy? Do you have preventive strategy? And if you look at the answers here, all the centers actually answered differently. And the bottom here focuses more on risk stratification and prevention strategies. A majority of the centers actually didn't have anything implemented. which is unfortunate because we have a lot of data about this, but it's also not uncommon. A lot of programs do not have a post-op AFib prophylaxis plan in place. And if you take anything away from this talk, what I want you to take is to go to your center and really work on a process to improve and prevent postoperative AFib because it is associated with a lot of complications and it will improve our patients' quality of life and outcomes. For the purposes of this talk, I'll be defining postoperative AFib. Like I said, it's defined variably depending on which guideline you look, but we'll say it's de novo atrial fibrillation that develops after surgery. It doesn't necessarily have to be cardiac surgery. And the diagnosis is if you have an EKG consistent with AFib, meaning you don't have any discernible P waves, you have R interval variations, should last for more than 30 seconds. It can be persistent or paroxysmal. The good things about postoperative AFib is it resolves in a majority of our patients. So after the healing process occurs, most of our patients will likely go back into sinus rhythm and they will remain asymptomatic. The common time we see postoperative AFib is within the first 1 to 3 days. The prevalence of post-op AFib is clearly much higher in cardiac surgery, and we'll go over that, the reasons why, but you also see it in other types of surgeries as well. In our isolated CABG population, and I didn't say this before, but this talk is really about CABG patients. I won't talk too much about other cardiac surgeries. In the CABG cohort of patients, the rate we see is about 20 to 30%. The mechanisms for postoperative AFib are multifactorial. The one factor is patient-specific factor, comorbidities that our patients come to us with. But then you have the added stress of surgery. Surgery causes inflammation. You have oxidative stress, surgical stress. And even though we do this every day, surgery is trauma. It's controlled trauma, but still trauma to the body. So you still have this fight or flight response that's triggered by the act of surgery that causes the activation of your sympathetic nervous system, catecholamine surge, all of which affect your atrial refractory period and increase your risk of tachyarrhythmias and development of atrial fibrillation. This fact is true whether you're having cardiac surgery or other types of surgeries. But unique to cardiac surgery is the heart is being manipulated. You need to patients on cardiopulmonary bypass, which requires cannulation of the atria itself and causes structural damage to the atria and makes it more irritable. You have disruption of the pericardial sac. The heart is in a pericardial space surrounded by a tissue for a reason. So when you introduce cells like red blood cells, white blood cells, these are pro-inflammatory and make the heart more excitable. In addition, the process of cardioplegia. So in most cases, the heart is arrested on purpose so the surgeons can do their part. So that process in itself is traumatic to the heart, and restarting the heart causes what's called a reperfusion, ischemic reperfusion injury, which we know causes or increases the risk of atrial fibrillation. The patient-specific risks that I mentioned before are the common comorbidities we see in our cardiac surgical patients. I won't go through that, all these things, but one of the most, highest risk factors for post-op AFib development is age. So elderly patients tend to be at a high risk for developing post-op AFib. And then there's intraoperative and postoperative factors. Intraoperative, and if you look at the list here, both are markers of severity of illness and complexity of surgery. So the sicker the patient is, the likely they will develop atrial fibrillation. intra-aortic balloon pump is an independent risk factor for developing postoperative AFib. And then complications, if a patient needs reoperation, if they develop organ failures, that in itself, or they need pressors and inotropes for a long period of time, those factors also increase the risk of AFib. If we understand the risk, the idea is hopefully we can develop a strategy to predict who's at risk for AFib and maybe do something about it in advance. And several predictive models have been evaluated. The most recent, I guess, predictive model that seems to be pretty accurate is the CABG score. As you all probably know, this is a predictive model that was created to predict risk of stroke in patients who have chronic or persistent AFib, and it's used to decide when to anticoagulate patients. The same risk calculator is it's actually very important in predicting AFib in our surgical population because it also tells us a lot about risk of structural heart development in this cohort of patients. So we can use this as a predictor. And there are several studies that have validated this. This is an example which I won't go through, but it was a prospective study looking at patients undergoing cardiac surgery. And this study it included 277 patients. 84 of the 277 patients developed postoperative AFib, a rate of about 30%, which is what we expect to see. When the authors went back and calculated the CABG score, 77 of the 84 patients were picked up with this strategy. So it gives you a predictive value of over 90%. So it's a pretty sensitive test. Several studies have also validated this, and you'll see the CABG score being used as a predictor of postoperative AFib when we're trying to risk stratify our patients. Why do we care so much about postoperative AFib, especially if most of our patients are asymptomatic and they revert back to sinus rhythm with time? The reason is it's associated with adverse outcomes for our patients. It increases their mortality, increases stroke risk, increases cardiovascular events, renal failure, but it also adds to the healthcare cost burden quite by a lot of money. One study reported that the cost of taking care of a patient with postoperative AFib is an added $10,000 to $20,000 per patient. If you accumulate that with the amount of postoperative AFib that's prevalent in our patient population, it comes up to be over $1 billion a year we're spending managing this problem. So if we can prevent some of them, not only are we improving our patients' quality of life, but we're also cutting healthcare costs. So now that we've kind of identified what the risks are, can we prevent postoperative AFib? And a lot of the data we have available is actually specifically on prevention strategies. We have pharmacologic preventive strategies and non-pharmacologic preventive strategies. The common ones that have been tried are really looking at the acute factors that I mentioned before and the mechanism of postoperative AFib development. And these are focused on working on inflammation, autonomic activation, catecholamine surge, cardiac excitability, and oxidative stress that our patients are exposed to during the time of surgery. And then there's some wacky ones like, fatty acids. And how many of you give vitamin C in your hospital for AFib prevention? Like we do. So we've seen like a lot of wacky medications being used, but majority of them have maybe some benefit, but cause little harm. This is the recent guideline from the different societies. CCS is Canada, this is the US, and these are Europe, and then NICE is UK. And their recommendation for prevention of postoperative AFib across the board, beta blockers are recommended. Interestingly, there's some that recommend continuation, some recommend initiation of beta blocker as a preventive strategy. Amiodarone is also recommended in most of these guidelines. In some, it's second-line agent, and others, it's only recommended for high-risk cases as well. So risk stratification is very important. And then lastly, other preventive measures that I'll mention later are biatrial pacing and posterior pericardiotomy, which are starting to gain some popularity. What about beta blockers? What do we know, and how do they work? The beneficial effect of beta blockers has been demonstrated by many studies, but we actually don't know which beta blocker to use. In UK, they use bisoprolol. In the US, we use metoprolol, but we don't really know which beta blocker is more effective. But in theory, we should be prescribing beta blockers to our patients. What is fact and well known is if a patient is on chronic beta blocker pre-op, discontinuation or abruptly stopping their beta blocker will increase their risk of AFib by 2 to 3-fold. So we should resume beta blockers as early as possible. The mechanism of beta blockers, you all know, I won't go through, but the role in the catecholamine surge is very important. Beta blockers tend to blunt this catecholamine response. Oh, this is, sorry. The next medication is amiodarone. What's the evidence for using amiodarone? The largest randomized control trial, which was done in the early 2000s, it's called the Papa Bear trial, enrolled patients in a high dose, 10 mg per kg dosing of amiodarone to see if it helped prevent postoperative AFib. It actually was a very positive study, and 50% of the patients treated with this regimen, there was reduction in AFib. But it never really caught on because essentially if you calculate it out, and this dosing was for 13 days, so if you calculated how much amio these patients were getting, it's essentially a 10-gram load, so it's a high amio load that you're giving them. So there was a lot of hesitancy about adopting this recommendation and using it as a protocol. But a lot of centers have used this data, and I think most of you probably come from those centers, where you have your own homegrown version of this protocol where we do a low-dose modified amiodarone to prevent development of AFib. This is Mount Sinai Morning Sites protocol, where we essentially, no drug is without harm, right? So the goal is to make sure you see the benefit of the drug while you're minimizing the toxicities. So the protocol we used is we actually used CHAD-VAS scoring and identified patients we deemed at high risk for developing postoperative AFib. And then we would prophylax those patients with amiodarone. And what we saw was we prescribed amiodarone less often, but we still saw a reduction in our postoperative AFib rate and an added benefit of reduction in our ICU length of stay. Moving on to the non-pharmacological strategies. Several strategies have been evaluated. I think atrial pacing, depending on where your center is, you may try that. To me, if you have A-wires, there's no harm in atrially pacing somebody to suppress atrial arrhythmias. You actually improve their hemodynamics at the same time. So this has been looked at. It has great level of evidence behind it. The recommendation is not that good. We'll talk about posterior pericardiotomy and ablation procedures on the next few slides. But the middle section here, anterior fat pad preservation, so this is a surgical technique, and then Botox. Again, Botox is everywhere, so injecting Botox into the pericardial fat has also been shown to reduce the risk of AFib. And if you work at a center that offers off-pump CABG, that technique itself is associated with reduced risk of postoperative AFib. So posterior pericardiotomy is a surgical technique. Essentially what happens here is the surgeons make a 4 to 5 centimeter incision in the back of the heart and the posterior pericardium. And the idea is by creating this incision, you are making sure that you don't get buildup of pericardial effusion, you don't get retained blood. We know it's an irritant and then causes inflammation. And then by doing this, we hope we reduce inflammation inflammation and reduce the risk of a post-op AFib. There was a single-center trial done at Cornell, which enrolled about 420 patients and randomized them to posterior pericardiotomy or no intervention. And in this cohort of patients, the group that had this procedure actually had a 50% reduction in their post-op AFib rate compared to the control. But there was an added bonus that these patients never developed pericardial effusions post-op, and the procedure did not have any adverse events or complications. So I know Dr. Puskas used to do that routinely, and there are some surgeons that do that routinely as well. But this is a procedure that's easily done, doesn't cause harm to patients, and definitely reduces the risk of postoperative AFib. I'll skip this slide for time purposes. The new, I think, exciting thing on the block is prophylactic pulmonary vein isolation. So in the world, the cardiology world, when patients develop a recurrent or persistent AFib, the definitive therapy that they're offered is ablation procedures. So the question here is, what if we did prophylactic pulmonary vein isolation at the time that they're undergoing their cardiac procedures? And this is a small feasibility study that was published last year. It enrolled about 62 patients. Most of these patients were undergoing isolated CABG procedures. The important thing in this study is the CHADVAS score of this cohort of people was greater than 4. So these are the high risk patients for developing postoperative AFib. So 29 patients were in the treatment arm where they received their index surgery, plus they had bilateral pulmonary vein isolation and left atrial appendage ligation at the same time. The control group underwent their just routine planned surgery. And the stroke rates were significantly lower in the treatment group. Only 2 of 29 patients developed postoperative AFib compared to 55% of the patients in the control group. This may be something where we're going to see more often. How many of you do conversion? Have you heard of conversion procedures? The new way of doing ablation, which is epicardial instead of endocardial. It's becoming very popular, and it's very easy to do compared to the conventional ablation procedure. So I think with this new technology, we may be seeing more of this being intervened, at least for the high-risk patients, as part of our preventive strategy. So that's the idea of preventing it. What if you tried everything and our patients, majority of them or some portion of them end up developing AFib anyway? So what can we do and how should we manage them? So the question is, do you do rate control, rhythm control, or both? In clinical practice, we end up doing both, but is one advantageous over the other? And cardiologists love their trials. There was a trial comparing rate versus rhythm control called the AFFIRM trial, and patients, non-surgical patients with AFib, actually rate control did better. Rhythm control was associated with slight increase in complications and offered no survival benefit. In this study, the same question was asked in the cardiosurgical population. So should we do rhythm or rate control? And the result was similar to the AFFIRM trial. There was no statistical difference between the two, but there was a slight trend towards positive outcome when we had rhythm control in these subset of populations. And the rhythm control here was amiodarone, rate control, and early cardioversion. The patients in the rhythm control achieved a stable heart rate and converted to sinus rhythm earlier as compared to the group in the rate control group, in the rate control treatment arm. In addition, we can really tease out if anticoagulation initiation was different because per protocol, all patients with AFib, recurrent or persistent AFib for greater than 48 hours were started on anticoagulation. But in real-world practice, it may also impact the need for anticoagulation if we're aggressive about rhythm. Which leads me to the next question. So once our patients develop AFib, the next thing we worry about is should we or should we not anticoagulate them? This is not a simple question because you're talking about anticoagulating a patient who just had a big cardiac surgery. There's always bleeding risk to consider. And this question is still unanswered, and these are the recommendations from the different societies, which give it a 2A at best recommendation. But if you look at the evidence backing, most of them are expert opinion. There is no data to suggest whether or not we should be anticoagulating these patients. The best, I think, guideline that we have is actually from the Cleveland Clinic, which incorporates the CHAD-VAS-2 score, which is really meant to, the question of using this is really to decide on anticoagulation for non-surgical patients. So it incorporates the CHAD-VAS-2 score, and if you're a low risk, then don't anticoagulate because their risk of developing AFib is small. If they're higher risk with a number greater than 2, then depending on the time, if they're an AFib recurrent or persistent AFib for greater than 48 hours, they should be anticoagulated. And the most important thing about this algorithm is they routinely do serial echoes on their patients during the first week to make sure they don't have complications of pericardial effusion, and that's something I think each center should incorporate. In terms of long-term anticoagulation, if patients revert back to sinus rhythm within 4 to 6 weeks, they shouldn't need lifelong anticoagulation, obviously. If they're in persistent AFib, they should remain on anticoagulation. But now we have fancy tools, especially with the atri clip. Left atrial appendage clipping is becoming quite common. So what's the evidence behind that? And is there any, evidence out there to suggest we should be prophylactically doing left atrial appendage clipping? The first study was from 2018, which did surgical ligation as a prophylactic measure for preventing strokes in our post-cardiac surgery patient. And this study actually showed improved outcome, decreased stroke rates in patients who underwent prophylactic surgical ligation of their appendage. Then the same question was asked in the ATLAS trial. The ATLAS trial is more of a safety trial. It's by the makers of AtriClip. They risk stratified their patients based on the CHAD-VAS score. So patients who were deemed high risk for a stroke were enrolled in prophylactic left atrial appendage clipping, and the results showed, it's safe to do this procedure. Not a lot of complications were seen, and it definitely reduced the risk of stroke. And now we have the LEAPS trial, which is the next generation, looking at a large randomized control to see if the same results can be replicated from the ATLAS trial. So hopefully we'll see if prophylactic left atrial appendage clipping will benefit our patients. In addition, I think the LEAPS is also going to look at the need for anticoagulation once you do left atrial appendage clipping, because we still don't have an answer. If you undergo left atrial appendage clipping, most centers still anticoagulate their patients. So that question still remains unanswered. For those of you that don't have a AFib prophylaxis protocol, the ERAS has published a turnkey order sets in 2023, which gives a good guideline of how to handle post-op AFib, starting from that preoperative phase, and I think this is a good place to start. The only, concern in this guideline is they actually use the Papa Bear recommendation, the 10 mg per kg per day recommendation of amyoprophylaxis, which may make a lot of people uneasy. But there's a lot of publication out there looking at a modified low-dose amiodarone as an alternate treatment or a prophylactic regimen. So I think this is a great place to start if you don't have a process in place at your institution. To summarize, postoperative AFib is very common. It occurs in about 30% of our patients. I think CHA2DS2-VASc score should be part of our screening tool for a majority of our patients. It will help us risk stratify our prevention strategies. The two preventive medications available are beta blocker and amiodarone. I think the concern for drug toxicity limits amiodarone use, but if you use the CHA2DS2-VASc score and use low modified amio prophylaxis regimen, the benefits outweigh the harm. In my opinion, non-pharmacological techniques like posterior pericardiotomy, and Dr. Preskis is here so he can chime in, and atrial pacing are beneficial. They're associated with little to no harm, so we should do them as often as possible to prevent AFib. In our cohort of surgical patients, we should strive for rhythm control as early as possible, in addition to rate control, but we should really try to get our patients into normal sinus rhythm as early as possible. The question of anticoagulation is still out there. Who should be anticoagulated? I think we should incorporate the CHA2DS2-VASc score to make this decision, and not to forget to order serial echoes on patients that we anticoagulate, because pericardial effusion is a big complication, and as you know, reoperations are a big adverse outcome for our patients. So that's AFib. Do I have time? No, so I'm going to stop here. I will stop here.
But I am now the Senior Nurse Manager for the Cath Lab, EP, and the Arrhythmia Institute. Radiation. Thank you, Interventional Radiology. I was formerly the manager of the cardiac surgery ICU over at Mount Sinai Morningside, and this is the journey that I took with all my team members to achieve silver. This is our agenda for today. We'll go over Beacon Award of Excellence, an overview of what the cardiac surgery ICU was, our journey to Beacon Silver, some of the key strategies that we used for obtaining silver from bronze to silver, strengthening our evidence-based practices based on what we received information back from the AACN, our enhanced clinical outcomes, some broader staff engagement that is required by the AACN in order to get the award, our next steps, and of course our achievement into silver. One second here. Where am I? Yeah. I can see.
No, we can't see.
Thank you. Forgive me. So, the American Association for Critical Care Beacon Award Excellence is a prestigious recognition awarded to units that demonstrate excellence in nursing care, leadership, and patient outcomes. It highlights the efforts of hospital units that have made significant improvements in patient care and provide an environment conducive to optimal patient outcomes. The award is given for 3 years, after which any unit can reapply to maintain their status and move forward to the next steps. There are 3 criteria that the AACN uses to evaluate during this award submission. One is leadership structures and systems, which evaluates the effectiveness of leadership that promotes quality care, appropriate staffing and staff engagement, ensuring adequate staffing levels and high staff engagement, effective communication, knowledge management, and learning, which is promoting continuous learning and ensuring communication and knowledge sharing within the unit, evidence-based practices and processes, the incorporation of the latest evidence-based practices into a patient care area, optimal outcome measurements, which is data demonstrating improved patient outcomes, including critical outcomes, patient satisfaction and safety, a healthy work environment, establishing a healthy, supportive, and safe work environment for staff, contributing to the better care for our patients. The Beacon Award has 3 levels. Let me go back, sorry. The Bronze, which honors units demonstrating progress in the path towards excellence. Silver, which is considered excellence, honors units that meet high-quality standards in care, safety, and patient outcomes. And Gold, which is sustained excellence, celebrates units with the highest level of sustained excellence over time. Next, I'll discuss an overview of cardiac surgery at Mount Sinai Morningside. So the 6 East unit, or Mount Sinai Morningside, is comprised of 495 nonprofit community teaching hospital, acclaimed for excellence and quality clinical care. Mount Sinai Fuse to Heart at Morningside provides world-class patient care to a diversified urban community in the Upper West Side, Harlem, and Morningside Heights in New York City. Mount Sinai Morningside Fuse to Heart is a hospital distinguished program for unrivaled diagnostics and curative measures designed to identify, treat, and prevent heart disease. Through the collaboration between the cardiology program and cardiac surgery program, Mount Sinai Fuse to Heart at MSM has expanded to great lengths. The United States News Best Ranking has designated Mount Sinai Fuse to Heart as number 17. The Mount Sinai Heart Division also possesses a 3-star CABG rating from the Society of Thoracic Surgeons and has earned gold recognition for STEMI, non-STEMI, and heart failure through the American Heart Getting with the Go guidelines. And most recently, we received comprehensive heart attack certification. 6 East has 2 types of units. It's a combined unit with 11 beds designated to the cardiac surgery ICU and the 15 beds dedicated to the CICU. It's also a primary care center, which was given to us in 2023. So in 2020, 6 East was awarded the Bronze Beacon. As a team, we felt invigorated by this distinction to showcase our key achievements in the development of our patient-centered care model, implementation of safety protocols and patient care guidelines, and the quality of care we deliver to our patient. With our next application submission, we've set our goals even higher. After we received feedback from the American Association of Critical Care Nurses, we set out to improve our metrics and quality outcomes, establish professional development and staff recognition programs, and foster a culture of shared governance and innovation. 3 things we knew we had to improve upon based upon the feedback from the Beacon Bronze submission was to strengthen evidence-based practice through utilizing our CABG pathway more efficiently, enhance clinical outcomes such as surgical site infections, improve nursing quality indicators, and finally broaden our staff engagement through the development of our unit-based practice council. So some of the things I'll discuss next are strengthening our evidence-based practices. The CABG pathway are specific interventions geared towards post-operative days. By achieving these daily patient goals, we aim to increase mobility, decrease pain, initiate nutrition, decrease length of stay, and increase patient satisfaction. We recognized that we needed to include preoperative interventions alongside intraoperative improvements and postoperative enhancements. Preoperative updates. The original plan, the original pathway was missing the entire preoperative component, so the pre-op work was included. It included risk stratification tools such as the STS scoring and the CHADVAS score. Also included key reminders such as avoiding specific medications, strict glucose control, and extensive pre-op education component for our patients. Intraoperative improvements included standardized use of the class 3 antiarrhythmic medications such as amiodarone to reduce atrial fibrillation risk and preemptively reducing pain by utilizing other agents reducing narcotic use postoperatively. Post-op enhancements included increased focus on enhanced recovery protocols like multimodal pain management, promote early extubation in our off-cup pump CABGs, early ambulation, and strengthened infection surveillance and preventative measures. Standardized pathways such as the CABG 2.0 has resulted in improved recovery times, decreased complication rates, improved patient experience costs, and cost savings. We reduced our length of stay in the ICU by improving its capacity and restoration of and resource utilization. We lowered post-operative complications by nearly 30%, such as reducing atrial fibrillation, infections, and blood clots. We improved recovery times utilizing fast-track extubation and early ambulation, which enhanced our overall recovery speed and reduced our hospital length of stay. We had better patient outcomes, improved surgical site success rate and safety. There was a higher adherence to prescribed discharge medications and follow-up care. We had an increased patient satisfaction overall. Patients reported better pain management, quicker mobility, and overall positive care experiences. We reduced cost savings we had fewer complications in the ICU, we had shorter stays, and a more efficient discharge planning. We improved team efficiency by enhancing communication, collaboration, coordination, and execution of initiatives to provide excellence in patient care. Some more surgical site enhanced clinical outcomes we had were Mount Sinai implemented a comprehensive strategy to reduce and sustain low surgical site infection rates. This approach involved reviewing compliance with surgical site care protocols, optimizing glucose control, and enhancing patient education. Antibiotic therapy played a pivotal role, with the first dose being administered prior to skin incision during the intraoperative phase. The 6 East multidisciplinary team works closely together to successfully minimize the risk of SSI during hospitalization and well after discharge. The SSI rate dropped significantly to 0.19 compared to the national benchmark of 1 during this time period when we were working on the bronze, or the silver, I should say. The Mount Sinai Morningside Fuse to Heart Cardi Bundle focuses on preventing catheter-associated urinary tract infections through evidence-based practices, including strict adherence to aseptic techniques during catheter insertion and maintenance. Key components also emphasize timely removal of catheters, routine assessment of necessity, and comprehensive staff and patient education. The CARDI per 1,000 catheter days remained 0 from quarter 21 to quarter 23 at this time during this submission. The National Database of Nursing Quality Indicators national benchmark showed a 0 for this period. The NDNQI national benchmark is 1. 6 East was 0, which is below the national benchmark. 6 East continues to aim for a 0 occurrence as here in quarter 2 of 2025. From 2021 to 2023.
Sounds like they're fighting.
Do I need to go there?
No.
What are you laughing at? Collapsing per 1,000, let me start all over again. From 2021 to 2022, CABG per 1,000 central line days data reveals that 0 incidents except for Q3 in 2021, and in 2022, Q3 was over 2.2. The nurses understand the risk of infection is higher the longer a patient has a central line. As part of all of our pathways, the nurses discuss on rounds the need for a central line. Understandably, it is recognized that sometimes a central line are the only option. The CABG bundle instituted is designed to promoting strict adherence to aseptic insertion techniques and proper maintenance of central lines. Core elements include maximizing better precautions, daily assessment of line necessity, and ensuring prompt removal of unnecessary lines to minimize infection risks. Broader in staff engagement, what did we do? We developed our unit-based council. We were one of the first at Mount Sinai Morningside to do so. And what we did was to try to promote evidence-based practices by discussing these during the unit-based council meetings. Recognize and reward the exemplary work that 6Cs had done. Work on quality improvement initiatives, what the unit has been doing tirelessly for the last few years, and encourage staff engagement. One of the things that we worked on early on when I was the manager were a virtual comment box, which allowed staff to just put in information which they need to improve the unit, a broken equipment pathway. It was once we became a stroke unit, maybe a EEG, rapid response EEG project, an assignment tracker, as well as a supply conservation project. One of the things that we did in order to operationalize and keep our equipment better was try to manage where what broken equipment we had. It was scattered all over the unit. We tagged these things, assigned them to a spot, had specific times in which the NAs could go bring them to Biomed and have us keep a book to track where our equipment was. Small projects, but got the staff engaged. Our next steps, what were our next steps after doing all of this work? We prepared for our application, obviously submit that application. We remained hopeful, and we waited a long time. Finally, February 16th of 2024, we were awarded the Beacon Silver Award. Some of the future things that we're going to work on is sustaining this while moving forward. We have to maintain the civil status. We've identified areas for improvement and we'll work on them. And of course, our long-term goal is to next apply for Beacon Gold. Well, that's it, everyone. Thank you.
Any questions, comments? They're having fun over there. They're having fun. So I just wanted to make a comment when you saw the NQNDI slides. You know, this is also very important for magnet status as well. So you have to remember that these things are not about perfection, it's about striving for excellence. So to have that expectation that everything is always going to be the benchmark of 0 is not realistic. So what magnet status looks at, they look at that NQNI data, and they have to make sure that 5 out of the 8 quarters, you're less than the benchmark. So there are areas where you can be over the benchmark, because you can't be 2 years of always perfect. Things do happen. You do everything perfectly, follow the pathway. So just remember, it's not about perfection, it's about the pathway to excellence. So it's 5 out of 8 quarters, and most organizations now are either magnet status or they do want to be magnet. So these things are really important when you go on your magnet journey in your organizations. All right, so we have next up, Dr. Michaelia Yemen is back. She's back. Is this the right one?
Sorry, people thought I was leaving earlier, but I had to finish at 3:35 because we needed a break. I think that's the one I did already.
This is the one.
Okay. The other one is... But I'm back. Okay, so we are going to continue on part 2. So we finished arrhythmias. In this section, I'm going to try to tackle these 3 topics, which may be a little challenging, but we'll see. So starting off with neurologic complications. This is another subset of categories which is common in our post-cardiac surgery patients. Neuro complications, we typically think of stroke, but there's a variety of neurologic complications that affect our patients. It's a mix of both central nervous system issues as well as peripheral nervous system issues. I won't talk about the peripheral nervous system complications, but just for your information, it's not unusual patients get mononeuropathies, especially from harvest sites. Phrenic nerve injury is very common, and then in our severely ill patients, we see critical illness neuropathies as well. But focusing on the central nervous system problems, I'll talk about strokes and post-op cognitive disorders. Stroke rate in our isolated CABG population is about 3%, and there's data to suggest off-pump CABG utilization may decrease this risk, and we'll briefly review that data. In the postoperative cognitive disorders category, the common issue we see is delirium, but there's also an entity called postoperative cognitive dysfunction, which can actually leave our patients with a long-lasting cognitive disorder. And there's a thought these two are a continuum of each other. The mechanism of these disorders is still unknown, but there's data to suggest as part of the surgical process, there's some trauma to the brain, including neuronal death, neuroinflammation, and again, microemboli, especially that gas embolic, I'll talk about gas emboli, that may be playing a role in the development of this disease process. So strokes, the pathogenesis of a stroke in most of our cardiac surgery patients, usually it's ischemic stroke that we see, and it's commonly embolic, but you can see ischemic strokes due to hypoperfusion as well, especially when patients are having complicated courses in the OR. Despite our patients being exposed to high doses of anticoagulation in the OR, you rarely see hemorrhagic strokes in this patient population. So ischemic stroke is really the one type of stroke we deal with. Majority of strokes are recognized upon awakening from anesthesia, and the thought process is intraoperative microembolization is the cause of strokes for our patients. This is an elegant study that was done in 2004 proving this point. They used a specialized, what's called a transcranial Doppler. They monitored 45 patients undergoing different types of surgeries. 15 patients were undergoing off-pump CABG, 15 patients were undergoing on-pump CABG, and the remainder 15 were undergoing complex open cardiac procedures like valves and aortas. And throughout the entirety of the case, they monitored these patients using this device at the bilateral middle cerebral artery. This ultrasound not only picked up the number of emboli, but it was also able to differentiate whether the embolic event was gas or solid. The results are shown here. The middle total median is the number of embolic events that was picked up with this device. And the off-pump CABG patients, a median of 40 events were picked up. And the on-pump CABG patients, 275 embolic events were picked up. And then the open procedures, which include valve and aortas, over 800 embolic events were picked up. Majority of these embolic events were gaseous, and so we see, we don't really account for gas emboli, but it's very common to have gaseous emboli during cardiac procedures. In terms of solid emboli, again, less solid emboli was seen with off-pump CABG, but when patients were undergoing complex surgeries and surgeries that require cardiopulmonary bypass, you do get some solid embolic events, and the timing of these solid embolic events was actually crucial. it tended to concur with times during the surgery when the aorta was being manipulated, either during cross-clamping, coming off pump, or cannulation times. So what this study tells us is embolic events are very common during cardiac procedures. They tend to occur, especially the solid ones, during aortic manipulation. And if we can offer our patients procedures that avoid these two factors, we may decrease their risk of stroke. So moving on to risk factors of a stroke in our CABG population, this table here kind of shows you the common risk factors that predispose patients to stroke events. But the main risk factor is actually prior history of a stroke, because these patients have had a stroke already and they're predisposed to have recurrent strokes. Severe peripheral vascular disease, especially carotid disease, history of atrial fibrillation, and again, bypass use seems to be a big risk. The routine preoperative tests that we do, like carotid ultrasounds, echo, and sometimes brain imaging, also help us risk stratify these patients. Unfortunately, we don't have any preventive measures to counteract the risk of stroke. The only thing that we can offer patients is risk stratify them. And again, risk stratification is also not that easy, but the routine like STS score and Euro score that we calculate in the preoperative period sometimes help us identify patients that may be high risk for stroke. And for those subset of patients, it's really important to make sure they don't have alternative modes of therapy. This chart here shows you the rate of stroke between percutaneous procedures and open surgical procedures. So if a patient can undergo percutaneous procedure, they'll have a lower risk of stroke. So for potentially high-risk patients, this should be something that's considered. I mentioned before avoiding cardiopulmonary bypass, and there's some data to suggest off-pump CABG also decreases the risk of stroke. The largest multi-center randomized controlled trials, which are now relatively old, comparing on-pump versus off-pump CABG, actually looked at the specific data. Stroke rate was an endpoint that they were assessing for. Unfortunately, as you guys may know, these randomized controlled trials did not show any benefit in doing off-pump over conventional on-pump CABG. But for those that know these details, these studies in detail, there's a lot of criticism in terms of how these studies were designed. There was a huge crossover from the off-pump into the on-pump category, which implies majority of the surgeons that were doing this procedure may not have been technically, adequate in completing the task. So there's some criticism, and we know, at least if you work in an off-pump center, it's a very technically challenging procedure that you can't do. You won't see the benefits if you do it once in a while. You have to fully commit and do it all the time to see the benefits of off-pump technique. So that was the criticism to these studies. Follow-up of the same question was asked, really focusing on data from high-volume centers that have a lot of experience with off-pump technique, and the same questions were asked. Is off-pump better in terms of some outcomes like stroke and AFib? And when you look at centers that do high volumes of off-pump CABG, the stroke risk is definitely lower. So that's something that we can consider if you work in a center that does a lot of off-pump CABG procedures. But even within off-pump CABG, there's, the challenge of comparing conventional CABG to off-pump CABG is there's so many variability. Even the off-pump technique, there's various ways that the surgeons do it. The three techniques are, conventional, what we call conventional off-pump CABG still requires cross-clamping, side clamping of the aorta. But now you have these techniques that are called clampless techniques, where you either use a specialized device that's called a proximal anastomosis device, or a technique that's called no aortic approach, where your conduits are coming off the bilateral mammaries, which completely avoids manipulation of the aorta. So the study, what they did is they compared different types of off-pump techniques to see if the stroke rates were lower when you approached the surgery in this way. And the results showed 60% reduction when patients underwent no aortic touch off-pump CABG. So at centers that do this frequently, this may be an option that our patients could benefit from. So, like I said, we can't really predict or prevent strokes, but we need to understand how to manage patients once stroke happens. The challenging part is majority of the strokes are picked up at the time of awakening from anesthesia. So our patients may be intubated, they may be partially sedated, or they may have other medications on board, which makes diagnosis challenging. If you have a focal deficit, then obviously you make the diagnosis. But a lot of complications that are associated with cardiopulmonary bypass, as shown here, mimic strokes. So we don't really know if their symptom is secondary to a stroke versus they're suffering from other complications. On top of that, stroke is a quality metric. So we can't just be scanning everybody, because if you pick up things that are not strokes, you still end up getting dinged, and your program will be impacted by these measures. So it is a bit challenging managing and diagnosing strokes. But if the suspicion of stroke is high, the algorithm should be you activate your stroke team, the patient should get urgent or emergent scanning, starting off with a non-con CT to rule out hemorrhage, and then that should be followed by a CTA or CT perfusion to rule out large vessel occlusion. Majority of the time, there's really nothing we can do except the instances where a patient has a large vessel occlusion. Because the recent studies, the DAWN study and the DIFFUSE-3 study, have actually shown us that several years back, the window for endovascular intervention was 6 hours. So you have door-to-balloon time for CABG. You also have door-to-needle time for stroke. So it used to be you have to give them a TNK or thrombolytics within a certain period of time. Same way, you have to intervene endovascularly within a certain period of time, and that cutoff used to be 6 hours. For our patients, that again was an issue because we don't know where their last known normal was. But now that window is expanded to 24 hours, so even if they wake up and we know what time they went to surgery, so time 0 starts at the time they went to the OR. So you have to take that into account when you're diagnosing the strokes, because if you are within that 24-hour period and they have a large vessel occlusion, endovascular intervention is a treatment option for them. But for the majority of our patients, it ends up being medical management because they're not candidates for thrombolytic therapy. So it's either medical management or endovascular intervention that we can offer them. So strokes, to summarize, can occur in about 3% of CABG population. Ischemic stroke is what we see often. Risk factors are shown here. STS score is very helpful in identifying patients that are at risk. There's really not much we can do about prevention short of risk stratifying patients and offering either percutaneous techniques or off-pump CABG as an option to decrease the risk of stroke. And then management, as we discussed, is early diagnosis, and don't forget to reach out to your neuro-IR to have early intervention for patients that may have large vessel occlusion. The next topic is delirium, which I'm a little delirious right now, so very appropriate. So delirium is a huge issue, especially in the ICU for our patients. The diagnosis or the clinical symptoms of delirium are shown here. It's really impairment in cognitive function, disturbance in consciousness, inattention, disorganized thought, and it can present in a spectrum. You can have patients with hypoactive delirium, hyperactive delirium, or a mixed of both. Highly prevalent, especially in a subset of patients that have increased comorbidities, like our elderly population. It can occur in 70% of those population. And the unfortunate thing is it's preventable, but we are delayed in recognizing it. So we have to have a vigilance to screen our patients and pick up early signs of delirium so we can get ahead of it. It is associated with increased cost in healthcare. It leads to prolonged length of stay in the ICU and overall in the hospital. And there's a lot of resource utilization associated with delirium management. Table 1 here shows you the most common risk factors for delirium, age being the biggest risk factor, and then prior history of neurocognitive disorder, prior history of stroke, psychiatric disorder, substance abuse. These tend to be the biggest risk factors for our patients. Then there's intraoperative and postoperative risks. The majority of them are really non-modifiable. And the medication side, medications like benzosteroids tend to increase the risk of delirium in the ICU and in the hospital. The best way to manage delirium is to diagnose it early, and we have a lot of screening tools available. I think most ICUs use the CAM-ICU screening tool, and this should be done daily or every shift for our patients so we can catch it early and optimize our patients. The pathogenesis of why, we don't really know why patients develop delirium. Like I said, majority of it, they have predisposing neurocognitive disorder, but we think the use of cardiopulmonary bypass also adds a huge impact on how their brain functions. The systemic inflammatory response that we see related to cardiopulmonary bypass is also thought to occur in the brain, disrupting the blood-brain barrier and leading to cerebral edema, which may be affecting or causing a delirium. The brain and the kidney are two organs that do not like cardiopulmonary bypass. You're changing the flow of blood from a pulsatile blood to a non-pulsatile blood, and this is not friendly to the brain and the kidney, so we think that impacts how the brain recovers. And then you also see ischemic reperfusion injury related to cardiopulmonary bypass as well. As I showed you from that study, there's microemboli that occur in every CABG case or any cardiac procedure, and majority of it is gas, and we don't really know the impact of these microemboli and how they're impacting the brain function. If you scanned everybody after cardiac surgery with an MRI, you will pick up something. Inevitably, you'll find embolic events. So we know that there's silent brain injury, we just don't know the impact of that in our patients. The prevention, like most things in cardiac surgery, management should start in the preoperative period. So it's very important that our patients are screened appropriately, and patients that are at risk for delirium should be identified if it's an elective case in the clinic, if it's in the hospital in the preoperative phase of their care, and whatever is reversible and can be optimized should be optimized. The one thing we forget is education. If a patient is deemed at risk for delirium, they should be educated on their risk. More importantly, their family should be educated on their risk, because when patients become delirious, it's very traumatic to family members to see their loved ones in that state, and they can't understand why this is happening. So if you get ahead of it and educate family members, they can be the support system that you need for the patient. Intraoperative selections, I think our anesthesia colleagues can comment on that, but medications used in the OR seem to contribute to post-op delirium. There's a thought that if you use medications like ketamine and intraop, they may reduce your risk of long-term delirium, although these medications are also associated with delirium in the immediate postoperative period. The thought about using ketamine is it also helps with pain. So when you use ketamine, you're minimizing your opioid need, and that may help minimize delirium long-term. Precedex is a magical drug. I think everybody should be on it. It's been known to minimize the risk of delirium, but also we use it to treat delirium in the ICUs as well. The management strategies or the prevention strategies in the postoperative period should focus on non-pharmacological techniques. If you don't have a delirium bundle, you should develop one or you should adopt one. This is from the ERAS Society, really focusing on the things that prevent and also treat delirium. These include early mobility, optimizing hydration, reviewing medications, pain management, focusing on non-opioids and multimodal pain management, sleep enhancement, making sure patients have their hearing aids and their eyewear, and then minimizing restraints. Restraining patients that are delirium is the worst thing to do. It just adds fuel to the fire. It doesn't really prevent anything. The only time patients should be restrained is if they're harmful to themselves or to others. And then in terms of pharmacologic agents, several medications have been tried as preventive strategies, but none have been shown to be beneficial. Some centers actually start melatonin or Ramelteon, which are sleep aids, prior as a prophylactic measures. To be honest, the evidence is not robust, but there is an added benefit that these medications, in addition to regulating sleep, may have some anti-inflammatory properties, and they're really well tolerated. So it's okay to use these medications as a prophylactic measure. If prevention doesn't work, what should we do when a patient develops delirium? And I think this is, if you take anything out of this section, this is probably the one thing I want you to take away is treat delirium as if the patient is undergoing brain failure. It's an organ failure. It's a symptom and not a cause. So you really have to figure out the initial insult and why they're developing delirium symptoms. So this mnemonic here is quite helpful. The most common causes of delirium for patients are pain, infection, nutrition, usually malnutrition, constipation or retention if they don't have a Foley, dehydration, polypharmacy, or environmental situations like sleep deprivation, noise, and things of that nature. So really go through this algorithm and figure out if there's anything correctable that can be identified and fixed. Once you do that, the primary goal should focus on using non-pharmacological agents to manage delirium. Medicine is not always the answer. If the patient's unsafe and they need to be started on a medication, antipsychotics like risperidone, olanzapine, and Haldol are all beneficial or efficacious. This is actually an interesting study which was done in Australia, and they randomized people to getting earplugs and eyewear. Patients undergoing CABG, half of the group got earplugs and eyewear, and the other group didn't get anything. And the rates of delirium were actually decreased in the ones that received the earplug and the eyewear. They had less frequency of delirium, but when they had delirium, the duration of time they were delirious was also shortened. So this shows you how non-pharmacological agents should be the primary treatment method for this problem. In summary, this is again the algorithm from ERAS. Delirium is very common. I think the management of delirium should start in the preoperative phase by appropriately screening and patient selection. We should optimize patients as best as possible, focusing on making sure we review their medications, making sure they're not dehydrated. And if you don't have a delirium bundle, this is where delirium bundle should be assessed and implemented as well. The anesthesia section is up to our anesthesia colleagues here, but medication selected by the anesthesia team, monitoring of depth of anesthesia, we know impact post-op delirium. In the post-operative period, routine screening is the most important thing. So using some form of a delirium screening tool on a daily basis to diagnose and prevent delirium from happening. Identifying causes of delirium before treating it, focusing on non-pharmacological management strategies, and when you do start pharmacological agents, make sure that you review and stop these medications when the delirium is resolved. That's something that we routinely don't do, right? A patient started on Seroquel and they'll be discharged on Seroquel. And these drugs are not benign. If they don't need it, it should be stopped as soon as the delirium is resolved. And in terms of long-term, we also don't have long-term for follow-ups for these groups of patients. We know a subset of patients, especially the ones that are elderly, have pre-existing neurocognitive disorders, they're at risk of having long-term impact from that episode. So making sure somebody is following them as an outpatient is also important and should be incorporated in our treatment algorithm. Okay, 2 more sections. Do I have time? Okay, I'll do blood and this one will be brief because you already have a session, had a session on it earlier. Bleeding, as you learned in the morning, is another common complication we encounter in our ICU cardiac surgery patients. 15% of patients will have some form of bleeding complication. Where you get a little bit sticky is when you're talking about excessive bleeding. We don't really know what excessive bleeding is, like one of those things that you know it when you see it kind of thing. But in literature, there's variable definitions about what is defined as excessive bleeding. But we know that bleeding increases our patient outcomes in terms of increasing morbidity, mortality, transfusion rates, as well as economic burden. Clinically, when we deal with bleeding, we define it into 2 categories. It's either surgical bleed that needs a surgical fix or medical bleed, which is called microvascular bleeding, commonly related to coagulopathy. So for us to stop the bleeding, the focus is on achieving hemostasis, and hemostasis requires 4 factors. The first is blood vessel integrity. So if it's a surgical hole, it needs to be fixed by a surgeon. There's nothing we can do medically. But for the microvascular bleeding, the goal is to have a good clot formation, which starts with having enough and adequate functioning platelets, having enough and adequate functioning coagulation factors, and fibrin or fibrinogen is the most important glue that binds this all together. Like most other things, bleeding management, again, starts in the preoperative phase. So I'll go through it, and then it continues in the operating room, and when we have our patients in the post-operative period, we continue that process as well. These are the guidelines that focus on blood and bleeding management in the cardiac surgery population, and most of them have actually been recently updated. So in the preoperative period, bleeding management means you have to assess the patient's risk for bleeding. Majority of our CABG patients are on some form of medication that's going to predispose them to bleeding. So understanding what to do with these medications is key. Another factor is anemia, which is usually not managed very well in the preoperative phase, but the recent guidelines focus a lot about anemia management and workup. So medications, aspirin and P2Y12 agents are common in our patient population. What to do with these medications is kind of inherent to us, but for the most part, aspirin can be continued with the exception of a few cohort of patients, and those are the ones we deem very high risk for bleeding and those that refuse transfusions for personal or religious reasons. In terms of P2Y12 agents, there's guidance based on what medications the patient is on. On average, most medications should be stopped anywhere between 3 to 7 days. But the metabolism of these P2Y12 agents can vary based on the patient. So if you have the capacity to check for a platelet function test, you should use that as a guide as well. For patients that cannot have their P2Y12 agent interrupted because they have a recent stent, you can consider bridging them with short-acting medications like Cangalore, or if you work in a cheap hospital, the 2B3A agents also work, so either or is acceptable. In terms of anticoagulants, most of our patients are on heparin because they have coronary disease, so we don't typically worry about heparin. But if they're on anticoagulation like Coumadin, this should be stopped at least a minimum of 5 days in the preoperative period. And then the direct oral anticoagulants are recommended to be stopped 3 days pre-op, but I think most surgeons or most teams stop it way before then. The other important point here is understanding what reversal agents you have available in case of emergency and you need to reverse these drugs. So the recent European guidelines for blood management focus on anemia management, which is actually very important. I think the definition of anemia is really the most important thing. So for women, it's hemoglobin less than 12. For men, it's hemoglobin less than 13. And I would guarantee you, majority of your patients do not have a hemoglobin at that level. So anybody with this degree of anemia needs to be treated with iron or EPO. And the role of EPO is really the key point that I want to focus on here. For most patients, iron supplementation is not adequate. They need a stimulating agent like erythropoietin. We know if you give patients EPO, it reduces their transfusion needs in the postoperative period. It also improves their outcome overall. The big concern about giving epoprotein prophylactically has been the concern of thrombotic complications, but that actually has been proven not to be true. There's minimal risk associated with giving EPO, so in my opinion, everybody should be getting EPO in the preoperative period, especially if they're undergoing elective procedures. In addition to its impact on red blood cell production, epoprotein is also known to have cardioprotective and renal protective properties. So you get the added benefit of improving these organ functions in the postoperative period. Another important point is epoprotein is secreted by the kidneys, and once the patient undergoes surgery, they will likely have some degree of renal insufficiency and may not be capable of producing enough erythropoietin, so giving it to them in the preoperative phase may help balance this out. So it's a very important medication which is underutilized in our pre-op patients and cardiac surgery patients. One study actually showed even giving epoprotein 1 to 2 days prior to their surgery decreased their transfusion need significantly. So I think as a whole, that's something that we should adopt in our institutions. I'll skip this part for time purposes. And then going back to the postoperative blood management strategy, this kind of falls into two categories. One is if you have a bleeding patient, and the other is if you don't have bleeding complications you're worried about. For those patients that are not bleeding, and if they're hemodynamically stable, we should all be able to accept restrictive transfusion parameters, meaning a hemoglobin anywhere between 7 to 8 should be adequate. We shouldn't be transfusing them to meet a number that may or may not mean something to them. Transfusion alone is independently linked to increased morbidity and mortality in our cardiac surgery patients. And there are several studies that have compared transfusion, restrictive versus liberal transfusion, and they have shown restrictive transfusion parameters were found to be non-inferior and led to better outcomes. So tolerate anemia as long as the patient is stable. If bleeding occurs, I think Dr. Chopra already mentioned that it's very important to establish a bleeding algorithm that fits with your institution, considering all the surgeons' preferences in terms of how they want their patients managed. This is an example of the bleeding algorithm we had, which focused on really, we did not transfuse patients willy-nilly. I think, whenever you transfuse a patient, I always say blood transfusion is blood transplantation. You don't give an organ to somebody without thinking about it. So you really should take a moment and really understand if the transfusion is needed. For that reason, we always tried to minimize transfusions, and we developed an algorithm that gave us a moment to manage patients. So one thing, this is at Morningside, what we did was every patient's coming out of the OR, their chest tube output was tracked for every 15 minutes for the first hour, and then it was, if it's stable, then you back off off to 30 minutes. If it's stable, then you back off every hour. So if chest tube output was greater than 30 for the 2 sessions during the first hour, then we go down the algorithm and say, are they stable or are they unstable? If they're stable, the tube consistency is not concerning, you can back off. If you are concerned about the consistency and it looks like blood, then you go down the algorithm of, checking their labs to make sure they're not coagulopathic. We increase PEEP. There's, mixed data about whether this helps or not. We would give DDAVP and protamine to reverse heparin rebound. Most of our patients are on aspirin, so to promote better platelet function. Then we would send a TEG or a ROTEM to see if there's any deficiencies that we need to correct. If the patients are unstable, we contact the surgeon right away to make sure that they're aware that bleeding may be an issue, so it's not a surprise if we can't control it medically. The last point I want to make is if you are concerned, order blood. You can always send it back, but it's always nice to have blood ready for you because once bleeding occurs, time is an issue. So waiting for blood is probably where we get into trouble. So if your suspicion for bleeding is high, order the blood. You don't have to give it. You can always send it back to the blood bank in a timely fashion. Do not let it linger in the ICU, but you can always send it back. So having blood available and ready to give is also another important thing. And when in doubt, always activate your MTP or massive transfusion protocol. I think Dr. Chopra discussed this, so I won't go to it. The factors needed for hemostasis. The goal is always to deliver goal-directed therapy. You want to diagnose what your deficiencies are, and then give what you need. You don't want to over-transfuse patients because we know that increases their morbidity and mortality. The new points that I want to make here are the role of these coagulation agents, especially fibrinogen concentrate and PCC, which are becoming more frequently used in cardiac surgery. I think that's the new paradigm that we are shifting towards. And these products I'll share with you here. PCC. What is PCC? PCC is essentially vitamin K dependent coagulation factors that are pulled from plasma and lyophilized, and they basically come in a powder form. You have to reconstitute it and give it to patients. These medications are routinely used to reverse elevated INR in the setting of intracranial hemorrhage and devastating bleeding. But we're starting to use these agents in the cardiac surgery world. And the use of these medications was very, I think, scary for a lot of surgeons, especially in the setting of CABG, because you don't want to increase graft thrombosis and graft closure. But now there's data available to show us that use of these agents is actually safe, even in our CABG population and our cardiac surgery patients. So this study was recently published, actually this year. It was comparing PCC to FFP to see if you get better hemostasis in cardiac surgery patients that had bleeding complications. And it was surprisingly showed superior results. It was better than FFP, and no adverse effects were seen with PCC compared to FFP. PCC comes in a volume like this. When you give FFP, you never give one, right? It's usually 2, 3, 4. So imagine giving a patient a vial of medication like this versus, 200 cc's of blood product. You're still dealing with complications like taco, trally, and all the other things that come with the transfusion. So using this medication is actually going to change how we manage our patients. The caveat here is when you use PCC, the dosing is still unclear on what dose you give the cardiac surgery patients. In this study, they used a dose of 10 to 15 units per kg. The recommendation for reversal is 25 to 50 units. So we're using smaller doses in the cardiac surgery world. At my current institution, we use PCC quite often, but we actually I call it microdosing. We would start with 500 units, then if that doesn't work, we'd give another 500 units, but we would never give a cardiac patient more than 2,000 units of PCC. If you're requiring that much, then your bleeding is really more of a surgical bleed and they need to be re-explored. What about cryoprecipitate versus fibrinogen concentrate? So fibrinogen is a very important clotting factor, which is misunderstood. It's probably the largest volume of clotting factor circulating in our body. It is the glue that stabilizes the clot, so it's very important in bleeding management. In cardiac surgery, acquired hypofibrinogenemia is very common for many, many reasons. One, patients are getting aggressively volume resuscitated, so there's a dilution component. There's, again, volume loading during the cardiopulmonary bypass process because the pump has to be primed with fluid. The inflammatory response also leads to consumption, and if you have bleeding on top of that, you're losing fibrinogen. So most of our patients have some level of acquired hypofibrinogenemia. On top of that, subset actually will have critical hypofibrinogenemia. And if you don't have fibrogen, you cannot control bleeding. So it's a very important factor to stay on top of and to correct. In the US, the way we would correct fibrinogen is by giving cryoprecipitate, which I'm sure you guys know, it's the most annoying thing to order, right? Because it has to be thawed and blah, blah, blah. And the the blood bank is giving you a hard time. It's like 30 minutes to an hour by the time you order it and the time it gets to you. And then the bleeding patient, you really don't have that much time to wait around looking for a blood product. And in other parts of the world, in Europe, the fibrinogen concentrate is what's used. They don't even bother with cryoprecipitate anymore. It's no longer available. But there's a lot of hesitancy in the US to use it. A lot of centers actually don't have it. It comes from the pharmacy. Again, it comes in this much of a vial and needs to be reconstituted, and the volume is very minimal. Compared to cryo, if you give 2 packs or however you guys call it, 5, 10, it's a lot of volume. Every place calls it differently. So this study compared cryo to fibrinogen to see how it impacted bleeding control and transfusion requirements in cardiac surgery patients. Again, fibrinogen concentrate was found to be non-inferior, and there was a slight increase in transfusion requirement between the two groups. That was one of the primary endpoints they looked at, but definitely there was no harm associated with it. So it's actually a good factor to use in a bleeding patient, and hopefully we'll be changing our paradigm towards using this medication. To summarize bleeding here, most other things I mentioned today, pre-op is really the best place to start optimizing bleeding complications by making sure patients are adequately prepared for the surgery and they're not anemic and they have blood reserve. I think everybody should be on EPO and or iron, depending on their iron levels. Epoprotein has been shown to be safe and effective in our cardiac surgery patients, and it will help us minimize transfusions in the postoperative period. We should accept restrictive transfusion parameters unless somebody's bleeding. If their hemoglobin is in the 7s and they're asymptomatic, just give them some time to make their own blood. Bleeding management should be tailored toward goal-directed transfusion, and we should try to avoid over-transfusion patients, and this can be accomplished by using point-of-care testing, your routine coagulation labs, as well as viscoelastic testing if you have it available. And I think the most exciting thing is the incorporation of PCC and fibrinogen and factors like this in the management of our bleeding algorithm. And I think I'm going to stop here because it's 42 minutes. Thank you.
Okay, guys, we're almost to the end. We have 2 more speakers. Both are anesthesiologists, so this is going to be very interesting. We will have Dr. Hermione Bott. She will be speaking about ERACs and multimodal. And what was happening? Oh, you're going there? Okay. Yeah. And I just set it up. Okay. This thing is rolling. Okay, you're going to. Okay. And multimodal analgesia, is this the answer to the opioid crisis?
it's moving.
Good?
Yeah.
Oh, perfect.
Okay, so three things. Despite being an anesthesiologist, I will not put you to sleep. For obvious reasons, I'm sitting up here, for those of you that didn't catch my appendages. And three, projection is usually not my weakness, and so I will make sure that this is a little bit further from where I'm speaking. Thank you very much for the kind introduction. Today I'm going to be talking about enhanced recovery after cardiac surgery, or ERACS, which is the way I'm going to refer to it, and multimodal analgesia, and how they are critical to reducing the opiate utility and dependency in cardiac patients. Now, just by show of hands, how many of you, and you've already heard of it, as a matter of fact, a few people have already referred to it. Marcy was speaking about the Beacon Award earlier, and what she described as the CABG pathway is essentially an enhanced recovery pathway. So again, and a lot of these aspects that I will refer to have been touched upon throughout most of the people that have lectured so far. But from a show of hands, how many of you either are familiar with or are part of, in other words, using some sort of enhanced recovery / multimodal type of pathway at your institution? So most of you know. Most of you know what it is and are now using it. A few years ago when I gave this lecture, most people were not using this, and so I'm glad that it's come a long way. Okay, my disclosures. So today I'm going to be talking about cardiac-related pain. I will discuss, of course, opiate use and chronic pain in cardiac patients. I will review some important components and outcomes of an ERACS program. I will review the multimodal analgesia model that I just referred to and what its relationship to ERACS is. And I will, of course, introduce the inclusion of regional techniques within this model, which Dr. Ali Shariat will then be getting into more detail. So let's talk a little bit about cardiac pain. So cardiothoracic surgery can be associated with significant postoperative pain. None of you are surprised. But it's usually categorized within three main types. So first, you have acute pain. This is most common. This is what we see. Is that initial inflammatory response is due to the incision, often due to the actual retractor. It is mediated by local and systemic inflammatory mediators. It often actually improves within the first few, it should improve within the first few days if you treat it effectively. Second is neuropathic pain. Now, this is an actual neurogenic inflammation, or it's usually due to some sort of temporary or sustained pressure, stretch, or direct injury to the actual nerve itself. This pain can be immediate or develop over weeks to months, unfortunately, as the severed nerve endings kind of regrow or stay trapped within scar tissue. Particularly the visceral and parietal pleura are sensitive to this pressure and stretch-related stimuli. Furthermore, harvesting internal mammary artery has been linked to neuropathic pain syndrome in many studies. The last one, which we don't often see, is post-pericardiotomy syndrome. Now, this is a heightened immune inflammation. It's usually to the pericardial injury itself. The symptoms can include fevers. They can include a pericardial rub. Patients can arrive with pleuritic chest pain weeks later, and unfortunately, pericardial effusions. Now, most importantly, and the point I'm trying to make, is that all of these factors can lead to chronic pain syndromes, which unfortunately require continued opiates in these patients. So here's a great cartoon. It shows basically so many multiple sites of incision in cardiothoracic patients that can actually be associated with pain. So now, not only can this pain be severe, but it can have long-lasting chronic post-sternotomy pain syndrome, and this is what we're all worried about. Here's a study looking at pain over a year in cardiac surgical patients. Now, what it showed is that post-op day 4, almost half of the patient had severe pain at rest, while with movement or coughing, the pain was up to 78%. What's more interesting is that even at a year, the patients reported 24% of patients reported some kind of pain with any sort of movement. Here's another study. A study by Brown and colleagues looked at 35,000 patients, opiate-naive CABG patients, CABG and valve, and what they found was 9.6% had new persistent opiate use between 90 and 180 days. That's a lot. What they identified as risk factors was CABG surgery compared to valve surgery, and that might have something to do with the internal mammary harvest, as well as younger age, female gender, pre-existing comorbidities, including CHF, lung disease, kidney failure, diabetes, of course, chronic pain and alcoholism, and any patients who were on some kind of preoperative treatments, such as benzodiazepines, of course, opiates, and any even muscle relaxants. So what about patients who are opiate dependent? Now, here's a study that looked at 330 patients who underwent CABG surgery to determine chronic opiate use in opiate-naive versus opiate-exposed patients. The chronic opiate use was defined at usage beyond 90 days after discharge. And of course, what it showed is opiate-exposed patients were prescribed higher doses, they required greater refills, and had significantly higher percentage of opiate dependence. Furthermore, not surprising, opiate-exposed or dependent patients have a higher rate of complication. This is a U.S. national cohort study which looked at over 5 million patients and found that patients with opiate use disorder, to begin with, who undergo cardiac surgery, have a much higher rate of overall complications such as transfusion, longer mechanical ventilation, pulmonary embolus, and of course, prolonged pain disorders. So one solution to this opiate crisis may be the implementation of multimodal analgesia within a well-crafted enhanced recovery model, or what I'm going to refer to as ERACS. Many of you know, as we talked about, many of you know about what this is, and we already established that some of you are using this. So now ERACS is a multimodal, multidisciplinary care pathway to achieve early recovery for patients undergoing cardiothoracic surgery. The increasing patient expectations, the complexity of a lot of these cardiac surgical patients, of course, the growing elderly population, and just the overall comorbidities makes cardiothoracic patients an ideal cohort for ERACS. Clinical trials have also shown that a well-designed and implemented ERACS program can assist in providing reduction in postoperative complications as well as cost. So now this is not new. It's not a new idea at all. ERACS goes back to even 1980s, as a matter of fact. Here are just 2 studies that looked at the implementation of ERACS components in cardiac surgical patients. The first study dates back to 1994, and there were anecdotal studies, like I said, going back to 1980s. Now, when applied to cardiac patients, it has been shown to have not only feasibility, but more importantly, potentially decreases post-op morbidity in all of these patients. As a matter of fact, the ERACS Society was formed in 2017 and released its first consensus expert review guidelines outlining components and implementation in cardiac surgical patients in 2019. They screened over 4,000 publications to formulate these recommendation and level of evidence. And I'm not going to go through all of them, but again, this is still used today and followed. Now, ERACS consists of multiple components that can benefit cardiothoracic surgical patients. More importantly, ERACS addresses the whole perioperative process. Here's a great schematic, actually, from a very large systemic review from 2025. It focuses on multiple ERACS protocols in actually minimally invasive cardiac surgery. This is an extensive diagram of common elements, including patient education, multidisciplinary teams, blood management, which we already heard about, and it's actually a dear topic to my heart, early extubation followed by early mobilization, and again, multimodal opiate-sparing pain management. Now, while these guys have placed it, based on their analysis, they've placed it in the post-op box, the reality is that the importance of this regimen is throughout the whole perioperative process, and I'll talk about that next. So, if you look at this, when you look at the whole ERACS perioperative process and the components that are important, multimodal analgesia and its process or components can be applied to the whole perioperative process. As a matter of fact, it's recommended. So this is something that, when you take on multimodal analgesia and look at any implementation, you have to take into consideration applying a lot of these facets to all of it. More importantly, the use of perioperative opiate-sparing multimodal analgesia regimen is considered a Class 1 indication in the ERACS guidelines that I referred to earlier. And it works, right? Nobody's surprised, it works. This is one of the first ERACS programs that was systemically applied to cardiac surgery in the United States. After a year of system-wide implementation, this study showed that they had a 30% reduction in opiate use from pre to post ERACS implementation, in addition to other things such as reduced length of stay and GI complications. Here's another study that looked at pre and post ERACS implementation with, of course, a very organized multimodal opiate-sparing analgesia and even a small community hospital. The ERACS patients were shown to have less nausea, less lightheadedness, and required significantly less opiates compared to pre-ERACS patients. Also, postoperative mobility was significantly better, and postoperative length of stay was, of course, lower. And this is a very recent study that compared 466 patients undergoing non-emergent cardiac surgery. Again, pre and post ERACS implementation. And what they showed is that the ERACS protocols, when they had an organized emphasis on multimodal pain management throughout the perioperative process, it was associated with a 57% reduction in opiate use after surgery. Recently, the joint conference between the Perioperative Quality Initiative and Enhanced Recovery Cardiac Surgical Society, which many people in this room have already referred to, convened to evaluate the literature and provide guidance on pain management in cardiac surgical population. They put forth a summary of core principles that support opiate stewardship and mainly the use of multimodal analgesia in cardiac surgery, including the application of non-opiate medications and techniques, utilization of opiates in a judicious manner, patient and provider education, and a structured system-level opiate prescription practices to reduce overall high-dose opiate use in these cardiac surgical patients. So again, I know I asked everybody. You all know multimodal analgesia, but what is it? What is the actual definition? Essentially, multimodal analgesia is the use of more than one pain control modality, not necessarily medications, but modality, to achieve effective analgesia. Basically, what better group than anesthesiologists to drive this? So it includes a broad variety of analgesic therapies, most of which work at different sites across the peripheral and central nervous system. And by targeting different receptors and pathways, we can enhance pain control, of course. It produces a synergistic effort, reduces side effects, and of course, reduces opiate dependence. So when you look at multimodal pain medication, it consists of two major components. There's the pharmacological and the non-pharmacological. The treatment of chronic pain in cardiac surgical patients often requires the utilization of multiple treatment modalities. This includes both opiates and non-opiates, regardless of the etiology of the pain. Now, commonly prescribed medications range from, NSAIDs, nonsteroidals, opiates, tricyclic antidepressants, serotonin and norepinephrine reuptake inhibitors, anticonvulsants, cannabinoids, muscle relaxants, benzodiazepine, and of course, even topical agents such as lidocaine, topical NSAIDs, and of course, capsicum. So here's an extensive, and I'm not going to go through this because it's a whole lecture in itself. Here's an extensive chart with multiple non-opiate agents that are often used in any multimodal pathway. Each of these agents has an important set of considerations now, especially when you're looking at cardiac surgical patients with, of course, multiple comorbidities. More importantly, each of these agents that I spoke about has a varying degree of evidence and, of course, safety when it's applied to these patients. And again, like I said, it's a whole different lecture in itself. Here's actually a very good graph looking at where many of these lie, not only in terms of their efficacy, but also their safety profile. And I had to include this. This is actually a copy of our institutional multimodal pain management protocol. This is just the pain management protocol. As you can see, it's a combination of both pharmacological and non-pharmacological therapies, many of which I previously reviewed. Okay, so the use of pharmacological agents cannot be effective alone in cardiac patients, unfortunately. This is where the non-pharmacological modalities have gained a lot of attention in the past years. Now, these modalities are important part of multimodal pain management and unfortunately often underutilized. And unique, again, to the anesthesiologist is the effective use of regional techniques. But what about cardiac anesthesiologists? I'm a cardiac anesthesiologist by training. So the importance and efficacy of multimodal analgesia for cardiac patients now kind of shifts our focus from the good old opiate-heavy-based cardiac anesthesia to now needing to kind of have a good foundation of pain management and being a good regional anesthesiologist. So multiple studies have now shown in cardiac patients that regional techniques within a well-implemented ERACS protocol can have a great impact on reducing opiate usage. Here's a study looking at outcomes post-ERACS implementation. It showed that total opiate doses administered both in the OR as well as post-op were significantly reduced. More importantly, the multimodal analgesia regimen is not only includes a lot of non-opiates, but it includes regional techniques such as transverse thoracic plane block and serratus anterior plane block. Now, as a matter of fact, regional techniques have become a standard component of many implemented ERACS protocols, as well at varying institutions, of course. I don't know, at institutions that, again, many of you raised your hands, I'm sure there's somebody who does some kind of regional block for your patients, whether it's in the operating room or even afterwards in the ICU. Not only that, but now regional techniques are actually recommended both in guidelines and practice advisories. The recent conference that I was referring to between the Perioperative Quality Initiative and the ERACS Society put forth this roadmap highlighting potential components of a comprehensive multimodal regimen for cardiac surgical patients. And of course, it now includes regional techniques as a recommended part of this regimen. Okay. In addition, this is a recent practice advisory which was developed by the Society of Cardiovascular Anesthesiologists, Quality, Safety, and Leadership Committee and the Opiate Working Group. And they also recommend that paravertebral blocks and fascial plane blocks for acute pain management in patients undergoing cardiothoracic surgery with a high level of evidence now. This same group actually just put out another practice advisory for post-op pain. This now also includes the use of regional techniques, including continuous catheters, as part of, again, this multimodal regimen. More importantly, they recommend the potential utility of these blocks after sternotomy and after minimally invasive cardiac surgery, which now opens up this whole discussion of rescue blocks, something, as I told you, our institution has been doing for our patients in the ICU for years. So multimodal analgesia and opiate sparing equals opiate free, right? And that is a big, big no, right? So this is not going to be possible. More importantly, it's not what we should be striving for in cardiac surgery, and may not even be possible. This is a very interesting study, a very recent study that looked at over 61,000 patients undergoing varying types of non-cardiac surgery and their opiate administrations throughout the perioperative process. They found that reduced opiate use during the intraoperative period resulted in a higher frequency of uncontrolled pain, an increase in new chronic pain disorders diagnosed at about 3 months, and a greater persistent opiate dependency and prescriptions at 30, 90, and 180 days. So now, even though these were non-cardiac surgical patients, we have to keep in mind that our mission to reduce opiates does not equal opiate-free. More importantly, multimodal analgesia, in addition to all of the components that I spoke about already, should include proper opiate use. Okay, so in conclusion, opiate dependence is still a problem in the cardiac surgical patients. ERACS protocols and multimodal analgesia models are not only gaining popularity, but they may be the solution to trying to reduce some of the chronic opiate use and chronic pain disorders that we see in a lot of these cardiac patients. Also, optimizing opiates in these models is critical, and non-pharmacological techniques such as regional anesthesia may serve as a good adjunct for these patients. Thank you. And no, as per that picture, we do not use a hammer to put our patients to sleep. I don't know if anybody actually caught that.
So first, thank you so much for staying until the very end. I know it's been a long day, and I'll try to get through mine as quickly as possible. My name is Ali Shariat. I'm a regional anesthesiologist at Mount Sinai Morningside, where I work with Dr. Bott. And I'm going to be talking about regional anesthesia in cardiac surgery. I'll start once my slides come up. Oh, okay. Thank you.
Being useful today.
Wonderful. Thank you so much. So I have no disclosures. I am going to start by talking a little bit about neuraxial and paravertebral techniques and their application to cardiac surgery. This is mostly from a historical perspective. And this is going to set up the real nucleus of the talk, which are the still relatively novel fascial plane blocks and the burgeoning interest in the application to cardiothoracic procedures. And I'm going to concentrate on specifically two different types of blocks, the superficial and deep parasternal intercostal plane blocks and the erector spiny plane block, or ESP block. So it's hard to believe that it's been like 8 or 9 years since Dr. Bott and I first started to brainstorm about bringing in these novel fascial plane blocks and regional techniques for a multimodal analgesic regimen for cardiac surgery patients. And at that time, this collaboration was considered to be kind of exotic. But in fact, regional anesthesia techniques have a very long history of being applied to cardiac procedures, particularly in the form of thoracic epidurals. And there is a really large body of literature that has evaluated the usefulness of this modality. This is one such study by Lehman colleagues in which patients going for coronary artery bypass grafting were randomized to receive either a thoracic epidural or no epidural. And they found that the patients who received the epidural were awake sooner, resumed spontaneous respirations earlier, and were able to be extubated earlier than those that did not. So the problem here really is that the fear of spinal hematoma has hampered the accumulation of data and experience in this modality, in this patient population that needs a very profound intraoperative heparinization. The question is, are these fears justified? It's noteworthy that there is not a single case report in the literature that convincingly links the intraoperative heparinization that is necessary for cardiac surgery to a spinal hematoma postoperatively in a patient who received an epidural. So what really is the risk? And this was figured out by Ho and colleagues to be between 1 in 150,000, which is the risk of a spinal hematoma in a non-anticoagulated patient, and 1 in 1,500, which was figured out using an algorithm for an event that has not yet taken place. Now, the reality is that these numbers are probably rather conservative in that the actual risk is a good deal lower. But for most practitioners, the idea of such a devastating complication occurring in an otherwise routine cardiac surgery is just simply too high a risk to take. Also, in that very critical, immediate postoperative period where it would be of critical importance to be able to pick up the signs and symptoms of a spinal hematoma is exactly the time that most of these patients are intubated and sedated. So this makes the risk unacceptably high. And this brings us to the paravertebral block. Now, I'm used to giving this talk to regional anesthesiologists, so I don't really go into the mechanism of action of a paravertebral block when I give this talk usually. But for those of you who don't know, the paravertebral block is performed just adjacent to the vertebral bodies, around the location where spinal nerves exit the intervertebral foramen. So it acts sort of like a unilateral epidural blockade, right? Because the local anesthetic does not traverse and go to the contralateral side. So right off the bat, there is half the sympathectomy that would be produced by an epidural block. So already the safety profile of the paravertebral block is better than an epidural. Also, there is not even a single case report that links a paravertebral block to a spinal hematoma altogether, right? So in fact, the paravertebral block has been studied and applied to cardiac surgery. Due to the unilateral nature of the analgesia that is imparted by this block, it has usually been applied to minimally invasive cardiac surgery through an anterior thoracotomy. And this is one study by Dole and colleagues in which patients going for minimally invasive cardiac surgery were randomized to receive either a unilateral paravertebral block or a thoracic epidural catheter. And they found that the paravertebral catheter was equivalent to the gold standard epidural catheter in terms of the reduction of postoperative pain and opioid requirements. And due to the better safety profile of the paravertebral block, the advantage was given to the paravertebral in this study. Now, the next question is then, if we can use a unilateral paravertebral catheter for patients going for minimally invasive cardiac surgery, why not place bilateral paravertebral catheters in patients undergoing cardiac surgery via a midline sternotomy? And this is a question that was examined by Ho and colleagues. This is Dr. Karmakar's team in Hong Kong. We have a very close relationship personally and professionally with this team, and they found very interestingly that when they placed bilateral paravertebral catheters in patients going for cardiac surgery, in all cases, these patients had postoperative mental status changes that were consistent with local anesthetic systemic toxicity, despite the fact that the dose of ropivacaine that was being given was well below the calculated toxic dose. So this shows us the limitations of the paravertebral technique. And this brings us now to fascial plane blocks. So what are fascial plane blocks? There is a myofascial sheath around muscles, and the neurovascular structures are traveling through this space that is created by this myofascial sheaths. And if you inject local anesthetic between these muscle layers, odds are you're going to anesthetize some nerves that are traveling through it. Now, right off the bat, they have a few advantages. Number one, there is the technical simplicity, right? Not all anesthesiologists are comfortable placing a thoracic epidural or a paravertebral catheter. These blocks are relatively simple to learn. And number two, there is a far better safety profile because local anesthetic is injected in locations that are distant from neurovascular structures, right? Making the safety profile much better. So the first block that I would like to talk about is the superficial and deep parasternal intercostal plane block. Really, these are two different versions of the same block, right? They're targeting the same nerves, the anterior cutaneous branches of the intercostal nerves between T2 through T6. This is the direct innervation of the sternum. And this is just a diagram of the area in which these blocks are performed, just adjacent to the sternal border and going from superficial to deep we have the pectoralis major muscle, the internal intercostal muscle, and the transversus thoracis muscle, which is a thin muscle layer that is just superficial to the pleura. Now, there's been a movement to try to unify terminology, and the superficial parasternal intercostal plane block was previously known primarily as the pectointercostal fascial plane block, or PIF block. That's a name that you may have heard before. And this block is performed by injecting local anesthetic between the pectoralis major and the external intercostal muscle, somewhere between either rib 3 or 4, rib 4 or 5. One injection site is usually all that is necessary to have spread between rib 2 and rib 5. The deep parasternal intercostal plane block was previously primarily known as the transversus thoracis plane block, or TTP block. As its name implies, it's performed at a slightly deeper level. In this case, local anesthetic is injected between the internal intercostal muscle and the transversus thoracis muscle, which, as I mentioned, is just superficial to the pleura. Now, here I'm showing an ideal picture, right? In most cases, the transversus thoracis muscle is a good deal thinner, and it's more difficult to discern. Okay. Now, due to the proximity to the pleura, there is documented a higher incidence of pleural puncture. Also, I'd like to add that the internal mammary artery is lying in exactly the same plane, in the same level as the transversus thoracis muscle. And due to the fact that at this level, the pulsation of this artery could be very difficult to discern on ultrasound, it is mandatory, in my opinion, to perform a Doppler ultrasound prior to the performance of the deep parasternal block to avoid injury to this structure. I'd also like to point out that in patients who have had a previous internal mammary artery harvest, this transversus thoracis plane becomes obliterated, and this has obvious consequences with regard to the spread of the injectate. This was very elegantly shown in this study by Fujii and colleagues. And we could see on the left side, where internal mammary artery harvest had not taken place, when the dye is injected at one level, we could see the spread of dye from rib 2 to rib 5. Whereas on the right side, where there was a previous internal mammary artery harvest, the injectate becomes restricted to the level of injection. Okay, so if you have a patient who is coming for re-op, the deep parasternal block would not be the correct block to use. So for all these reasons, many of us have opted to favor the superficial parasternal block over the deep parasternal block. Now, these parasternal blocks have been applied and studied widely in patients undergoing cardiac surgery. This is an early study by Fujii and colleagues in which patients undergoing cardiac surgery were randomized to receive either the TTP block, that is the deep parasternal block, or no block. And these are bilaterally, they're performed bilaterally, of course. And they found that patients who received the deep parasternal blocks had lower pain scores in the first 12 hours post-extubation. This is a very recent study by Demarquette and colleagues. It's from 2025. And they randomized patients going for cardiac surgery via midline sternotomy to receive either a superficial parasternal block, a deep parasternal block, or no block in a 1:1:1 ratio. And there were 254 participants. So it was very well powered. Now, unfortunately, they found no difference in this case in terms of postoperative pain and opioid consumption, right? So this is the latest study. There are a lot of issues that we have yet to work out. We have to work out, for example, issues of technique, volume, concentration, so forth and so on. But so far, this is the latest information that we have. So going to the erector spinae plane block, or ESP block. This is a block that has garnered a great deal of enthusiasm in recent years, as well as a certain amount of controversy, as I'll come to. This block is performed by injecting local anesthetic between the transverse process and the overlying erector spinae muscles, usually in the thoracic region. This results in a craniocaudal spread of local anesthetic that, at least in the first case reports by Ferrero and colleagues, resulted in a very surprisingly wide sensory distribution of the block, encompassing almost the entirety of the hemithorax. Now, first thing that I'd like to point out is that these were rather unusual patients, right? These were chronic pain patients with neuropathic pain in the thoracic area. And they discovered this block surreptitiously because the trigger point for the pain was exactly in the ESP plane. So they injected local anesthetic at the trigger point for the pain, and they found that these patients had numbness throughout the hemithorax, right? So first and foremost, they were unusual patients. They were not your regular run-of-the-mill patients. Second of all, I'd like to point out that even in this first case report, the sensory distribution ends at the midclavicular line anteriorly, right? So there is sternal sparing exactly in that distribution of the anterior cutaneous branches of the intercostal nerves. So we have to keep this in the back of our minds when examining its role in sternotomy procedures, albeit, as Dr. Bott mentioned, postoperative pain from cardiac procedures is multifactorial, right? But there is, even in these case reports, sternal sparing. So early on, the mechanism of action that was suggested for this block was that the local anesthetic not only distributes in a craniocaudal direction, but also anteriorly towards the paravertebral space. And according to this theory, it gains access to the paravertebral space through microscopic fenestrations in the posterior costotransverse ligament. The posterior costotransverse ligament forms the posterior border of the paravertebral space. Hence, they named this theory paravertebral by proxy, right? They're not entering the paravertebral space with the needle, but they're stating that the local anesthetic is gaining entry into the paravertebral space. So this is an early study by Krishna and colleagues of patients going for coronary artery bypass grafting via midline sternotomy, and they randomized patients to receive either bilateral one-shot ESP blocks or no blocks. And they found that the patients who received the blocks had a shorter time to extubation, lower opioid usage, and less length of time in the ICU. Now, you can also insert catheters for continuous anesthetic infusion for any fascial plane block, including the ESP block. And this is what Philippe Macquart's group studied. They inserted bilateral ESP catheters in patients going for cardiac surgery and compared them to historical controls who did not receive any regional anesthetic, and they found that those who received the ESP catheters had a lower morphine consumption in the first 24 hours. So after these studies and many, many others, there was a wave of enthusiasm for the ESP block. Some practitioners wrote editorials that called it a golden bullet for postoperative pain for thoracic procedures. However, things became complicated because subsequent cadaveric studies did not back up this paravertebral by proxy theory. And this was a very important study by Ivanusic and colleagues, in which dye was injected in the ESP plane in 10 cadavers. And they did not find even a single case in which the dye gained entry into the paravertebral space. Rather, the dye spread laterally towards the lateral cutaneous branches of the intercostal nerves. That would certainly explain the sternal sparing that we observed in the initial case reports by Ferrero and colleagues. However, the situation became even more complicated with the publication of this volunteer study by Zhang and colleagues, in which they found in healthy volunteers, when they performed the ESP block, there was a sensory distribution that was limited only to the posterior thorax, right? So after these studies, certain rather famous regional anesthesiologists who had their doubts about fascial plane blocks and the ESP block in particular voiced their concerns. In this editorial, they went so far as to state that the ESP block is not working by a conduction nerve block at all, but by acting as a reservoir for the local anesthetic, which then was being absorbed systemically and having a central effect of the local anesthetic, right? And some subsequent studies have sort of perhaps corroborated this claim. This is a very recent study by Hoogma and colleagues. This is a team out of Leuven, Belgium. And they inserted ESP catheters unilaterally in patients undergoing minimally invasive cardiac surgery, and they randomized patients to receive either local anesthetics through the catheter or saline. So the methodology in this case was very robust in that they had a placebo group. And they found, unfortunately, that there was no difference between the two groups in terms of postoperative pain and opioid consumption. And finally, our group at Mount Sinai Morningside has just concluded a rather large study involving patients undergoing sternotomy procedures. And we randomized the participants to receiving either bilateral one-shot ESP blocks, bilateral superficial parasternal blocks, or no blocks. And we had 271 participants. So again, it was very well powered. Unfortunately, again, our study, like the Hoogma study, was largely negative, with one exception. On postoperative day 3 for patients who received the ESP block, we saw a very profound decrease in pain scores and opioid consumption. And you might wonder, well, day 3, at that point, the block should have receded, right? We were injecting bupivacaine. At most, it'll last 17 to 24 hours. So the first question is, was this effect real, and can it be reproduced? And this is not the first time where we see a delayed sort of analgesic effect of a fascial plane block, right? There have been other studies that have shown this. And second of all, if it is real and if it is reproducible, what was the mechanism? And we postulate that perhaps there is an as yet unrecognized role for suppression of the inflammatory process with a fascial plane block. It's purely conjecture, but the inflammatory process would peak at 72 hours postoperatively. So that is a possible explanation. But it has to be explored and studied. So, finally, where do we stand with with this issue, right? We have a lot of contradictory information, a lot of contradictory opinions, a lot of extreme opinions. Some people think it's a golden bullet, some people think it's useless. So where is the truth? So first and foremost, the fascial plane blocks do not function like our traditional conduction nerve blocks, like a brachial plexus block, in that dense blockade is rarely seen with a fascial plane block. As such, the ESP block does not behave like a paravertebral block, right? With a paravertebral block, we can establish surgical anesthesia with the block alone. Nobody suggests that this is possible with a fascial plane block. Fascial plane blocks have a role in multimodal analgesic regimens. Second of all, unlike those other conduction nerve blocks, with the fascial plane blocks, we are not directly visualizing the nerves themselves. We're injecting local anesthetic in a space where the nerves are traveling. So a certain variability in the results is inherent and a certain failure rate. This has to be investigated, right? So we have to see what is the failure rate of these blocks? Why does the failure happen? Are there technical reasons? Should we increase volume? Should we vary our needle placement? All of these matters still have to be studied. And finally, we find in many studies that there is a disconnect between the dermatomal distribution of these blocks and the actual observed analgesia, right? And the question, again, is why? Why would this be the case? Perhaps there is an as yet uninvestigated role of the fascial planes themselves, which were actually very richly innervated in the pathogenesis of postoperative pain. So despite the fact that I put some negative studies up here, there is a lot of work to do. I think that we should keep an open mind, not go for the extremes of the opinions, and continue investigating this and sharing our experiences. Thank you.